त्यांचं चालू झालंय का? Hello, mic check. Hello, 1 2 3 4. Hello, mic check. Hello, mic check. Hello, 1 2 3 4. Hello, mic check. Hello, mic check. Hello, 1 2 3 4. Hello, mic check. Hello, mic check. Hello, 1 2 3. Hello, mic check. 1 2 3. Hello. 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 Mic check. Hello.
अच्छा हुआ ना। आप नहीं सारा काम किया। Ramandeep got an invite to do write commentary. Then he wrote me in, and then he wrote you in. Either you can sit there.
Oh, that's okay.
Good morning, everyone. I think we have a very long day ahead of us, packed with sessions on survivorship. And the good point about this is I think we've got very wonderful speakers with us today. And in order, we have Professor Greg Armstrong, we have Professor Darren Hargrave, Dr. Smita Bhatia, Dr. Gauri Kapoor, and Dr. Lashkar speaking for us today. And I mean, I don't think this really needs much of an introduction, but I think all of what we do is to ensure that our children get cured. And after they get cured, they have, long and productive lives. So the first session we have is just giving a background to survivorship. The second session in the afternoon will be talking about, how we can actually prevent late effects and what are the guidelines we use to monitor survivors of childhood cancer. And there's a third session, a shorter session in the evening, which is about the implementation of guidelines and the practical aspects of doing survivorship care in India. So to start off the first session, I invite Prakriti. Dr. Prakriti Kaushik is a consultant pediatric oncologist with an interest in late effects at the Kidwai Memorial Institute of Oncology in Bangalore. And Dr. Purna Kurkure, who is on the way, but I think I would be doing her, injustice by actually introducing her. And I think everyone knows that she's one of the people instrumental in starting survivorship care in India. So she will be arriving shortly, but for now, we'll start our session.
Good morning to all. It feels really great to be seeing such a gathering here, and we will start off with our first talk, which is an introduction to later effects on childhood cancer by our speaker, Dr. Greg Armstrong. I just invite our speaker onto the stage.
Very well, good morning. I want to begin by just thanking you, Maya, Prasad, and everyone else and the organizing committee. Thank you for the opportunity to be here. It's really just such an honor to be here in your country. Your city is beautiful. We spent the day yesterday going all around Mumbai, and I'm just so impressed here. So I hope today we get to talk a common language, the language of cancer survivorship. And I have the honor of kicking off this meeting. I'll start with some very elementary things that many of us know, and then move into some of the more recent research efforts that have defined some more recent things. So here we go. Childhood cancer survivorship, an introduction. So in North America, as many of you know, more than 85% of children will survive their primary cancer. And that means that now in the United States, there's 500,000 children who've beaten their cancer and are alive. And now they're aging across the lifespan. They're growing in number, but they're growing in age. And what's really interesting about this is if you go back 50 years, this wasn't happening. So we've created a new population of people that didn't exist on planet Earth until now. And now they do. And we've had the opportunity over the last 40 or 50 years to follow them and study them and learn from them. And I hope some of what we've learned in North America will translate, but we can't just think about North America, of course. We've got to think beyond that and think about global cancer survivorship across the world, right? So you see in green, those countries across the world who have a survivor, 5-year survival of 75% or more. But in the yellow, those that are in that 50 to 75% range, and with increasing color, dark, the color red, lower survival. But it's now time, as global survivorship is improving, to think about global survival is improving, to think about global cancer survivorship. So late effects after childhood cancer encompass a spectrum of physical and psychosocial morbidities. And I know of no better introductory slide than the one that Melissa Hudson has used now for well more than 15 years, that in one figure captures so many of the morbidities of cancer survivorship. Not only does it include organ dysfunction such as cardiac, endocrine, and risk for GU and musculoskeletal dysfunction, but risks for fertility and reproduction abnormalities, risks to growth and development, risk, of course, for subsequent malignant neoplasms that have a really terrible effect on these survivors and the potential for mortality, and then the psychosocial aspects. And so these are related to specific cancer treatments. It's really one of the mantras in our field that it's cancer treatment that drives the late effects. But we've learned more recently it's not just the cancer treatment. There are other things that are key drivers for late effects beyond the therapy. And this last bullet point, it says it's reported by most long-term survivors. Actually, if you look close enough, it's reported by all long-term survivors. Every survivor has some late effect of some sort. So survivors may have a high risk for multimorbidity, a high burden for chronic health conditions, excess hospitalizations and healthcare utilization for sure, work limitations and challenges. So these things stream into their normal everyday lives and impair or limit their normal everyday activities. Financial hardship due to the burden, the medical burden, and then ultimately impact on their quality of life. And now, Melissa uses this slide as sort of the classic learning slide. What we learned in the 1980s and 1990s and the early 2000s as our first wave of survivors was aging. So if you take a child treated for Hodgkin's lymphoma here with a mantle field radiation port that you can see, we know that with time, that's early on, that's a person who's at risk for musculoskeletal abnormalities, but with time, that radiation had a cardiac impact, increasing risk for cardiac disease, specifically atherosclerotic disease, and as well as risk for breast cancer. And so that is one of the common stories that we all know well. But we also know that since that first era of survivor, we've used risk stratification of frontline cancer therapy based on both cancer biology, presentation, and response to reduce exposure of cytotoxic treatments. So obviously we've intensified therapies for children that were hard to treat, but in the last several decades, we've de-intensified therapies for children whom we can cure with a lower toxicity. And so that's had an impact, and I'll show you some of that impact. And then risk-based health surveillance becomes key. If these are some of the major morbid outcomes, even within the first 20 or 30 years after cancer survivorship, then risk-based health surveillance and screening is very important. And you're fortunate to have in the room Smita Bhatia, who more than 20 years ago with Melissa Hudson, Wendy Landier, and Sandy Constein initiated the Children's Oncology guidelines for childhood and adolescent cancer follow-up. And so she's really, we really owe her. Those things exist because of her. And we think about screening exist because of the work that they've done now for 20 years. So I want to move to a few principles of survivorship research. I'm going to give you 4 principles as we start this conference. And the first came to me as I looked at this figure. This is a figure that my mentor, Les Robison, put into a grant 20 years ago. And he put this into the grant to expand the childhood cancer survivor study. And this is a pretty potent figure. He compared 5-year survival for children diagnosed 1974 through 85 versus those diagnosed 1986 through 1997. And he did it by primary cancer. And it's really clear to the eye that in just a short amount of time, about a decade and a half, there was an incredible improvement in 5-year survival across every cancer diagnosis. Well, this tells you one thing. If we're changing how we're treating and improving survival, we're also going to change the profile of those long-term survivors, right? Changing therapy. If therapy is driving late effects, then changes in therapy are going to mean changes in late effects. So we made a very strong argument 20 years ago to expand the childhood cancer survivor study to include children diagnosed 1970 all the way through 1999. It made me ask the question, though, what about now? What about the last 20 years since 2000? Have we seen these same improvements in survival, or have we not in North America? Have we plateaued? So we replotted this data. This is the same data replotted, and asked the question, what about 2000 and beyond? Okay, before I click next on the slide, what do you think? Do you think these survival curves plateaued or continue up? Well, here's what they do. They continue upward, right? So we've continued to see improvement in 5-year survival across all these cancer types in North America. And that leads to principle number 1 as we think about today, that given continued improvement in 5-year survival, evaluation of long-term effects of contemporary therapies is absolutely essential. So that's my lead into Darren Hargrave's next lecture. Stick around. It's going to be really important that we think about modern therapies and their risk for late effects. Principle number 2 is when we think about mortality. As oncologists, we really focus in on 5-year survival. It is really our number 1 outcome, is it not? But I want to challenge that. And Anna Lynn Williams, one of our fellows, one of our postdoctoral fellows, challenged this in a paper called Rethinking Success in Pediatric Oncology, Thinking Beyond 5-Year Survival. She took a very simple metric. She used SEER data and this very simple metric of excess deaths. It's deaths observed due to cancer minus those expected in the general population. So these are excess deaths due to cancer in the population. And why that is potent is because if you look at this, in 1985, there were almost 3,000 excess deaths in the United States due to cancer. That's a body count. You can count that in people, okay? But then by 2015, that number had dropped to about 2,000. So simply improving 5-year survival in the United States means that there's 1,000 less children dying each year due to cancer and excess deaths. That's great. But look what happens when you now start thinking beyond 5-year survivorship. When she added data on deaths between 5 and 10 years, and then beyond 10 years in a stacked plot, you can see here, this red are deaths beyond 10 years, and they're increasing in number. We've pushed these children out to be into their 20s and 30s, and many of them will die young in their 20s and 30s. And you see the number dying is larger. Part of that is just a product of the fact that there are more survivors, right? So there's more survivor deaths. But also it tells you they're still young. They're dying young. But here's the real point. Look at this, just about 3,200 excess deaths in 1985. And guess what? It's no different in 2015. You know that win? We had a win here, right? We lost it. Where did we lose it? We pushed them beyond 5 years, only to still die young. Okay, so that's principle number 2. Now let me show you before I tell you principle number 2. It's not true across all cancer types. For ALL, we've done a fantastic job. These long-term survivors are generally not dying young, not to the same degree, but certainly for Hodgkin's lymphoma, oh my goodness, they're at super high risk for early death. And so here's the one key question is, if we're seeing these early deaths, can that risk for early death in their 20s and 30s and 40s be modified? Hang on to that question. I'm going to come back and answer it. But here's the principle number 2. We've got a long way to go to achieve a normal lifespan in survivors. We are nowhere close in North America to achieving a normal lifespan for kids who beat their cancer. Principle number 3, underlying mortality is that burden of chronic health conditions. That really drives mortality, right? Now, we've shown in the past through the Childhood Cancer Survivor Study that we've improved mortality decade by decade. For children diagnosed in the 70s in the black line, or the 80s in the red line, or diagnosed in the 90s in the blue line, the cumulative incidence of the total chronic health condition burden has been less by decade. That's great. But it doesn't take an epidemiologist looking at this slide to tell that's actually not the most important point from the slide. The most important point from the slide is none of those groups are close to the health burden of their siblings. They are all have a tremendous health burden compared to the siblings. So principle number 3 is that we have a long way to go to achieve a normal health span. So a long way to go to achieve a normal lifespan, long way to go to achieve a normal health span. And then principle number 4, this is for the naysayer. This is for the person in the room who says, that's all true, Greg, but come on. In the modern era, for ALL, for example, we've gotten rid of cranial radiation. Certainly those kids who aren't getting cranial radiation are doing great, right? They're not going to get their high-grade gliomas or meningiomas as second neoplasms. They're not going to get their neuroendocrinopathy and thyroid hormone deficiency and growth hormone deficiency. They're going to be great. Well, maybe they're not. So look at this data. This is the cumulative burden per survivor for each of our total therapy studies in childhood ALL at St. Jude. And these are the total therapies that used cranial radiation, and these are the total therapy studies that did not use cranial radiation. So first of all, there's no decrease in the cumulative burden of late effects for these survivors, but there is a change in the profile. You no longer see this light blue, which are subsequent neoplasms. They're very small, right? So those meningiomas, those high-grade gliomas, we're not seeing them to the degree. But look at what's different. Look at this blue. This is musculoskeletal. This population, because we've increased steroids, are having avascular necrosis and bony deficits, bone mineral deficits. And, they are fractures, for example. But also the gray, which is endocrinopathies. So diabetes and obesity in this population has increased. So here's the real point. As we've changed therapies and modernized therapies, is that principle number 4 is even among populations where we have risk stratified and reduced therapy, normal health cannot be assumed. You can't just say, we got rid of the cranial radiation, we don't need to think about this anymore. The impact of therapeutic trade-offs needs to be assessed. So we made a therapeutic trade-off. That means there's going to be a late effect trade-off. And we've got to study that. We've got to know that. So with those principles in mind, I want to show you how we think about late effects research. And I've got to give Smita a lot of credit. She probably does not know the degree to which she impacted my career when she developed this model for late effects research with Les Robinson. But when I went up for my first promotion, I was trying to frame the work I had done for my promotion. I actually used this circle to really frame things. And since that time, it's really been central in my thinking. So a lot of credit to Smita. I hope now I have adapted it. I hope she doesn't throw tomatoes at me for adapting it in a way that she doesn't like, but here we go. So when we think about research in cancer survivors, it really starts with that epidemiologic research, observational research that we know well, risk and risk factors, so that we can really understand who are the high-risk populations. But from there, we want to take the deeper dive and think about genetic predisposition and physiologic mechanisms. And Smita's going to talk today and cover a lot of that. But in addition, it all has to translate forward. It all has to translate back to the patient. And we can do so by risk prediction models, again, a topic that Smita will talk about today, individualized risk prediction, developing calculators that can be used at the bedside, development of clinical care guidelines, development of interventions and strategies, and all of that, if done well and disseminated back to the cancer survivor, can have an impact, either through primary prevention, changing how we treat a patient, or secondary prevention, changing how we follow, screen, surveil, intervene on survivors. So with that in mind, I want to close down this introduction talk with a couple of examples of each of the type of research along this wheel diagram. So number one, let's talk about what can we still learn about observational research. And so we obviously think about large populations through our two large cohorts, the Childhood Cancer Survivor Study with 38,000 survivors eligible, 25,000 participating, and the St. Jude Lifetime Cohort with 10,000 survivors eligible, 6,000 participating. And 2 years ago in Lancet, Stephanie Dixon published this data on excess risk of death compared to the US population. Now think back to that 5-year excess deaths study that I showed you earlier. She used that metric and then looked at CCSS and showed a U-shaped curve looking at excess deaths on the y-axis and time. These are survival from diagnosis in 5-year increments. And this U-shaped curve tells us that early deaths are largely due to this gray, which is death due to recurrence. But with time, the death picture changes, the mortality picture changes, where what is driving this are the yellow subsequent malignant neoplasms or deaths due to subsequent neoplasms, cardiac death in blue, pulmonary deaths in green, and then other medical deaths in red. And the excess deaths per 10,000 person years, way down here on this end of the scale is 95. So 95 excess deaths per 10,000 person years. But when you go to the other end at age 40, you actually see that that all-cause mortality becomes 138 excess deaths per 10,000 person years. So it's higher. But most importantly, the health-related causes, these in the bracket, those that are medical deaths, largely due to late effects, has increased. It was only 21 per 10,000 at the 5 to 9 year mark. But by the 40-year mark, it's 131. So at the changing face of mortality. But you remember the question I posed was, can we change that? They've already had their treatment exposure. We can't take the treatment exposure away, but can we change that risk for mortality? And it ends up, maybe we can. So here's what Stephanie did. She looked at the things we can modify about a survivor's lifespan: smoking status, alcohol use, physical activity, obesity, and underweight, put them into a composite score. And you can see ultimately came up with 3 categories: a healthy lifestyle, a moderately healthy lifestyle, and an unhealthy lifestyle. And when she did this, she created 3 different figures that are somehow upside down. I don't know why, the titles, so forgive me for that. But it doesn't take an epidemiologist to look at these figures for health. These are reversed. This is the unhealthy lifestyle, and this is the healthy lifestyle group. Which one do you want to be in? If you're a survivor, you want to be in the healthy lifestyle group. They have a lower risk for excess death in this population. And so this tells us that healthy lifestyle is associated with fewer excess deaths. So there is something we can do potentially. Interventions targeting lifestyle should be evaluated to determine if they can reduce risk for mortality. So this has been a major push for us in the last decade to really push lifestyle interventions that may modify their overall risk for mortality. Now, second, just a couple of examples. Smita will go into much more detail, I believe, when it comes to genetic predisposition, physiologic mechanisms, and ultimately risk prediction models. But when it comes to, when we think about late mortality, we have really talked about second cancers and the risk of radiation and chemotherapy causing those second cancers. But we've always suspected that some of them may be due to the underlying genetic predisposition that they may have towards cancer. And we've never known how much of that risk really we can attribute to genetic predisposition, but that's changed now. Xiaoming Wang from our department identified that about 6% of our survivor population have an underlying genetic predisposition for cancer. When he looked at them, he then showed that if you have a genetic predisposition, your risk for mortality due to second cancer is threefold higher. And that's true whether you're in the CCSS or the St. Jude Lifetime cohort. So we have another little bit of understanding of how genetics drive risk for second cancers and death from second cancers in this population. And then coming from another angle, genetic predisposition for severe obesity. We know what causes severe obesity in our population, particularly cranial radiation in our brain tumor survivors, right? But above and beyond that, Yadov-Sepkoto looked at genetic risk scores used in the general adult population and took those polygenic risk scores, applied them to our survivors, and found that, in fact, the polygenic risk score or genetic risk score of common variants was associated with a 53-fold increased odds for morbid obesity. So it's not just the cranial radiation. If they have a genetic predisposition for obesity, we have to consider that as well. And when it comes to risk prediction, this improved the risk prediction by improving the AUC quite significantly here, as you can see. And then lastly, in closing, interventions, right? The only hope here for us to modify this pathway is to think about intervention trials. So I'm just going to show you two examples. This is the Health Shares R01 study by Yutaka Yasui and by Ai-Chan Wang, with the overarching goal to utilize daily monitoring of symptoms and momentary activity to improve survivor care. So let's say you see your survivor once a year. What about those other 364 days of the year? Well, perhaps through health tracking and mobile health, we can monitor them more closely. And that's the goal here, is to use a mobile health platform to collect and integrate symptoms, activity, health behavior data, and develop and validate risk prediction models for quality of life, chronic health conditions, and ER visits and hospitalizations. In a sense, if this is successful, this could be an mHealth-based early warning system for survivors. And then finally, just another example of an intervention. Our survivors of childhood cancer, many of them are at higher risk for insomnia. And so this is the Sleep Well study, just wrapping up a study in the United States to look at cognitive behavioral therapy to improve symptoms of insomnia by using an app, the Shut-Eye app, that has been used in the general population. And our hope is that if we can improve insomnia, then we can also improve neurocognitive function in this population. And that's the goal. Now, this is a remote assessment that's done completely remotely. We never see these survivors in clinic. We do it all remotely. And this is led by Kevin Kroll and Tara Brinkman. So just a couple of examples of intervention. And with that, I want to thank you. Any of the science that you've seen today is team science. Look at the contributors it takes to some of this work. And Smita's name is on here among others. But it really, really takes an entire team to really dive into late effects. So with that, I hope that's a good introduction and look forward to a really great day with you. Thank you.
Thank you very much for that lucid talk. Now, we will take the question answers at the end of the session. I request our second speaker to speak about the long-term toxicity of newer treatments, Dr. Darren Hargrove.
Thank you, and thank you again to the organisers to invite me to this excellent meeting. I have to say, you know when you've been to a good meeting when actually it really makes you think again and thinks about, stimulates new ideas, and that certainly happened yesterday. I'm sure it will do today. So for my second talk, I'm talking about the long-term toxicity of newer treatments, and I've added the question mark because, of course, one of the hopes that we have with novel therapies is that we might actually reduce the burden of late effects. But I think from some of the things I'm going to discuss, we just need to caution that, and we need to get more and more data. As yesterday, I work a lot with biotech and pharma, so these are my disclosures, but I'll be presenting my own thoughts today. So novel therapies and adverse events. In some way, there's a little bit of contraindication when you talk about long-term because we've just not had that follow-up. We've actually just heard about the fact that we've been learning from the effects from the 80s, the 90s, etc., and that's ongoing. And of course, we actually have relatively short-term follow-up for most of the treatments I'm going to talk about. But I think there are some clues in terms of and lessons learned from these. So we have to be honest that the vast majority of novel therapies we get are repurposed from adult cancer. There will have been longer term exposure in adults, and therefore, can we actually learn what may actually be a problem in children from that? Well, yes and no. We know from conventional treatments such as cytotoxic chemotherapy and radiotherapy that the role of organ maturation and development are absolutely critical in what may be expected. So we also always need to caution lessons learned from the adult population. We also know that these novel therapies tend to have a very different spectrum of adverse events for targeted immunotherapies compared to established treatments, which means that we need to be very open to considering what are these long-term consequences? Are our monitoring and surveillance programs fit to actually detect those? And of course, as I've already stated, by definition, we simply do not have the same long-term follow-up on novel therapies in children and young people. And therefore, there are a huge amount of unknowns, and we really need to adapt our programs to follow these further. So I've kind of divided this into a few physiological areas, and I think groin and bone development have been very interesting in terms of some of these novel therapies. We know that they're physiologically important, they're hijacked by cancer cells, and therefore it shouldn't really be unexpected that we may get some inadvertent consequences. So I'm a neuro-oncologist, so you'll probably see that a lot of this is focused on things we've learned in brain tumors. But as we discussed yesterday in the precision medicine talk, we've learned a huge amount over the past few years about the underlying genetic causes of our tumors, including genetic predisposition. And in medulloblastoma, of course, we now know that this is not one disease, but actually multiple diseases. This, at its most simplistic, is 4 types, but we know there are probably more. But when this actually occurred, of course, there was a lot of excitement because we thought we could target these. And of course, the Sonnet hedgehog activated medulloblastoma, was a particularly interesting target, representing about 25%. We know the hedgehog pathway is critical in development. It is not just Sonnet hedgehog, there's Indian hedgehog and desert hedgehog, and these actually play major roles in early development. And I think one of the things that is a learning point is that even from our preclinical modeling, we need to be aware of the potential adverse effects and potential late effects that could occur. So although there was some fantastic preclinical data suggesting that smoothing inhibitors really could target transgenic models of Sonnet hedgehog medulloblastoma, there was actually also data from Tom Curran in St. Jude suggesting that there could be an impact. Now, that wasn't seen if you used adult mice or rodents, but it was seen when you used juvenile models. So first learning point is that we have to study in preclinical assessment the thing that represents as best as we can children developing. And what they showed was an early closure due to an impact on chondrocytes of the growth plate. So at least when we actually entered into our trials, we were aware that this could be a consequence, and we put in place the monitoring. And I'll show you 2 examples and 2 lessons learned from this. So when we actually started to inhibit the hedgehog pathway with smoothing inhibitors, we were aware of this, but of course we were interested in trying to cure more patients. These were relapsed patients that already got multiple morbidities from the standard treatment of surgery, radiotherapy, and chemotherapy. But when we ran these studies, we started to see issues. Now, when the phase 1 studies were done, of course, these were done in relapsed patients who, by definition, were older. They were skeletally mature, and therefore we hadn't seen such problems. But when it moved into phase 2 with the smoothing inhibitors, lo and behold, we started to see problems. And this is from a St. Jude's study where actually early growth plate fusion was seen, thankfully detected, but it was in those patients that were obviously skeletally unmature and had had long-term exposure. Unfortunately, this occurred in all epiphyses, so it wasn't just short stature, but it was a disproportionate growth, abnormal growth, and really would have a major impact for these patients. So much so the decision was made to actually halt the trial and only do this in skeletally mature patients. Unfortunately, this was a class effect, and I was involved with this early phase study, which moved into phase 2 with a different smoothing inhibitor, and we saw exactly the same. We saw very good effects. We actually had very long-standing patients, 2 years out, whose sonic heteroactivated medulloblastoma responded. But unfortunately, yet again, those skeletally and immature patients had growth plate. And this has really held this back. So we have to be aware that even at the very early preclinical and early phase stage, we could predict potentially irreversible side effects for our populations. Unfortunately, this is not just related to the hedgehog pathway. FGFR is an important regulator, FGFR3 of bone growth, and actually is a negative regulator. And without that, you actually get overstimulation and increased growth. And that's seen in genetic conditions. But of course, FGFR is mutated in low-grade gliomas and high-grade gliomas and other pediatric cancers. And therefore, the use of FGFR inhibitors have started to be observed with some, again, good clinical impact, although not in everybody. But unfortunately, in this case, what has been observed is that patients may well have hyperstimulation of growth, which then leads to slipped capital femoral epiphyses, which then need to be corrected. And these, of course, this damage could link to long-term problems with osteonecrosis, the arthritis, etc. And therefore, yet again, we've actually found that one of these targeted agents could lead to long-term consequences. Yesterday, I talked to you about low-grade glioma and the MAP kinase pathway, and we talked about the Firefly-1 trial and type 2 RAF inhibitor. And of course, that was very positive, leading to early registration in the FDA, which may be expanded in Europe soon. So I showed you the results, the excellent waterfall plots. But one of the things that we did monitor was growth. And we reported this last year at ISPNO that we had seen a decrease in growth velocity when patients were treated with tovorafenib. Now, of course, many of these patients were actually heavily pretreated. Some of them may have had radiotherapy. Many of them had pituitary, hypothalamic dysfunction, etc. They'd had steroids. But when we actually looked, this does seem to be a significant issue that actually, although in less than 50% of patients, we were actually seeing in patients that had not closed their epiphyses that there was a significant decrease in growth velocity. That can actually be very represented, and I've treated several of these patients, and I have to say this is exactly what their growth curves look like. But you can see the significant plateauing of growth after they've started, and interestingly, when you stop, the growth picks up here. So it does appear that this may be reversible, but as we discussed yesterday, one of the problems with these targeted agents is how long do you need to treat patients for? Is this a 2-year period? Is it actually lifelong? We simply don't know. Now, again, in this study, these were multiply relapsed patients. They were often skeletally mature. They already had a burden of growth effects from other treatments. So, this could be of less concern. But this agent has now moved forward to first-line treatment, which means that naive patients are now receiving this, and very young children under 1 year. So these are things that we really need to actually consider because they potentially could be an issue for long-term toxicity. Again, illustrated that at the moment, we've got some reassurance that patients recover when they stop, but the problem is that when patients stop, some of them rebound and may go back on one of these inhibitors. Interestingly, we don't actually see this with the first-generation inhibitors that I described yesterday. So we don't see it with first-generation RAF inhibitors or with MEK inhibitors. And we think the reason is that it's CRAF, yet again, in the cartilaginous growth plate, which is important. And one of the advantages of type 2 RAF inhibitors is they block many of these other dimers, but it is blocking CRAF, and it's probably this that's actually leading to this temporary growth arrest. So again, moving on, we talked yesterday in the precision medicine molecular tumor about those targets which actually really have been impactful with regards to targeted therapies such as NTRAP, ROS1, and ALK. And this was a study led by the American group looking at entrectinib, which targets all of these. Again, fantastic waterfall plots. So on the surface, a real success. But what they also noted was that patients in 48% had significant weight gain. And interestingly, there was an increased risk in fractures. Now, one had to tease apart whether this was due to previous treatment, to use of steroids, but actually it does appear to be a real phenomena that was actually related, and this will need to be studied. As these drugs are used, particularly outside of clinical trials, we need some way of monitoring these adverse events and seeing if we can prevent them. So weight and hormonal changes, again, for brain tumors, these are something we're trying to avoid with novel therapies. And it may well be that when we actually compare them, we can do this. But of course, many of our patients receive these targeted agents after they've already received those treatments. And what we're actually finding is that these agents can actually contribute. So this is an institutional study that was looking at weight gain, but I can tell you we've got exactly the same data at Great Ormond Street. And what we see is in the proportion of patients, they do actually have significant weight gain. Although interestingly, there's a debate as to what that is, and it may actually be that it's actually increasing muscle bulk, which one may regard as a positive thing. Again, it seems directly related as when you stop these inhibitors, that weight gain is actually lost. This is a report from our own institution at Great Ormond Street of our experience, and this was 55 patients who'd been treated with BRAF or MEK kinase inhibitors, MEK inhibitors. And what was described was that there seemed to be, on starting these treatments, an increase in hyponatremia. And for those patients who had diabetes insipidus, this was actually worse. It seemed to be that there was alterations in the dosage of their desmopressin needed. But even for patients who had not yet had to start treatment, it triggered treatment. And there was also some changes seen in hypoglycemic control. So what about fertility and pregnancy risk? Well, here we're having to learn from the adults. And I think that what we know is that certain tyrosine kinase inhibitors may have an impact, although really there is insufficient evidence. And this is going to be certainly something we have to follow up. And of course, again, teasing it out from the other therapies that they may receive may be difficult. But we know that they do have an impact on the ovaries and on gonadal tissue in males. And therefore, there can be issues. And we will have to consider about whether cryopreservation is needed or not in these patients. However, we also know that patients can get pregnant, but we also know the risk of taking TKIs in first trimester, where there is an increase in congenital malformations and elective terminations because of concerns, as well as spontaneous abortions. So that needs to be considered. And of course, it may well be that you need a treatment break from your TKI to consider how safe and whether you want to have a family if these are chronic administered treatments. Skin and hair side effects, I talked yesterday that this is the different problems that we have with some of these inhibitors. And here we see, although more severe cases, but some of the repertoire of skin side effects, paronychia, acneiform rash, etc. Now, it's hoped that these are temporary, but I think we're increasingly seeing that there are actually perhaps some more chronic changes that we're seeing with our dermatologists. And there also is a risk potentially of second malignancy. We know from the adult melanoma world that actually targeting with first generation BRAF inhibitors increases the risk of squamous cell and keratoacanthoma. And I can tell you that those agents are very nevogenic. The patients actually develop nevi on a regular basis. And I think the reason they're not developing to malignant transformation is that they've not have UV damaged skin. But if patients are staying these a long time, it may be that we start to see those second malignancies occurring. What about long-term effects from immunotherapy? Well, yesterday we had an excellent session. We heard that things like immune checkpoint inhibitors have not really had the same impact in pediatric cancer as they have in adult cancer, but in some situations such as CMMRD, they have. We know that there's a whole different spectrum of these endocrinopathies, and some of them can be chronic, some of them can occur after you've stopped treatment, and some of them are irreversible, although they may be able to be managed by hormone replacement therapy, but you may still have issues with regards to inflammatory arthropathy and peripheral neuropathy. So we do need to be considering those. I think I've got a duplicate slide here, but what I was also mentioning here is that CAR T cells and anti-GD2 immunotherapy that was discussed yesterday, again, in the longer term, we do need to consider whether these may contribute to additional side effects. So in summary, I think that the hope is that novel therapies, which are more biologically targeted, could reduce the overall burden of treatment for children with cancer. And whilst this may be true, early experience is telling us that actually they do target critical developmental pathways. And of course, children will be more vulnerable than adults. So we can't always learn the lessons from them. Many novel therapies are used in the relapse setting and alongside conventional treatment. So it can be quite difficult to tease out what's causing what. But equally, as we move them forward to the novel setting, it's going to be younger children. They're going to be on these treatments for longer. So we need to consider that. So we're going to hear, and I've already heard about the established survivorship programs. And I would argue that you need more money again to actually adapt to actually collect these, because I'm pretty sure that unfortunately this is not going to be done by the pharmaceutical industry. This is going to fall upon ourselves as clinical academics with those already established programs to see what the major effects of these could be over the longer term. So with that, again, I'd like to thank some of the funders that have sponsored the research for our novel therapies. Most of all, the patients, their families for contributing and also for agreeing to go into long-term follow-up programs, which we've established, and to you for your attention. Thank you.
Thank you, Dr. Darren. Now we go on to the next presentation by Greg again on the care of aging survivors of childhood cancer. It's a lifelong journey, and we will hear from him how they have developed the program for long-term follow-up of this aging population.
All right. Let me just give you fair warning before I give this talk. I'm a pediatrician, not a geriatrician. So what do I know about aging? Well, we're learning, right? For the first time, I can't think of many fields where pediatricians and geriatricians reach across the aisle and join hands. But we are now, both in our observational research and even in some of our intervention trials. So let me talk to you a little bit about the premature aging of the cancer survivor. And I'm going to start with a paper that Rowan Hamoud, my postdoc, published last year in Lancet Oncology, titled The Association of Cumulative Cardiovascular Burden with Major Adverse Cardiovascular Events, or MACE, in survivors of childhood cancer. And when Rowan started as a postdoc, I told her, I think there is a snowball effect in our survivors, and we need to show it, and we need to prove it. Now, I know you don't get a lot of snow in Mumbai, right? So let me explain the snowball effect. It simply means if you take a snowball and you start at the top of a hill and you roll that snowball down the hill, guess what? It picks up snow and it gets bigger. And by the time it gets to the bottom hill, it's a pretty big snowball. In fact, it's a pretty big problem. And what it means is just a euphemism for the idea that small problems can become big problems. And we wanted to use the St. Jude Lifetime cohort to really establish what are the small problems that ultimately become the big problems. Because if we can identify the small problems, maybe we can target them. So the big problem, or the big snowball at the bottom of the hill that we wanted to avoid when this study, was MACE, major adverse cardiovascular events, defined as having a stroke, grade 2 or higher, a cardiomyopathy, grade 3 or higher, a myocardial infarction, grade 3 or higher, or any other cardiac death. Okay, so that's what we want to avoid. That's the big snowball at the bottom of the hill. That's the outcome. But the exposures, or the components that could build into the snowball, the question we had was, what about all the other cardiovascular events that are non-MACE, but not minor, that actually can accumulate? So within the St. Jude Lifetime cohort, there are 22 clinically assessed non-MACE chronic cardiovascular diseases. So this is the first cohort. And I don't know where the text went in all of these categories, but I can tell you that these 22 non-MACE events include arrhythmias. These are measured by EKG, cardiomyopathy, and other things measured by echocardiography, heart valve disorders, grade 1 cardiovascular events and other vascular events, hypertriglyceridemia, hypercholesterolemia, and this is hypertension. If the text was there, I don't know where it went. So we took all of these things and said, well, what are the chances? If you get one of these, what's your chance of getting MACE? If you get two of these, what's your chance of getting MACE? And so here was the model that we built. This is the multivariable model, intermediate cardiovascular events and risk of MACE. Now, in the model, of course, because they're cancer survivors, we include the treatments you would expect could lead to a bad cardiac outcome. Anthracyclines, chest radiation with a nearly 3-fold increased risk for MACE, of course, as you would imagine. Neck radiation and cranial radiation, because of that stroke risk, increases risk for MACE. But the question was, what if we, on top of those things, add one non-MACE cardiovascular event? When you do that, it ends up, you increase their risk for MACE fourfold. That's more than the anthracyclines or the chest radiation. That's interesting. Do you now think that those little things matter? They matter, don't they? Now, what if you get two non-MACE events? Sixfold risk for MACE. What if you have a third non-MACE event? A sevenfold increased risk for MACE. And if you have four of these cumulative cardiac things that happen along the way, you've got an 11-fold risk for increasing MACE. So there's the snowball effect, right? One thing leads to another, and ultimately you're down at the bottom of the hill with a major cardiovascular event. One of the questions we wanted to ask of this data set, though, is what do we do with those asymptomatic findings? So you send that kid for the echocardiogram, the EF is 45%, a little below abnormal, but what do we do with it? Maybe we just see him back in a year. Well, with this data set, we could ask that question. And so here's the answer. With cardiomyopathy, and again, I'm sorry, we're missing some of the background to this figure on the slide. I don't know where it went, but when it comes to cardiomyopathy, if you detect a grade 2 cardiomyopathy by echo, that's an ejection fraction less than 50%, between 40 and 50, but they're asymptomatic, they look great, they don't have heart failure, you're seeing them in the clinic and they look just fine. What do you do? Well, this tells you that there's double the risk of MACE in the next 5 years. So knowing that if that asymptomatic echo tells you there's a doubling risk for MACE, we might act on that, right? That might actually change how we think, at least shorten their follow-up, if not get them to a cardiologist and have them evaluated, right? And the same is true for a number of other things, although none of the data, there we go, arrhythmias. So grade 1 and grade 2 arrhythmias, and I'm sorry that this is jumbled, those increase risk for MACE. So a grade 2 arrhythmia, which is symptomatic but non-urgent, a threefold increase for MACE in the next 5 years for your survivor who develops that. And the same is true for hypertension and for heart valve disorder. So that echo with a grade 2 asymptomatic, moderate regurgitation, asymptomatic, yet it gives you a threefold increased risk for MACE in the next 5 years. So these asymptomatic things matter. All of these things begin to add up on our survivors. So with aging, you can see the snowball effect. Now, we also asked a question, what about biomarkers? These cardiovascular biomarkers might help us to determine in this population. If you had an NT-proBNP or echo and imaging biomarkers like a global longitudinal strain, if we had those routine assessments, would they improve our prediction for future risk for cardiomyopathy? And Matt Earhart looked at this and published this in JCO just a couple of years ago. And I think it's an important study. It needs to be reproduced somewhere, but he showed that if you had an abnormal global longitudinal strain, but a normal NT-proBNP, no increase in risk for cardiomyopathy in the next 5 years. But flip that around, an abnormal NT-proBNP with a normal global longitudinal strain, and you double your risk for cardiomyopathy in the next 5 years. But if you have both of those biomarkers abnormal in the same patient, so imagine they're sitting in the room with you, they look completely normal, they're asymptomatic, but their NT-proBNP is high and their global longitudinal strain is abnormal, that is actually important, right? They're fourfold increased risk for cardiomyopathy. I do think we want to have these findings reproduced, but this is where we begin to move towards precision survivorship, early identification of high-risk populations for early intervention. All right, so aging, we talked about the snowball effect. I think another thing we need to think about is physiologic frailty, and as it's a concept that has been well established in geriatrics. And about a decade ago, Kiri Ness, one of my faculty members at St. Jude, really looked at our survivor population and wanted to evaluate their loss of physiological capacity that interferes with normal function. We all have this as we age, but are we seeing it in survivors earlier? It's described in older adults. It can be distinguished from disability and comorbidity, and it identifies individuals that are highly vulnerable to adverse health outcomes. So a frail population is highly vulnerable to a major event, right? And it often precedes chronic disease onset and is a predictor of mortality. So this idea of physiologic frailty is actually a really important concept. And here we go with this figure that hypothetically shows that with time, we all become more frail. But in our cancer survivors, maybe that chemotherapy and surgery and radiation and cancer process becomes an early hit that sets our survivor on a different aging trajectory altogether. If so, then having tailored interventions becomes an opportunity to improve that trajectory of physiologic frailty. Now, what are the 5 components? How do we measure frailty? Well, it's 5 component composite measure: muscle wasting, muscle weakness, self-reported exhaustion, slow walking speed, and low energy expenditure. And you are deemed frail if you have 3 of these 5 factors as abnormal, and pre-frail if you have 2 of these components that are abnormal. So let me show you the data. And just for the sake of time, I'm going to move fairly quickly through a couple of slides. Here was Curie's original finding in the St. Jude Lifetime cohort when we looked at frailty. So red are our St. Jude Lifetime cohort survivors aged 18 to 50 years, but a mean age of 33 years. 7.9% of them were frail. They met 3 of the 5 criteria. That compares to this blue group, which is from the cardiovascular health study. These people were aged 65. The youngest was 65 through 101 years of age. 7% of that population were frail. You get that? See the difference in age, but how the frailty measures are comparable? Clearly, our younger survivors have a higher prevalence of frailty. And that when you compare that to our controls, our population of patients that serve as our community controls, they've not had childhood cancer, 18 to 50 years of age, none of them were frail. So very clearly, our survivors have a burden of frailty. And then they had higher rates of pre-frailty as well. Now, what happens from that baseline standpoint as they age? Well, guess what? Frailty increases quite quickly. Again, these slides are not quite right, but here's the point. Yellow was the baseline assessment for frailty in our survivor population. With 5 years of follow-up, forget the data that's here. You can see that that's a doubling. 5%, roughly 5% were frail at baseline, 6%, that doubled in 5 years. So frailty is not just a one-time hit that happened at cancer. It wasn't just because they had a brain tumor and they have a number of limitations because of the brain tumor. It's a process that seems to be premature and progressive in this population. And when you ask what it is that's driving, again, I'm very sorry, I don't know what happened in the conversion here, the slides. But what it's driven by largely in our population across these 5 components is low energy expenditure and low lean muscle mass. All right, let's go to another way to assess this accelerated aging. We took a geriatric scale. Curie did this as well, the cumulative incidence rating scale for geriatrics. It's used in geriatrics all the time. But how do our survivors measure in the scale? It's an organ-based system. It looks at different organ systems, 14 of them, in fact, some scores. And the brilliance of this study is that Curie used the childhood cancer survivor study and 2 time points longitudinally, almost 20 years apart. So a lot of time to look for accelerated aging. And here's what she showed. We segregated this between females and males. And for females, you can see there's a baseline and follow-up time point, and the total score in the cumulative incidence rating scale changed from here to here for females. And so you get a slope. And that slope is very different than the sibling slope or the NHANES slope, which is a representative population in the United States. And so when you get 2 points in time and a slope for this process that's different, that's actually accelerated aging. That's a pretty good definition for accelerated aging. We see less acceleration in males. And whether you look at the total score or the number of grade 4s, it's really the same process. There's evidence for accelerated aging. So a steeper slope of change over time associated with what was driving it: kids who had cranial radiation, chest radiation, platinum dose, and female sex. These were the risk factors that really increased risk for this accelerated phenotype. And a 1-point increase in the total score increased risk for late mortality by 9%. So it does not pay to have a higher CIRSG score as a survivor. It predicts your mortality will be sooner. And so the punchline here is that with 2 decades of longitudinal follow-up, CCSS provides evidence for accelerated aging burden in our survivors. Now, one more measure just to close the deal on this accelerated aging. This is the Deficit Accumulation Index, or the DAI. It's another accumulation of multiple aging deficits. Rather than just looking at chronic disease, it includes other limitations such as, can you take a shower? And this one for St. Jude Life was developed with 44 items, and you simply get a 0 or a 1 for your score, in some cases a 0.5. And then you sum those the scores and divide by the total number of items. So you end up with a number, a DAI number, somewhere between 0 and 1. And in geriatrics, 0.2 for your DAI score is low, and high is 0.35. and a meaningful difference is 0.06. Keep those in mind. So in 4,000 survivors within St. Jude Life compared to 683 controls, first, there was a clinically meaningful difference among our survivors. If the clinically meaningful difference is 0.06, we clearly achieved that threshold with our survivors. But maybe more importantly, more obviously in a visual image, is that when you plot the deficit accumulation index by age, the slope of the line for survivors is steeper. So it really argues that there's an acceleration of this deficit accumulation in survivors. So I think we all agree, phenotypically, there's pretty good evidence for accelerated aging. Now, what underlies that? Let's talk about the physiologic mechanisms only briefly. I think Smita may touch on this as well. So we know from geriatrics that there are a number of things that drive aging. Genomic instability, telomere attrition, epigenetic alterations, cellular senescence are some that we're very interested in our survivors, because maybe radiation and chemotherapy drive or accelerate that in our survivors. So just a couple of quick studies. Xiaoming Wang is looking at epigenetic aging. And just for the sake of time, I won't go through the details of this R01, but he had preliminary evidence when he looked at epigenetic age over chronological age that the slope for our survivors is different when it comes to epigenetic aging. So maybe there's epigenetic modification that's occurring with some of our cancer treatments or some of the downstream effects that are modifying this age acceleration. And another one is clonal hematopoiesis. And Xingwei Zhang from our institution showed that when you look at CHIP in our population and compare survivors to controls, there's certainly higher levels of clonal hematopoiesis, and it's associated with certain therapies that we gave them, the alkylating agents, the radiotherapy, and bleomycin. So it may be that there are underlying biologic mechanisms explaining this. There's a lot more to be explored in this population. So I want to close this talk with, well, what do we do about it? How do we think about this? If they're aging faster, their aging is accelerated, how do we think about it? Well, one is to think about models of survivorship care across the lifespan. And we think about treatment of cancer, of course, that's happening in a cancer center like yours, and there's cancer center follow-up for some amount of time. But for the long term, of the many models that are out there, one of our favorites is the idea of shared care. The idea that there's a specialized long-term follow-up clinic that's sharing care with community follow-up, and that this might be the best way or one of the best ways for our survivors. Now, there are other models, but in the shared care model, the principles are that follow-up in a cancer center occurs, but with transition to community care. And that ongoing contact with community providers through this process is really, really very important if we're going to hand these patients off and share their care in a meaningful way. Continuous availability of the cancer center team is key. And then providing services to a larger number of survivors is possible when you're sharing care like this. It's potentially more cost-effective than cancer center follow-up. It maintains a link to the cancer center to monitor late outcomes. And then you can ask, well, why is this so important? Well, there's actually data to show that this may be the most effective way. When we look at cancer and non-cancer related preventative services, our survivors are more likely to receive the services they need if they're in this shared care model. So you see here on this table from data now almost 20 years ago, that those receiving care both from a primary care provider and an oncology provider are going to have the highest levels of mammography for breast cancer screening, the highest levels of lipid assessment, influenza vaccination, cervical examination, colon examination. So this shared care model may be the strategy. Now, can that apply here and apply across the world? There are obviously different challenges to this model and thinking about that model across the world, but it's just one way that we're thinking about it in the United States. So with that, I will end. And again, thank you that this is a team effort and team science. All right.
Heavily research-oriented talks, we come down to the ground reality of what is the landscape of survivorship in India. And I'm very happy to see Dr. Gauri here telling us about the landscape of survivorship in India.
Thank you, Dr. Kurkure. Dr. Kurkure is not only my teacher as in pediatric oncology, but also in survivorship. It's really an honor to be here, to be part of TMH EBM, and so happy that there's a whole day dedicated to survivorship childhood cancer. So that's just a photograph of my hospital. And these are basically the agenda points of my talk today. I will try to stick to the time. So as we all know, that until recently, childhood cancer in the low and middle income countries, such as India, was associated with poor survival due to various challenges. However, over the past decade, there has been a significant increase in the accredited training programs for pediatric oncology. There's better infrastructure and there is more awareness. And these advancements, alongside the improved infrastructure and treatment facilities across the country, have contributed to enhanced survival rates among childhood cancer, prompting a renewed emphasis towards surveillance and management of late effects. There is now more recognition, there is more awareness among our pediatric oncologists in India about the significance of late effects and long-term effects of cancer therapy. This is further substantiated by the formation of our national multi-center registry for survivors under the umbrella of the Indian Pediatric Hem-Onc Group, the INFOG. It's called the INFOG Late Effects Study Group, which was initiated in 2016. And we also see that there is a growing number of survivors in our country. This slide I have borrowed from Ramandeep Arora. And this detailed analysis shows that the population of childhood cancer survivors is likely to be almost 0.42 million. And for the childhood and adolescent cancers today is almost more than 500,000. Which is almost equal to what we have heard about the number of survivors in the US and in Europe. So we do have a large burden of survivors in our country, but where are they? So globally, especially in the high-income countries, awareness and focus on late effects has been in existence for nearly half a decade, as evidenced by the famous statement of Professor D'Angio that emphasizing that cure was not enough and that late effects research he declared to be a very essential priority. So the high-income countries now have mature survivorship programs with a lot of research, a lot of outcomes being shown, which we have heard this morning. And they have specialized long-term follow-up clinics with excellent support from multidisciplinary teams. And their follow-up care plans are based on evidence-based guidelines that, like the COG. And other Western countries have the Dutch later, the Swedish, the UK, they all have their evidence-based guidelines. In countries like India and many parts of Asia, the cancer survivorship program is just emerging. These clinics are, as you have seen or you are aware, are mostly primary pediatric oncology physician-led. The multidisciplinary team support varies. They cater to children and adolescents, although few also attend to adult survivors. Transition is a dream. It's something we would like. Resource limitation is almost universal in terms of time, space, manpower, funds for treatment of late effects, etc. Hence, civil society and NGOs play an important role in the survivorship program in India. Let me walk you through the evolution of the survivorship program in India and its landscape. So the Tata Memorial Hospital were the pioneers in this field under the leadership of Dr. Purna Kurkure. So they do have a dedicated long-term follow-up clinic, which is located in a cancer center. It is an excellent multidisciplinary support. And you can see here, it was initiated in 1991, almost 35 years ago. And they have their weekly endocrine cardiac support. And the psychosocial education career guidance is supported through the institution and through the Indian Cancer Society, which is an NGO. They also help with tracking of patients. Subsequently, informal clinics also were initiated in 3 or 4 other centers in the country in 2005. In 2014, the INFOG Late Effect Subcommittee was initiated. And in 2016, the Registry of Childhood Cancer was initiated by Dr. Rachna Seth at All India Institute, and some of us are part of this study. I will just show you 2 prototypes of other large clinics in the country. So the first, I will talk about All India Institute under the leadership of Dr. Rachna. It is a pediatric oncology-led clinic in a multi-specialty hospital. Once a week, dedicated space for the clinic, risk-based assessment with support from nurses, counselors, dietitians, and multidisciplinary support available from the various departments of the hospital, whether it's endocrine, cardiac, pulmonary, neurocognition, psychiatry. So they have a very good team. At our hospital, which also started its clinic formally in 2014, we have two days a week clinic. It's a clinic in a cancer center, pediatric oncology led. We have a dedicated counselor for the clinic, which is given to us by the Indian Cancer Society. And we have a once a month endocrinologist. We have an obesity intervention program supported by physiotherapy and the dietitian. And we do have a data manager. Education, career guidance, and psychosocial support is all provided through the ICS counselor. So we all, through this registry, the C2S registry, which is the INFOG study, use now or have developed and now use this abbreviated treatment plan, sort of the treatment summary and a follow-up plan. And we try to have, I think most of you will be familiar with this treatment summary plan. It's quite basic, but it's a big start because prior to this initiation of this registry, we were not using this in any formal way. And now most of us have a slight modification of this form, not exactly in the same way, which we give to our patients at the completion of treatment. And we have a very simple kind of a follow-up plan in which not only disease, we actually enroll patients at the end of treatment, so we don't have attrition because we think otherwise we will not get these patients into our clinics. And other than the basic growth, pubertal development, academics, immunization, and a few other things, our risk-based assessment is quite preliminary. In this INFOG study, which was initiated in 2016, the accrual of patients was quite slow, but now we have almost 30 centers. I think 5 or 6 of these are still yet to accrue patients. They are from various, most of them are in New Delhi, Mumbai, Hyderabad, Bangalore, and we hope to have more centers recruit patients. As you can see here, almost 500 odd patients. This is actually, we have recruited about 4,800 patients in this clinic. But I'm showing you data of 1,400 who have completed more than 2 years of follow-up. And you can see that actually only 3 or 4 centers are recruiting in a good way. So really we need a boost to this to sort of encourage more people. As we know, there is a resource and manpower crunch. And so we have to take time away and people away from acute care to dedicate to this. And therefore, recruitment is often slow. I'm also showing you some data from a preliminary analysis, which was presented just 2 weeks ago, in which you can see that just about out of 4,200, only 470 have more than 5-year follow-up. And this is not because of attrition, but because of the slow recruitment. And we were trying to look at the various exposures and plan some guidelines. So because of resource crunch, the NGOs or civil society plays a very large role in reducing attrition. They help track our patients. Some of them have passport for care, some modification of it. They provide support for growth hormone and other late effects, and a regular psychosocial support. You will hear in the subsequent presentations more about this. And the two major players here are the Indian Cancer Society and the CAN Kids, which are helping a lot of patients. So moving on to the India's service delivery models in India, and this I'm basing this on Dr. Arora's presentation paper in IGMPO, in which he has actually displayed results in which an online questionnaire was made, and about 86 centers were identified, which had pediatric oncologists, and 59 of them answered. And you can see that 91% provided survivorship within the routine oncology clinics. There was really no upper age limit or time period for the follow-up. And these were some of the barriers they observed, which was mostly a distance to the clinic or lack of knowledge, and that it was not a priority for most of them. I think there's a huge knowledge gap, and we need to address that with the help of the civil society. So differences in ethnicity, nutrition, treatment protocols, quality of drugs, quality of supportive care, lifestyle and behavior all influence spectrum of late effects. And if you look at the main late effects that we observe in these are some of the 3 or 4 common problems that we see, and these are reported by the larger clinics, larger survivorship populations from these centers. And you can see that obesity is a big problem now. Almost 20 to 30% of survivors at 5 years follow-up are obese or overweight. Metabolic syndrome is almost seen in almost 5 to 10%. Dyslipidemia is very common. I'm showing you hypertriglyceridemia, which is 10%, but actually if you look at the whole burden of dyslipidemia, it's almost 40%, and this is actually high in our country. Overall, ethnically, or you can say genetically, we have high predisposition. Psychological problems, scholastic difficulties are seen in 40 to 50%, and the patients treated prior to 2000 and prior to 1990s have a high burden of or high seroprevalence of hepatitis when the screening methods were not so good. Attrition is a big problem, and this study from Tata Memorial, you can easily see, courtesy Dr. Maya Prasad, that patients who were treated prior to 1980, almost 75% are lost to follow-up. Those treated between 2001 and 10, almost 20%. And then now in the current era, they have a more than 90 to 95% follow-up of their patients. So really the tracking is helping. This is our own institutional data, and I'm trying to show you that about 100% if they have follow-up at 1 year, you can see it drops to 83% by 3 years, 60% by 5 years, 30% by 8 years, and by 10 years, you can see hardly 20% of them are following up. So when we looked at the data, it was a bit discouraging. So we hired a secretary, active tracking was done. We offered free preventive screening at 5 years to everybody, which included lipid profile, hepatitis, and few other thyroid and few other hormonal evaluations. We did cultural events to motivate them to come to the clinic, and we saw that from 22%, we have up to 60 to 70% follow-up now. These are 5-year follow-up patients who are 5 years from diagnosis. And these are just some cultural events that we do to try to motivate them to have a physically active life. So spectrum of late effects also, you can see here the prevalence. This is data from Tata Memorial. It's important to recognize a unique spectrum of late effects in India, but there is also a trend, a change happening. If you see this paper, they will show you that in the 90s, almost 30% seroprevalence was there for hepatitis, but now it is down to almost 2 to 3%. So with better facilities, we definitely have. So we can see here, obesity almost 30%, metabolic syndrome 9%, and with aging, with increase in the age of the survivors, you can see metabolic syndrome from 3% is now almost 30%, equal in boys and in men and women. It was more in the boys, but now you can see this graph as well is showing you the rapid increase in metabolic syndrome. Therefore, it's really important that with our follow-up, and which we are actually doing, we really insist and aggressively counsel for physical activity and healthy diet and avoiding Also, we are looking, and this is again data from Tata Hospital, which have the largest publications to date. The high prevalence of, so they have looked at azoospermia, endocrine abnormalities, and even now looking at the trend in gonadotoxic treatments over time. And you can see that the doses of the gonadotoxic treatments are also being reduced over time with better risk stratification and better understanding of late effects. So this is our paper from one of my colleagues who shows high incidence of sarcopenia, bleomycin-associated pulmonary toxicity, and now coming to the very important thing that we don't have our own clinical practice guidelines because we do have a unique set of side effects. So there are difficulties in adapting and adopting Western guidelines because they are basically evidence-based on a different profile of patients. And Ramandeep in his subsequent talk will, I think, delve into this in greater detail, that it is very cumbersome for us to use it, and it may not be appropriate for our population. So to conclude, the scientific landscape of childhood cancer survivorship in India is evolving with significant strides made in establishing registries for childhood cancer survivors, but we need to really encourage more robust participation. Adaptation of guidelines on survivorship care plan is work in progress, and you will hear about it soon. Involvement of civil societies to overcome resource barriers, address knowledge gap among survivor families, and advocacy for government policy is really important. Ongoing research and dedicated programs are essential to create our own evidence and further enhance survivorship care and improve the overall well-being of childhood cancer survivors in India. Thank you for your attention.
Thank you, Dr. Gauri, for that positive closure of very bright future for survivorship care in India. And now I go on and invite Dr. Smita Bhatia from University of Alabama. Smita has been a long-time friend, and she was the first one to think about genetic basis. We always say that it is an interplay of the organ at risk based on the treatment given, but also the host factors, which are basically the genetic basis of late effects and risk predisposition. So she is going to overview this aspect of late effects.
I guess I do need to stand here. Thank you, Purna. Thank you, Maya. Where are you, Maya? Here. And thank you all for attending this talk. The first thing I want to say is that I am going to give this talk, and occasionally I'll lapse into Hindi. And if I do that, my colleagues who don't speak or understand Hindi, please know that there's nothing that you're missing when I'm doing it. Okay, it's just to add some local flavor. Occasionally, I might not do it. It depends on what happens. But again, thank you very much for attending this session. And here is the talk. I have 20 minutes, 19 minutes. Okay. So you've heard this again and again, right? 500,000 childhood cancer survivors in the US, and now with Dr. Arora's calculations, again, 500,000 anticipated projected survivors in India as well. As Greg had said so eloquently, that by almost everyone has a long-term complication. And that becomes evident with these figures that by age 45 years, over 95% of patients who survive childhood cancer will develop a significant health problem related to childhood cancer diagnosis or its treatment. And these are figures from CCSS and St. Jude Life. Most of the definitive studies have emerged from CCSS and St. Jude Life. So if I don't acknowledge that part in terms of describing the magnitude of the problems, if I don't acknowledge that, please know where it's coming from. These complications were also outlined by Greg in his figure from Melissa Hudson, but I just want to highlight certain problems which are actually life-altering. These include steroid-induced osteonecrosis, anthracycline-induced heart failure, And then radiation-induced second cancers. Shown here are breast cancer and a meningioma in a patient. This is a slide from the British Childhood Cancer Survivor Study. And what we are trying to show here is that there are cause-specific late mortalities that happen as a result of these complications. Here's the baseline rate for anybody. You know, life is a terminal event. We all are going to die. So the risk continues to increase. But in childhood cancer survivors, the recurrence-related mortality is high initially and then plateaus off. On the other hand, all other causes except recurrence continue to increase. They cross the recurrence-related mortality and there's no plateau seen. The risk of dying is 6-fold higher amongst childhood cancer survivors as compared to age and sex-matched general population, and the life indeed is shortened by 1 to 2 decades. There are clearly clearly defined associations between therapeutic exposures and chronic health conditions. Anthracyclines and chest radiation result in heart failure. Radiation alkylating agents, topo-2 inhibitors, and anthracyclines result in second cancers. Now, if a patient comes to the clinic, we do need to treat them. Therapeutic exposures based on the age and sex result in adverse events, but we do know that there are certain modifiers: genetic predisposition, lifestyle exposures, alcohol, smoking, viral infections, hepatitis B, hepatitis C, EBV, human papillomavirus. All of these contribute to those who are at a higher risk of developing these complications and can be harnessed to identify those that are at highest risk. We can use these to modify therapeutic exposures up front, screen those who are at high risk, and then develop risk reduction strategies. But we need to do this smartly amongst those who are at the highest risk so we can take care of these adverse events. Now let's talk about genetic predisposition. Traditional epidemiology, I'm sorry, there is some translational stuff that happens, so please forgive us as these certain things get modified here. So therapeutic exposures result in adverse outcomes. Who will develop those adverse outcomes are indeed a black box. Molecular epidemiology has taught us that exposures will result in varying internal doses, biologically effective doses, altered structure and function, preclinical disease, before clinically overt outcomes develop. And we can harness all of these gray boxes in order to understand who is more susceptible to develop these outcomes and dissolve that black box, which didn't get dissolved in this. Anyways, so for this reason, we developed a case-controlled study of key adverse events after childhood cancer. This is the COG-ALTE-03N1 study. And as you can see, 03 means it was started in 2003. And today it is closing. Today. So 21 years later, 22 years later, we're closing this study. What was this study? This study said those individuals who were diagnosed with the primary cancer at age 21 years or younger and had developed a second outcome, subsequent outcome, would be enrolled, and a matched control of individuals who were diagnosed with a primary cancer at age 21 years or younger, but no evidence of that key adverse event would also be enrolled. The matching criteria: primary cancer diagnosis, year of diagnosis, race, ethnicity, and time since primary cancer. We were collecting samples, DNA and RNA, from those who gave us peripheral blood. And if they did not, then saliva samples, although most of the patients gave peripheral blood, and self-report of comorbidities. We also asked, 100 sites participated. We asked them to summarize therapeutic exposures for cases and controls. And we asked for source documentations for osteonecrosis, for congestive heart failure, for second cancers, and for stroke. And these were the 4 outcomes that we targeted. Important to note that for all of these patients, we got almost 99% of the information that we asked for. So we are going to discuss these 2 outcomes here: heart failure and second cancers. We all know that cardiomyopathy in childhood cancer is primarily caused by anthracycline chemotherapy. I'm not going to delve into the newer agents because we really haven't established, as you also saw in a very beautiful talk earlier this morning, in the pediatric population of the long-term outcomes in this group. Risk modifiers include chest radiation, young age at exposure, female sex, and cardiovascular risk factors. So sorry for this, but here we are. We have shown a clear dose-response relationship, as if others. On the x-axis are the cumulative anthracycline exposures. On the y-axis, the risk of developing cardiomyopathy. And you see that there is a sudden inflection here at 200 to 250 milligrams per meter squared, where patients develop a much higher risk of developing these complications. However, we have to remember that about 60% of children exposed to high-dose anthracyclines do demonstrate echocardiographic indices of abnormal cardiac remodeling, and that those who develop heart failure have a poor prognosis. Less than 50% of them survive 5 years. With this in mind, we have to understand what happens in the heart. So those who are going to develop heart failure go through these successive changes in their myocytes. Initially, there's cell dropout, myocytolysis. This then is followed by patchy myocardial necrosis. You see these patches. Then multifocal myocardial fibrosis with disruption of the myocardial structure, and then florid interstitial fibrosis, which then presents as heart failure. We also know that there's significant inter-individual variability of anthracycline-related cardiomyopathy. Here are the cases. On the y-axis are the doses of anthracyclines. Each of these green dots represent a case lined up against the dose. Cutting the dose at 250 milligrams per meter squared, you see that a number of people have developed heart failure at a much lower dose. And amongst the controls, you see 250 milligrams per meter squared cut here. A lot of people have received anthracyclines at higher doses and yet escaped developing heart failure, bringing up the concern of genetic susceptibility. So here is our framework. We're saying you'd receive high doses of anthracyclines. The anthracyclines need to get into the heart. So genes responsible for drug transport need to be harnessed. And then they undergo a single electron reduction through the NADPH oxidase multi-enzyme system, or 2-electron reduction, becoming an alcohol metabolite, which then results in myocyte apoptosis. But both these mechanisms result in increased reactive oxygen species, result in mitochondrial dysfunction, myocyte apoptosis, maladaptive remodeling, and then heart failure. So we have used candidate gene approaches, carefully curated SNP arrays, agnostic genome-wide association studies, and also functional studies in order to understand where these genes fit into this model. So using the candidate gene approach, what we have shown is that if we take a particular gene, carbonyl reductase, where the enzyme adds an alcohol moiety to the parent doxorubicin, which is tremendously cardiotoxic and hangs around in the myocyte for a very long time, which the gene resides on chromosome 21. It is expressed in the heart. And what we also know is that amongst the white populations, the minor allele frequency is 31%. Amongst the blacks, it's 51%. When we look at the association between carbonyl reductase, GG allele, genotype, we find that the dose-response relationship with heart failure is much higher than when we look at GA and AA genotypes. And what we find is that this association is present at all doses up to 250 milligrams per meter squared. So there's no safe dose here. We then took liver tissue and looked at CBR3 activity, the enzyme activity. And what we find is that in the GG allele groups, much higher amounts of CBR3 activity was found as compared to the AA groups, suggesting that the GG genotype is associated with higher enzyme production, greater amounts of the alcohol metabolite, more cardiotoxicity. And this is where it would sit here in this model. We've also looked at GST. We all know that GST class of drugs are important in detoxifying anthracyclines. So when you have no glutathione S-transferase M1, then you won't detoxify anthracyclines, and the anthracyclines will hang around for a much longer time. And here what we find is that the GST-M1 null genotype is associated with a threefold higher risk of developing anthracycline-related cardiomyopathy. When you look at the GST-M1 gene expression, you find that here are the cases and their matched controls sitting next to each other, that the cases have much less expression of GST-M1 as compared to the controls. You look at the human-induced pluripotent stem cell cardiomyocytes, and getting hidden by this particular bar, but believe me when I say that this has been derived from a healthy cardiomyocyte, and this from those who had cardiotoxicity, and those who were derived from the cardiotoxic patients had lower expression of GST. So this is where GST-M1 would sit. It would increase the null genotype would result in an increased amounts of anthracyclines. Now, we've also done carefully curated SNP arrays. Oh my God, the time is running away from us. And here, why did we do this? We did this because, as Greg had also said, if you have hypertension, much higher risk of anthracycline-related cardiomyopathy. If you have diabetes mellitus, much higher risk of cardiotoxicity. So using a particular cardiovascular SNP array, we prioritized about 2,100 SNPs likely to be involved in cardiovascular disease. And what we find is that there was a gene on called HAS3, which resulted in its GG form, no increase in risk of cardiotoxicity. GA form, a little bit of an increase in risk, and the AA form was tremendously increased in risk. And we replicated it. And what we showed then was we took the heart samples from National Disease Research Interchange, where we genotyped this HAS3 and then looked at gene expression. And we found that amongst those who had the high risk genotype, much less gene expression was there as compared to those who were not the high risk genotype. And what does hyaluronic acid do? Hyaluronic acid has significant antioxidant properties. And if not enough antioxidant properties are available, there is increased reactive oxygen species and therefore increased risk of cardiotoxicity. Really quickly, agnostic genome-wide association studies. Here we're looking at a GWAS that we did earlier on and found that a particular SNP on a gene called SELF4 was associated with an increased risk of anthracycline-related cardiotoxicity, such that in the discovery, we found that the AA genotype, no increase in risk, no matter how high the dose. The GA genotype, no increase in risk, no matter how high the dose. But the GG genotype, much higher risk. And we replicated it, these findings. But here we're looking at the SELF4 gene. So SELF4 protein is encoded by the SELF4 on chromosome 18. It regulates pre-mRNA alternative splicing of TNNT2 gene during development. And this TNNT2 splicing variant carries exon 5. It's carried on exon 5. It's expressed in embryonic hearts, but is mostly absent from the mRNAs in adult hearts. Now let's talk for a minute about TNNT2. Now TNNT2 encodes for cardiac troponin T. It's located on striated muscles. It regulates muscle contraction in response to changes in intracellular calcium concentrations. And we know that cardiac troponin T is a biomarker of cardiac injury, and that the levels increase soon after anthracycline chemotherapy. Now, if we were to have persistent expression of both the embryonic and the adult variants of TNNT2, it would result in a myofilament which responds in a very different way at different times with rising calcium levels. This would result in decreased ventricular pumping, and coexistence of 2 or more TNNT2 splicing variants have been found in dilated cardiomyopathy. So the question was that could the expression of 2 TNNT2 variants in myocardial tissue be associated with the genotype that we had identified? We again took heart samples. These are healthy heart samples, people who had died in auto crashes, etc., not had heart failure, not exposed to anthracyclines. And we genotyped them. And we looked at embryonic splicing variants of TNNT2. In the low risk, there was no embryonic variant. In the intermediate risk, 62% carried the embryonic variant. And in the high risk, 91% carried the embryonic variant. So our hypothesis was tested in this, that the embryonic TNNT2 variant more likely coexisted with the adult variant in hearts that were homozygous for this GG. And here, this is how we thought it would fit in, that self-mediated alternative splicing of TNNT2 would result in more than one isoform of TNNT2. It would result in decreased myocardial contractility, and it would result in heart failure. More recently, we did another GWAS study in collaboration with CCSS and identified a significant gene-environment interaction in a gene called ROBO2. Now, ROBO family of genes encodes a transmembrane receptor that binds slit guidance ligands with functions that are linked to cell adhesion, migration, growth, and survival. Slit robo signaling promotes cardiac fibrosis, and we showed that each of these pieces was indeed significantly associated with cardiomyopathy in our study. And here is where ROBO2 would work. What it would do is, through slit robo signaling, result in cardiac fibrosis and result in maladaptive remodeling. I will not show any of these, but we've done a fair amount of work, but all of this to show that each of these has a place in this cardiomyocyte here, where this is the DNA and this is the mitochondrium, and all of these things result in a high risk. Now, can we identify high-risk groups? Indeed, we can. Multiple variants have been combined and have resulted in classification of patients into high-risk groups, intermediate-risk groups, and low-risk groups. And I won't go into any of these details here because of time constraints, but just to show you what you're missing. Bahut sara. To end the talk, I would say that this is the group that did it. These were the funding agencies that did it. This is the hospital where I work. And this is the guy I turn to with my questions. And I'll be happy to take, whenever the questions are being taken, I'll be happy to address them. Clearly, I miscalculated how much time I had. Sorry. Thank you.
Thank you, Smita, for that. Thank you, Smita, for that wonderful talk, though abbreviated. We have been told by the organizers that they need this hall for inauguration, followed by hospital day oration setup. And that is why my dear friend Siddharth will speak later in the day after the oration. And we don't have much question and answer, but to just summarize this session of morning, we saw basically we had a good overview of what the late effects are. And if I have to put it in two baskets, we have one old time standard modality of treatment, that is chemo, radiation, and surgery, causing late effects with a finite endpoint. And you have another bucket of newer modalities where it is newer and we are learning, and it is not a finite treatment because the duration of treatment is variable and questionable whether it is to be lifetime. And that leads us to the new era. I'm sure all the high income countries where you have done enough of work for the first bucket now will do their bit for finding out as to what this newer molecules can cause problem as we go by. And that keeps us busy for further 2 to 3 decades, I'm sure, till something new comes up. So it's a most dynamic situation, how we chase the late effects from the standard treatment that we had to the newer molecules and more after that. With that, I think we can break for tea and ask very specific questions to the.
So thank you very much, everyone. I'm sorry we had to cut short this, the last talk, but we will start our afternoon session at 2 p.m. instead of 2:15 p.m. as is there in the schedule, so that we can have Dr. Lashkar also speaking in the afternoon. We have our, as you probably know, yesterday was our hospital day, and this entire program is built around our hospital day celebrations. So at 11 a.m., we have our hospital day oration, our celebrations, and also a keynote. So all of you are very cordially invited to attend this. Now we'll break for tea.
Yes. सगळ्यांना बोलव माझी माझी Who is that? बड़े हो गए अगर चल चल ऊपर वो दीपक किधर गया दीपक को अपने वहां पे आ रहा है सिद्धेश इकडे पहिला इथे 1 सेकंड का काम आहे टेबल साईडला करायला पाचचा गिनती गिनती करो काढतोय ना खालती ना एक खाते एक खाते जास्त माणसं hello check 1 2 बहुत ऊंची बड़ी बड़ी check hello yes check आगे तो क्यों इधर आए? बस कैफेटेरिया वाला कौन है जरा बोलो यहाँ से ये तो क्या होएगा ही अच्छा
We should readily agree as our health. People across the world even greet each other through a
yes yes सबके लिए रिबन वाली तो ट्रेन है मतलब ट्रेन है अंदर अरेंज करो बहुत मारो
Check, check, one, two, testing. Check, check, one, two, testing. Test, check, one, two. Check. Hello. Test. Check. Hello. Hello. Check. Test. Hello. Hello. Testing. Hello. 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 Test. Check. One. Hello. Check.
शैलेश लाइट बंद कर शैलेश शैलेश चव्हाण लाइट ऑफ कर लाइट ऑफ कर ऐकायला येत नाही का? अरे काय मोठं माणूस आहे. हे ऐकायला येत नाही तुला काय एवढं टाइम लागतो
Hello, 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 check. Hello, 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 check. Hello, check. Hello, check. Hello, hello, check. Hello. लाईट लाईट बंद कर. हॅलो चेक. हॅलो चेक.
काय नाही होणार तो प्रोजेक्टरच तुमच्या चेहऱ्यावर येतो.
come from little social commitment also. So I wanted to come and I said yes to go Anand that I'm coming, but I could not come. Ah, whole day. Tomorrow also I'll have this presentation. Okay. Yes. Thank you, sir. आता पाणी भरून ठेवणार हा
इधर 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 नहीं रुकेगा, इधर ही है, नीचे आके, इधर ही है। नहीं रुकेगा, उधर नहीं रुकेगा, इधर गिलास गिलास दो गिलास।
Dear esteemed dignitaries, guests, colleagues, and friends, a very warm welcome and a very warm good morning to one and all. It is my absolute honor to welcome you all to the EBM 2025 Hospital Day Oration Session at the Tata Memorial Center. Since the last 23 years, cancer care providers across India and beyond gather in this august auditorium, with our phones on vibrate mode, if I may add. We gather to celebrate the profound impact of evidence-based medicine on patient care and to catalyze the adoption and propagation of the same, one small evidence-based step at a time. To set the stage for the oration, let us first take a moment to reflect on the fascinating story of the history and evolution of the EBM. People of my generation, and I'm clubbing myself with the younger generation here, love superhero origin stories. And the origin story of the EBM is no less than that. The wheels of the first EBM in 2002 were set in motion by a very interesting insight we received from a team from NIH, America. They had surveyed multiple African countries in 2001 and realized that the Western guidelines were not practically implementable in Africa, and that in fact about 7 to 8 African countries were religiously following the more pragmatic TMC guidelines for cancer management. Realizing the enormous impact of our work, not just in India, but beyond across all LMICs, our former director and then surgical faculty, Dr. Badwe, pioneered the first evidence-based medicine conference in 2002. He, along with an eminent team, including Dr. Rajesh Mistry, Dr. Rajiv Sareen, Dr. Sudeep Gupta, Dr. C.S. Pramesh, Dr. Devendra Chaukar, Dr. Pankaj Chaturvedi, amongst others, successfully organized the first EBM with 2 tracks focusing on breast and thoracic cancers each, and updated and published the evidence-based guidelines for the same, including specifically resource-stratified guidelines for LMICs. And here we are today, celebrating our 23rd EBM. To speak more about the glorious traditions of the EBMs, I invite on stage Dr. Vikas Oswal, the officer in charge of the Central Research Secretariat, Clinical Trials Center, Department of Atomic Energy.
Good morning. On behalf of Clinical Trials Secretariat and Department of Atomic Energy, Clinical Trials Center, I extend a warm welcome to you all. Cancer treatment is extending or expanding, and we have significant gray areas in the treatment. And today we gather to discuss the evidence-based cancer treatment, but also we look at the nuances, or we look at the gray areas, what we have to explore. Well, as we look at these gray areas, we discuss many options which are available, but we also aim that our cancer treatment becomes more effective and more informed, especially that can help our patients. This is what lies at the heart of the EBM. And EBM is evidence-based management of cancer treatment, which helps us to understand more and more about these nuances, more than what is available. The EBM oration has a rich history and a tradition. And we had 2 Nobel laureates, Sir Paul Nurse and Professor Amartya Sen, speaking and sharing their expertise on right here at this platform of EBM. And we were delighted to hear them, and we had many more orators, and this was a privilege for all of us. So without further ado, we here showcase the great legacy of EBM to you all. Thank you.
There's nothing as important to human beings, we should readily agree, as our health. People across the world even greet each other through a quote-unquote salute. Salute is a word that literally means being in good health. By saluting each other, we wish each other, at least in our choice of word, good health. Not more wealth, not more opulence, not even more happiness, but better health. Public health care, we need more devotion by the state, and in a democracy, the people ought to demand it rather than be silent. That's really the biggest culprit here.
Wasn't that just inspiring? I'm sure that after that video, none of you can wait for today's proceedings to begin. And so let us do that right away. We are indeed fortunate to have in our midst an equally distinguished galaxy of stalwarts. And I would now invite them on stage to grace this occasion. Let us all extend our warmest welcome for them. I invite on stage Dr. Ajit Kumar Mohanty, Secretary, Department of Atomic Energy and Chairperson of the Atomic Energy Commission of India. Dr. Sudeep Gupta, Director, Tata Memorial Center. Dr. Rajendra Badve, former Director and Professor Emeritus, Tata Memorial Center. Dr. C.S. Pramesh, Director, Tata Memorial Hospital. Dr. Pankaj Chaturvedi, Director, Paediatric. Dr. Satyajit Pradhan, Director, Mahamanna Pandit Madan Mohan Malviya Cancer Center and Homi Bhabha Cancer Hospital, Varanasi. Dr. Bibhuti Borthakur, Director, Dr. B. Barua Cancer Institute, Guwahati. Dr. Ashish Gulia, Director, Homi Bhabha Cancer Hospital and Research Center, Mullanpur, and Homi Bhabha Cancer Hospital, Sangrur. Dr. Umesh Mahan Shetty, Director, Homi Bhabha Cancer Hospital and Research Center, Vizag. Dr. Shripad Banavli, Director, Academics, Tata Memorial Center. Dr. Rajesh Dikshit, Director, Cancer Center for Cancer Epidemiology. And last but certainly not the least, it is my privilege to invite today's esteemed orator, Professor Soumya Swaminathan, to grace the dais with her presence. We now have the honor of felicitating two stalwarts in their respective fields. I request Dr. Sudeep Gupta to present a bouquet to Dr. Mohanty as a mark of our respect for his achievements and generous support to TMC. I now invite Dr. C.S. Pramesh to felicitate our orator for today, Professor Soumya Swaminathan, with a floral tribute. I now invite Dr. Sudeep Gupta, Director TMC, to deliver the welcome address.
The chief guest, Dr. Ajit Kumar Mohanty, Secretary, Department of Atomic Energy, Government of India, the Hospital Day orator, Professor Soumya Swaminathan, former Secretary, Department of Health Research, my distinguished colleagues on the dais, who, as you have heard, are all directors of various units of Tata Memorial Center, my predecessor, the immediate past director of TMC, Dr. Badwe, distinguished invited faculty members from within and outside India, distinguished delegates, ladies and gentlemen. It is a proud moment for me to welcome you all to the 23rd Evidence-Based Management of Cancers meeting in Tata Memorial Hospital. I'm proud for several reasons. Foremost, yesterday was the 84th birthday of Tata Memorial Hospital. We have redeemed, at least in part, the vision and dreams of those who founded us 4 years ago. We are now 11 hospitals in 7 states of India, a rainbow of institutions, and the directors of all those wonderful institutions are on the dais. In the calendar year that just set upon us in this past December, we registered among all our hospitals a little under 1/10 of all new cancer patients in India, 129,000 of them. We not only registered these patients, we provided them with evidence-based care that we have so assiduously nurtured in this institution since the time that EBM was in its infancy. It is this adherence to the letter and spirit of evidence-based management in our service that brings tens of thousands to our portals. They know that our systems will try to do what is right and what is good for them. The 4 pillars of this institution are service, education, research, and public health. And the ethos of evidence-based action permeates all of them. Our researchers try to create evidence that is actionable and implementable in our country and throughout the world. We don't use lower doses and lesser durations of expensive drugs just out of the blue. We try to create the highest levels of evidence for their use. Our trainees, who are molded in the image of this institution and are our lifelong ambassadors, are steeped in the culture of EBM during their tenure here. Our public health and epidemiology specialists create community-level evidence that can be acted upon on a country-wide scale. The most impactful example is the adoption throughout the country's public health system of clinical breast examination and visual inspection of the cervix with acetic acid as the methods of screening for these 2 cancers. Our institution conducted the seminal study that provided level 1 evidence for these methods. So here we are gathered in this auditorium on the 23rd occasion for doing what is right by our patients. I thank all the faculty members and delegates who have shared your precious time with us to be a part of this journey. We have the legacy of India's 2 great institutions behind Tata Memorial Center. the House of Tatas who founded us, and the Department of Atomic Energy who have lovingly nurtured us under their umbrella since 1962. We do not claim to be perfect, but we do claim that we will work with fire in our bellies to redeem the trust that so many continue to place in us. Thank you.
Thank you so much, sir, for those very insightful and thought-provoking words. I mean, I got reminded of Robert Frost's lines that the woods are lovely, dark and deep, and we have promises to keep and miles to go before we sleep. As we celebrate medical excellence, we do also recognize the dedication of our backbone, our beloved non-clinical and paraclinical staff. And we would like to take this opportunity to celebrate a very special achievement. Mr. Johnson Lucas, the Chief Security and Fire Officer, Tata Memorial Center, was honored with the prestigious President's Medal for Meritorious Service on January 26, 2024. This was in recognition of his outstanding contributions to security and fire service. Mr. Johnson has ably served Tata Memorial Hospital since 1995, 30 years, and with his efforts has been recognized on multiple occasions by the hospital's present and past senior leadership, and now, of course, by none other than India's first citizen. It is now my privilege to introduce our chief guest, Dr. Ajit Kumar Mohanty. Dr. Mohanty is a highly decorated nuclear physicist. He was born in Odisha in 1959. He completed his graduation with honors in physics from MPC College, Baripada, and his post-graduation from Ravenshaw College, Cuttack, and then joined the Nuclear Physics Department of BARC in 1983. He obtained his doctorate from Mumbai University and has conducted research using the Pelletron Accelerator at the TIFR and participated in the Phoenix and CMS experiments at CERN, Geneva, and at the Brookhaven National Laboratory, USA. He's a highly published researcher with an H index of 227 and more than 243,000 citations. He received the Young Physicist Award from the Indian Physical Society in 1988, the Indian National Science Academy Young Scientist Award in 1991, and the Homi Bhabha Science and Technology Award from the Department of Atomic Energy in 2001. He was the director, Saha Institute of Nuclear Physics, and the director, BARC, before being appointed the Secretary, Department of Atomic Energy, and the chairperson of the Atomic Energy Commission of India. I now request Dr. Mohanty to present the Presidential Award frame to Mr. Johnson Cherian Lucas. As Dr. Sen said in the video, a salute is actually wishing good health, isn't it? Ladies and gentlemen, we now move to a significant milestone, the launch of the Tata Memorial Center textbook of oncology. I invite on stage Dr. Shailesh Srikhande, Deputy Director, Tata Memorial Hospital, Head of Cancer Surgery and Chief of GI Surgery, and one of the editors-in-chief of the textbook to provide more details about the book.
Very good morning to all of you, and always a pleasure and privilege to be here on the foundation day of our hospital. Good morning to our distinguished guests and all the dignitaries on the dais and off the dais. And thank you very much for being here with us as we celebrate this great institution. Tata Memorial remains the leading institution for cancer care, offering world-class treatment despite resource limitations in a country which continues to live in different centuries at the same time. Actually, it doesn't live, it thrives. Recognizing that cancer care is best delivered close to home, we have really embarked on a program to try and develop our infrastructure in different parts of the country. And to a large extent, we have already achieved that in the past decade or so under the Department of Atomic Energy's leadership. However, there are vast challenges that we see and formidable challenges across this vast nation. We see about 15 lakh new patients of cancer. The mortality rate of cancers is more than 60%, and perhaps it's not in keeping with the best figures globally when it comes to looking at us as a developed country, more than a low and a middle income country, which we today are. And late detection, it remains a problem. After all, pain is the only real point of contact where a patient seeks a doctor, and issues of affordability, accessibility, and availability remain a problem, not just for patients, but even for those who want to specialize or develop or get interested in oncology. There are global concerns as well that 65% of global cancer deaths occur in LMICs. 57% of the new cancers that we see are also in the world, which is beyond the United States, Europe, and some of the developed nations of the world, which is a small minority, as you're all aware of. Cancer is responsible, and it's going to be a major economic burden for us, whether we like it or not. Perhaps close to $40 billion. That's going to be the economic burden for us in a young country where our life expectancy continues to increase, and yet we have an increasing geriatric population as well. So given the challenges that I just mentioned and personally witnessing for over 23 years, we are speaking about 23 and 24 years, that's the year that I joined Tata Memorial on the faculty when Dr. Badwe was our head of department. So at that point in time, we realized that yes, we are a beacon for service, research, and education in all aspects of oncology, but we need to make our knowledge more accessible, available, and there should be a high quality resource which is available, and therefore the genesis of the Tata Memorial Hospital textbook of oncology. We also run some of the largest training programs to train and develop specialists in oncology, in all aspects of oncology, not just surgery, medical oncology, and radiation oncology, but everything that is the world of cancer care. This book is designed to ensure that right from the undergraduate to the super specialists, everyone included, those who are doing oncology and those who are not even practicing oncology, it would be an invaluable resource to them. Why is it important that we reach out to everyone in the country and beyond? 40% of oncology care in our country is given by non-cancer specialists, and that's the reality which we can't ignore for a few more years at least. The book is over 1,000 pages. It's taken 5 years for us to put it all together. It provides a solid foundation for those interested in oncology. There is not only theoretical knowledge, but the foundations of oncology are very well explained in details. And as you know very well, most of the foundations of life do not change. The same thing applies to oncology as well. Of course, we are a rapidly changing field, and the landscape is always going to change every few years. But the foundation would be there very much so in this book. Well, we also have other challenges that we want to make sure that this book in the modern era reaches out to everyone, not just the hard copy, but whether there is an online version or all other forms of media. I personally like handling a book. I think my retention is better when I read a book. I'm not doing a sales pitch here, just to let you know, but I think it's important for you to know that a book in your home or in your shelf and in your libraries is something much better than all the smartphones that we handle. Now, this book would not be possible without certain major contributions. We have 191 contributors in this book, and they are all Tata Memorial faculty, current faculty across the country, and even the Tata Memorial Hospital alumni. I think they deserve a big round of applause for contributing to it. Now, moving on beyond the authors, I think first and foremost, as always, we would love to thank the Department of Atomic Energy, our parent department, for the Tata Memorial Center, for your consistent, unwavering support and continuing to believe us in our efforts and our capabilities. This book was again a brainchild of the same man who has established a whole number of centers across the country, Dr. Rajendra Badwe. And then he has a habit of saying yes to everyone, as Pankaj was saying some time ago. And then he promises everything and then he leaves it to us to deliver. So that's fine. That's okay. I think Sudeep Gupta has done a fantastic job in pushing through this book through the COVID years and even otherwise. And it's been also wonderful for my colleague Siddharth Laskar and me. We all four of us could work together. And hopefully you will come see this book, which is going to be something which is going to be enjoyable and educational. Special thanks to also one quiet worker, Yogesh Kembavi, for his many hours of hard work, relentless hard work. And I've always seen you smiling. I've never seen you unhappy. Privately, I'm sure you are, but at least you don't show it to us. Springer is a world-class publisher, and we are very grateful to them for bearing with us and for being so proactive and professional. As I come to close this talk, I think the TMH textbook will serve as an indispensable resource for oncologists, but also policymakers and medical institutions across India and in healthcare systems similar to ours. Every academic cancer center, not just academic cancer center, but every medical college and hospital library will have a copy of this book. And that's something which is our endeavor, our focus, and we will ensure that this will happen in this very year itself. We need to dedicate this book. Very often at the beginning of the book, we have a page of dedication, which we very much have in this book as well. But I think this book is dedicated to doctors, workers, paramedical staff, back office personnel, almost every single employee of the Tata Memorial Center and the DAE. This book is to be dedicated to them. But all of us exist here only due to and for our patients. So we dedicate this TMC textbook of oncology to the countless patients who place their trust in our great institution during their darkest hour. Their courage will continue to inspire us to continuously push the boundaries of excellence and research in cancer care. Thank you very much for your kind attention.
Thank you so much, sir, for sharing the inspiring story behind the textbook. I would also request Dr. Siddharth Laskar, Deputy Director Academics and one of the editors-in-chief of the book, along with Dr. Badwe, Dr. Gupta, and Dr. Srikhande, to come on stage for the launch. I now request Dr. Mohanty to formally launch the textbook of oncology. That was indeed an uplifting moment, I would say, for me, and I'm sure for all of us. Continuing the spirit of academic progress, we will now have the organizing chairpersons of both the tracks to briefly introduce their respective tracks. I first request Dr. Gaurav Narula, the Track 1 organizing chairperson, to speak about the track.
Dignitaries on the dais and dear friends. I'll go again. The dignitaries on the dais and dear friends, it is really indeed my proud privilege to welcome you to the track 1 of the 23rd EBM 2025 that we are having in the main auditorium over here today. It's called Changing Paradigms, and one might think that, you know, when you attend conferences across the world, this changing paradigms is probably an overused and overextended sort of term that has been used for many, many things that are happening in oncology conferences. But not so in pediatrics. In pediatric oncology, nothing much has changed in the last 50, 60 years except the outcomes. We really had mainly the same new drugs, same old methods, just getting a bit more refined. We've been using them in different schedules and improving the outcomes. It's only recently that we have got more insights and are actually managing to move the needle. So for this EBM, we decided to focus on 4 main areas. One was the cancer genetics and predisposition syndromes and how they are affecting the outcomes and how they're affecting our diagnostic and ability to catch them, and also to use the available medicines and tweak them. One thing which does not happen in pediatrics much is new drug trials. And therefore, we have to make do and learn lessons from the adult oncologists of how to use these drugs. So we had a fantastic session yesterday where we discussed these issues. Another thing which has changed in pediatric oncology is the use of immunotherapy, especially with the use of checkpoint inhibitors and CAR T-cell therapy. And this is another area which required to be discussed in detail, which is what we did yesterday. The one thing that has improved in pediatric oncology is survivors. We now have the older survivors of pediatric cancer well into the 50s and almost into the 60s now. This has created a huge cohort of people now who require advanced care. And we heard some fantastic talks in the morning from our esteemed faculty from India and abroad about how we can now influence the outcomes of these people who are now surviving their cancers and well into adulthood. Another area that we have to focus on now, that all this has come about through collaboration, through clinical trial networks, and to implement the available science and to roll it out and come together. Pediatric cancers are not common, and therefore it requires all of us to come together to improve these outcomes. And that's the last session that we'll be having later today. And followed by that, we are going to be talking about some advances in radiation oncology, especially how to save the tissues, especially in these children, because they're going to have a long life after that. While I stand before you as the program director, I would like to tell you that this program has actually been put together by a great team of people and has actually been conceived by Dr. Girish Chinnaswamy, ably assisted by Maya, Dr. Mukta Ramadwar, and my friends from the Pediatric Oncology Department. They have worked tirelessly over the last several months to bring you this amazing program. And it is it has been their hard work which has brought a very good galaxy of speakers from India and abroad for you for this meeting. We ultimately managed to have about 170 registrations for this meeting, which was a bit difficult because we had to compete with several local and international meetings which were occurring at the same time. However, we still are very, very enthusiastic, and we are very, very happy about the large amount of turnout that we have had. There are some 24 abstracts which were submitted, out of which 5 very high quality abstracts will be discussed in the oral session. One last thing before I wind up, I can tell you that there was one more thing when we were discussing the speaker for the oration. As a student in FMC, everybody who's passed through FMC, we have these boards on the wall which show you the person who's got the gold medal in each subject in each year. And right through my college years, there was one name which used to be on every board, right from anatomy, physiology, biochemistry, every subject that you could think of, right down to the president's gold medal. There was one name on each board in the library, and that was Soumya Swaminathan. So indeed, when the final orator was being decided upon, there was none more happier than me. Somebody who's, we could only dream of what kind of person could this be to have her here with us for this day and prestigious oration. You will be hearing more about her and from her later on. And with that, I would like to welcome you once again for the track one and thank all the delegates and international faculty who have come from far and all our dignitaries and national faculty who have taken out their time to come here and be with us and educate us on these issues. Thank you very much.
Thank you so much, sir, for that lucid and concise introduction and for sharing that very interesting and I would say completely unsurprising trivia about Dr. Swaminathan. I now invite Dr. Sanjay Biswas, the Track 2 organizing chair, to speak on the track.
Good morning, everyone. On behalf of the organizing team of Track 2 of EBM 2025, it is my honor to extend a warm welcome to all the distinguished dignitaries on the stage and also those seated in the auditorium. This year's theme for Track 2 was infection and cancer. Team members, like Akshay said, that this is a legacy. And for a department like microbiology, don't go by the name, the burden was huge for us. But we had the support of Department of Medical Oncology and Department of Critical Care to go through. As you are all aware that infections have become a major concern in today's world with multi-drug resistant organisms, causing a threat to public health and have become a major cause of illness and death in hospitals. People who have cancer or who are getting cancer treatment often have a higher risk of getting an infection because of changes in the immune system, due to which infections can be more serious. Bacteria are the most common cause of infection in people with cancer. Other microorganisms include viruses, fungi, and parasites. In a recent study, it was shown that uh, uh, overall mortality in cancer patients is close to 2%, whereas when it comes to hematological malignancies, it is 60%. A total of 119 participants registered for the workshop and the main conference. We had 2 international, 8 national, and 14 local speakers to deliberate on various topics, keeping in mind the theme. In the workshop, we had discussions on basics of infection and diagnostics in cancer care, modern diagnostic tools, diagnostic techniques in specific infections, and a few clinical cases were also discussed. On the first day of main conference, topics such as tailored approaches to drug dosing, management strategy and stewardship in navigating the sepsis spectrum, management of infections in hematological malignancies, co-infections in cancer patients, and clinicians' dilemma to treat or not to treat infections were discussed. Infections as a cause of cancer and innovation in infection management, infection prevention and control in oncology settings will be discussed today. Additionally, a debate, an interesting one, of course, on unpacking infection management will be held. We had 26 abstracts, of which 5 have been selected for oral presentations and 21 for poster presentations. Your presence is a testament to a shared goal of advancing our understanding of infection. Once again, on behalf of all the members of the organizing committee of Track 2, I thank our directors for selecting such an important theme and giving us the opportunity to organize the conference. I thank you all for making this conference a meaningful and engaging experience. Thank you.
Thank you, Dr. Biswas, for that eloquent introduction. Ladies and gentlemen, we have heard a lot to celebrate and get inspired from already. But it's now my pleasure and privilege to invite our chief guest, Dr. Ajit Kumar Mohanty, Secretary, Department of Atomic Energy and Chairperson of the Atomic Energy Commission of India, to share his insights with us.
Good morning to all of you. Dr. Shaminathan, Dr. Badwe, Dr. Gupta, all the center directors, delegates, both from India and abroad, my dear students, ladies and gentlemen. I'm here to practically listen the Foundation Day oration. But then in this process, I got an opportunity to address you also, fully knowing that I'm the odd man out in this among you. Couple of months back, in fact, I was participating in a similar conference called EVM 2024. And you are discussing today EBM 2025. EVM, electron voting machine. This acronym always confuses me, but then it is very important by which we participate in Indian democracy. And this EBM, evidence-based management for cancer, it brings a range of hopes to the people. I always tell Tata Memorial Center and all of you working in the center are the jewels in the crowns of atomic energy. However, Director General of IAEA, Mr. Grossi, he says, all of you, not only jewels, you are the rays of hope for the people. And this is that EBM 25 is the rays of hopes. My first job was to release this book, textbook, and it was in my possession for a month. And the weight of this book is heavier than my weight. And since it was into 1 month with me, and Dr. Gupta has told I have to release it, I started reading without understanding. And but wonderful book, although I did not understand. It is wonderful the following way. You might have seen that cooperative movements in India in many ways. Amul cooperative must have. It is a book has come out of the cooperative movements. 191 authors, 4 editors. And generally books are written by hardly 2-3 people. And if you read it, very nicely printed, of course. I read a couple of them. Not that I did not understand anything. I read a couple of them, but the sequencing such nicely done by the editors. I was talking in the tea time that if we just remove the authors and just say chapter 1, chapter 2, chapter 3, it will be not less than a classic books on oncology. And this is how it is. And all of you should read it. And in fact, I was telling why it should be Tata Memorial Center textbook on oncology. Knowledge is global. In fact, it is a primer of modern oncology. A book, if you give a name, give primer of the modern oncology. And it is indeed this only. That's it, the book. Also, I forgot to congratulate Mr. Johnson getting the January, the President Award this year. Congratulations, Mr. Johnson. Your birthday was yesterday. A great day. 84 years of birthday of this institute. But you do not know what was the day yesterday. It was the Science Day for the country. C.V. Raman discovery happened in the same day when you were established, 28th. And while talking to the children yesterday, I was just telling modern science and future, where we have reached, because Raman discovery is nearly 100 years over, 95 or 96, close to a century. And I was telling them that what it has brought to us today. In fact, it is the scattering of light, Raman effect, what we call it. And today, if I extend the same analogy, same light, it appears in many forms. Something you can see it, that is the visual light in the visible region. But if you cannot see, we call it electromagnetic radiation. but it is light. In a broader sense, it is light either visible or invisible. It starts from radio wave, larger wavelength, then it becomes microwave, which enters into our kitchen, infrared, red, blue, yellow, ultraviolet. Then you can again see it, X-rays and gamma rays. These are all manifestation of radiation. And this radiation, he has not taught, using this radiation, we have learned a lot, we have discovered a lot, and going to learn a lot. Not only in fundamental science, day-to-day application, this radiation has entered in a great way in the oncology also, radiation oncology. And just a little diversion I told the children that using this radiation, probably you can see the future, see the past. You can study past, what happens in the before. Like we always say that our ancestors, those are rishis and munis, they are trikaladarshi. You mean that three kal, past, present, future, they all can see. I told them that we cannot be like that. We are not that intelligent. But with the aid of science and technology, probably now also we can see the past. We can see, we are seeing the present, and we can predict for the future. We can predict for the future. If we cannot do, we can take aid, that is artificial intelligence and basic learning. Whatever we have learned today, probably we can predict for the future. The question comes, how do you see the past using the lights, in some form of the lights? And in fact, it happened. Like why I told you, switch on the light, when it goes to you, you immediately see it is a present, because light moves with a velocity of very large, 3 into 10 to the power 8 meter per second. So if I put a light, immediately you see it, it doesn't take any time, instant. That is where the present is. But you know the light which comes from the sun, when it came, distance between sun and us is roughly 150 million kilometer. And if we divide by the velocity of light, it is not instant, it is 8, around 8. So if anything we are seeing today, it must have come 8 minutes before the sun. So it is a past. So using this light, we can study the past. In fact, in the Department of Atomic Energy, BRC in particular, and other institute, we have developed a time machine. And this is time machine we have installed at Hanle, Ladakh. And it is a 4.5 meter above the ground level. It is a mirror, parabolic mirror. And this mirror can collect lights from the celestial body. And this is called Cherenkov light, another form of the light. Again, coming from anything happening in the galaxies. We are where the Milky Way galaxy, the universe is full of galaxies. This whole is full of galaxies of luminaries, it was told. But universe is also full of galaxies. And we are the Milky Way galaxy. Like that, there are millions of galaxies in the universe. And in a galaxies, there are stars. Our solar system is part of it. But then we don't know how big the universe is. And many things has happened in the past. If anything happens in the universe, suppose some charge particle accelerates or some magnetic field, high magnetic field happens, there are radiation, gamma ray comes out and it can reach us. By the time it reaches the Earth's surface, it will convert into the visible radiation, Cherenkov radiation. Using a big mirror, you can detect it. On January 26th this year, when we are celebrating Republic Day, a signal came from us, which was created from a distant galaxy, a signal which was created 8 billion years back, and we detected today. So you imagine how big the universe is. And I told this because I can use the same light which we are using to study what is happening inside the body, inside the cell, by imaging, knowing the present. Same light can be used to know the future as well. And use your AI ML, you can predict the future. Present, you know, future you can predict. This is what the science today. Then question is, this science, I'll slightly change the topic. I will say modern science and nuclear medicine. This is what probably I understood from this book. Because if you leave the part oncology, the rest I know, because I'm a nuclear physicist. And in this, I don't want to take much of your time because you are waiting for an oration, wonderful oration lecture. But let me complete this saying that nuclear medicine, you know, with the radiation, typically radiation ideally massless particle. There should not be mass. Electromagnetic radiation, what I told, radio wave, gamma, X-ray, whatever you do. Fortunately, you are using more dealing with X-rays and gamma rays in the radiation oncology. But there are also radiation comes from charged particles. You cannot see them. These are fundamental particles. Even then we call them radiation because so tiny. Alpha, beta, gamma, proton, electron, neutron. These are all fundamental particles. And as far as their size and mass is concerned, you can consider them as a radiation. And this is what oncology deals with. While it is imaging, identifying, or doing a treatment. So modern nuclear medicine, if you see in one word, it has gone a long way. But what is the future and which science can help? I say that nuclear medicine going to be theranostic in future. That is probably the future is. Theranostic means not only will image it, at the same time we'll be making the treatment also. How it is possible, then you have to ask suitable, in order to have a nuclear medicine, you have to have a right radioisotopes. And isotopes, you know many. Lutetium, you all know, lutetium dotatate or lutetium PSMA. It is one isotope which is a game changer in prostate cancer treatment. You all know more than me. But it is a very small, in the tip of iceberg. There are much more we do not know yet to be discovered. Nature has given a lot of us, lot of things. Cancer is a curse, but radiation is a boon. Because people are afraid of radiation, you have to be, but radiation is also boon. Certain quantity, certain amount can become a beneficial as well. I won't discuss this, but what I want to say today, a couple of days back, recently you must have heard that, well, there is a negotiation with US and Ukraine war to stop it. And US in turn wants to acquire mines of, in Ukraine, it is called rare earth elements. You must have heard they are making a duel to take out the rare earth element. That may be the starting point to you. You know what is the rare earth elements? You must have studied in chemistry. Periodic table. It starts from hydrogen, helium, beryllium, boron, carbon, like that it goes. And it goes increasing order of the mass number, what we call atomic number, 1, 2, 3, 4, 5. I don't know how many of you have realized when you reach 56 barium, after 56 to the right, next one, there will be just a box. And suddenly it will start from 72, 72, 73, 74. I don't know whether you have remembered it. In this box, 15s are there. 57 to 71 in one box. They are called rare earth elements. They are rare. They are not rare because since it is coming in one group, physical and chemical properties are nearly identical. So very difficult to separate them. And we have this knowledge. Because of the Department of Atomic Energy, fortunately, we started searching them in the sea beach sands. We are looking for a particular minerals called monazites. It gives radiation, all of you know, but it doesn't give radiation because of it contains all rare earth elements. But radiation is not because of rare earth element. It also contains thorium and uranium. And that was our game. We are searching for it. We have a mastery of taking out monazite, separating the rare earth elements, and taking out the thorium, uranium, which is radioactive for our purpose. Now, today people are talking about extracting radioactive elements, very difficult because being the same chemistry, similar chemistry, difficult to processing, but we have the technology. But unfortunately, we are not very strong having all types of rare earth in India. We are searching it, we may get it. Why it is important? Lutetium you may be using. Do you know it is coming within this 15 only? Separation is extremely difficult. Lutetium, natural lutetium, you can get it. And there is an element called 176 isotope. Very low. We have a technique to enrich it. Recently in BRC, you take a natural, normal lutetium. By putting the laser isotope, you can select the mass you want. I want 76. 76 can be taken out. Put into a reactor which gives neutron. 76 becomes 77. Then it becomes a beta emitter and make your nuclear medicine, DOTAs or PSMA. And this is the thing modern science has gone. Same reactor which you want to do for power production, the neutron becomes a tool to convert certain elements into the nucleides, radionucleides, which one becomes a medicine later on. Lutetium is a radioactive elements, rare earth elements. you may be using without knowing where it is in the periodic table. It is hidden. But it is a beta emitter. But then you are not very happy with the beta emitter. You want a heavier one. Like gamma also you are not satisfied, you are imaging. And positron, a new creation, we appreciate it because it is a very good PET-CT emission. It is a very good imaging device. Positron emitters we have developed. Oxygen 18, we use oxygen 18 in a cyclotron, and you produce every day FDG, fluorodeoxyglucose injection. But you know how it comes from? Oxygen 18 is very rare. In the water, H2O is predominantly 16, but 18% is 0.2%. And have you ever thought how this oxygen, you should have a water rich with oxygen 18, put a proton in the machine, it will become a fluorine 18, and then story goes, FDG comes. But oxygen 18, if you know, we are all importing in India today. We don't have this manufacturing. But we have, fortunately, because of our nuclear program, reactors need heavy water. It drinks heavy water, not water. And heavy water is the H2O, D2O. And we have enough heavy water. Heavy water is more rich with oxygen 18 than water. And now we have a technique. Recently, heavy water boat has separated oxygen 18, 10 gram, around, and they can go in a year with this setup 10 kg. And we have now the oxygen 18 also. And we are going to set up a plant to produce hundreds kg of oxygen 18, which will not only fulfill the requirements of the country, probably will be able to export it also. A raw material for anything. But then before I go, I will also like to mention here what happened in oxygen 18 and fluorine 18. It is a beta plus emitter. It doesn't emit electron. It emits the brother of electron, positron. In modern language, we call it the antiparticle of electron. But for common man, it is so common that we just say the positron emitter, E plus. And when it goes through in the medium, like a tumor tissue drinks more FDG than glucose than the normal tissue. That's why this fluorine 18 get accumulated in a tumor cell and emits positron. Positron can immediately annihilate with electron. Electrons are many. And a gamma rays come, 2 gamma rays comes out. So you can pinpoint the point where it is come. This is the principle. I don't have to explain it. What I want to tell here is, positron cannot annihilate. The moment it emits, it comes with an energy. It cannot immediately annihilate. It has to go many scattering. It has to lose energy, come to 0. Then only it annihilates. And how many of you remember that our great nation builder and father of the atomic energy, Homi Jahangir Bhabha, is a great scientist before you came to India, before the World War happened. And he was a scientist of highest caliber. And he's known, he gave a theory. He gave a theory that E plus theory, that positron theory. When positron moves in a path, what is the mechanism? It will lose its energy. It is called positron scattering. And people know it is Bhabha scattering. And this, we don't realize today, but before this FDG positron comes to a rest, it goes many Bhabha scattering before it becomes 0. This is the science we are proud of. It is known Bhabha scattering and very useful scattering in fundamental physics. Slightly deviation, I was telling that rare earth elements, why I'm talking about, that we need to go beyond alpha, beta, gamma, beta and gamma. We have to produce alpha. Because you know the LET of alpha is a high value LET, it has a high RV factor. So people are now looking, nuclear medicine has to be treated with alphas now. That is everybody want. We have actinium, it has to be produced, not available. It is a actinides series. Radium also people use, but they are not that good because even though they give alpha, the daughter products are also alpha emitting, so that you cannot have a pinpoint precise treatment. But then there are an element called terbium. Again, it is a rare earth element, sits within the 15, terbium. If I can extract it, and one isotope of terbium, 154 or 55, I don't remember, it is an alpha emitter. Not only that, it also beta plus emitter. Now imagine what will happen. If you can get this terbium and make a nuclear medicine, suitable medicine, target wherever it had to go, then by that time it goes to the tumor site, it will just create an alpha particle. and also a beta plus particle, positron. Positron will give you the annihilation and it will give you the imaging, exactly where the tumor is. And alpha precisely kill the cells. Alpha is much more powerful than electron or gamma. A less dose being discussed, you can do the kill the cell and only healthy tissue can. These are the paradigm shift in nuclear medicine. Science has to come, technology is to come, and then this is how things are going it. What are science today? Basic science even. I'm a nuclear physicist. These are what I talked about nuclear science. But then it is not going to be a science alone. Probably it will convert into the technology. And the technology will enter into the medicines, everything. It is going to be a lifesaver. This is what is science today. It is going to the technology tomorrow. Coming back to one more line that we are also talking about particle radiation, where proton therapy is one of them. Dr. Laskar is here somewhere. And okay, we tried our best to build a machine for multi-ion therapy. Did not succeed. We did not succeed. In fact, when I joined Bhabha Atomic Research in 19, Dr. Laskar was moving with a project with having a money of 1,500 crore. And that was my question to you: have the money, who will build? He says, Japanese will give us. That time I did not argue with him. Today also I'm asking him, how can Japanese give me? Nobody has built it yet. And you have to make it. The philosophy is, proton is a wonderful machine. Like gammas and other, by the time you go to the tumor tissue, it will start affecting the healthy tissue on the path also, which is undesirable. But proton has a beauty that it doesn't lose until it reaches its range. So in the path, it will very little, it will lose it. So it loses at the end, what I will call Bragg peak. Around that point, it deposit all the energy. So the target treatment you can do with heavy ions, you only adjust your energy of the particle and see where you want to target. And once they reaches the range, it will deposit all the energy. Proton, up to proton is good, but there are beyond proton. More the heavier, this path is more clean. Their Bragg peak will be more clear if you use heavier than proton, like carbon. You can use helium, neon. In fact, advantage is if such type of beam you can get an accelerate. This is called multi-ion. Imagine instead of carbon, I went carbon 11. Carbon 11 is a beta plus emitter. If you do that, you are succeeding. Carbon will not have a better Bragg peak. So healthy cell will not be affected unless it goes to the tumor cell. But carbon not only will give large LED, but carbon 11 will give beta plus also. Same thing. You can do annihilation, you can do imaging with a beta plus, and you can do the killing with the carbon. So these are the effect of the multi-ions, but we have not succeeded yet. Probably future is this only. Neon, I was told that neon not only kills, it suppresses the oxygen production at that region. So these are the something we have to study it. And this is how one direction multi-ion therapy may move, but then it is very expensive. Building an accelerator is always expensive. So it is people criticize us that therapy with proton or multi-ion is a rich man's therapy. Poor man cannot afford it. Well, it may be true, because unless the technology of the accelerator became that cheap, this type of treatment will be very, very expensive. But I have shared my thought with at Attract with the doctors. There is another novel methods which has to be made popular. That is called boron neutron capture therapy. Neutron, if you can produce a neutron, easier to produce. Neutron can penetrate. But then in the tumor cell, if you can develop a nuclear medicine where this boron can get implanted at the tumor site, neutron and boron, they react very nicely, producing alpha and lithium. And in fact, Japan and other people are trying. If you can develop a neutron machine, high energy, neutron can penetrate, but patient can just sit in front of it and you put the boron wherever you have to implant, target. Neutron will pass through, but in the place where there is a tumor, neutron will interact with the boron. Boron 10 has higher neutron absorption. So it will absorb and produce lithium and alpha. Probably effective killing is much stronger. If you can BNCT, you can do it. So BNCT will be definitely cheaper than ion therapy. And I say to the people, BNCT will be a poor man's proton therapy, which rich people can also use. But then it is not very popular. Dr. Gupta says that neck and head cancer treatment, people are using BNCT. But then comparing the cost of the machine and techniques, all those things, it has not become popular. But probably it can be made popular. Reactor, neutron production, we know how to do. DD fusion, we know. We can have a compact device to produce neutron. And this technology can be, science can be developed, biology can be developed. So that probably, I feel personally, BNCT will be a better therapy treatment than even proton or heavy ion treatment, which is going to definitely costly. Anyway, these are the directions. It once, not that it is perfected yet, but these are the futures. That's all my knowledge about oncology. Thank you very much, and wish you all the best.
Thank you so much, Dr. Mohanty, for that masterful talk and for, if I may use the word, for radiating wisdom, humor, and encouragement to all of us and sharing your insights into what the future is in store for us. As we now prepare for the oration, I would also like to thank all the esteemed dignitaries on stage for gracing this occasion. Yeah, they are arranged. Yeah. Yes, sir. And now, ladies and gentlemen, we arrive at the much anticipated oration of the day. The topic of the oration, I would say, is very globally relevant in today's world, especially given the recent events in the West. I request Dr. Pramesh to introduce our esteemed orator, Professor Soumya Swaminathan.
Good afternoon, friends. It's a privilege to be part of this event and this session in particular, where we promised you two stellar speakers, but you actually got three for the price of two, courtesy Dr. Mohanty, who practically gave an oration by himself. privileged to introduce our main orator for the day, Dr. Soumya Swaminathan, who, cliched though it might seem, practically needs no introduction to this group. However, she is currently the chairperson of the MS Swaminathan Research Foundation based out of Chennai, doing a lot of work in tribal areas in India, looking at the effects of climate change with air pollution and several other areas of public health, which are far removed from her primary experience of being a pediatrician and a TB researcher. Prior to this, as all of you know, she was the first chief scientist of the World Health Organization, going through a very stormy period in the world when we had the COVID-19 pandemic. And prior to that, she was the Director General of the Indian Council of Medical Research and the Secretary, Department of Health Research. But primarily where her heart lies is in tuberculosis research, which even now she is very closely involved in. You did hear about some parts of her early career from Gaurav, where she topped in medicine at the Armed Forces Medical College initially, and then did her pediatrics from the All India Institute of Medical Sciences in New Delhi. Subsequent to that, she joined the Children's Hospital in Los Angeles at the Keck School of Medicine, where she took a postdoctoral fellowship in neonatology and pediatric pulmonology, which is where her passion for clinical research began. She then went on to be a research fellow at the Department of Pediatric Respiratory Diseases at the University of Leicester in the UK. And over the last 30 to 40 years, she's been well known as a pediatrician and globally known clinical scientist for research in tuberculosis and HIV. She's a fellow of the US National Academy of Medicine, the Academy of Medical Sciences in the UK, and practically every major science academy in India. She also holds honorary doctorates from very prestigious institutions, including the Karolinska Institute, the EPFL, Lausanne, and the McGill University. And this is her receiving the honorary doctorate at McGill University. More recently, she gave the very prestigious pump handle lecture. So this is the her standing next to the actual pump handle, which is one of the most prestigious lectures in the UK. Her early career, as I said, started in tuberculosis research, and this is her working a couple of decades back at the Tuberculosis Institute, which is also an ICMR institute in Chennai. And I don't think she quite signed up for this when she took over as the Director General of the ICMR. And for those of you who aspire for administrative posts, I think this is something that you need to be prepared for. But she was a Director General of the ICMR with a bit of a difference. I haven't seen too many directors of the ICMR actually going into primary health centers, working and looking at research on the field. And this is her in one of her visits in one of those areas of research. Subsequent to that, she went to Geneva, where she thought she'd have a nice holiday at the World Health Organization. This is her with some of her friends at Geneva and going through some of her initial exploration of the city. And very soon COVID hit, and you can see the lines on her face, thanks to what we went through. And this is something that all of us are familiar with, the biweekly calls that the World Health Organization organized to disseminate information about COVID and share best practices. And while we might criticize the WHO for many things that they've done, I think it is important to recognize the fact that for more than a year, they had press conferences on every single day, giving and sharing information, the best knowledge that was available in a very rapidly evolving phase, practically every single day. And she herself was involved in these twice a week. And again, you can see the impact of COVID-19 on her face. Thankfully, it all came to an end. And before she actually left left Geneva, she had the opportunity to travel. She's a great nature lover. And many of you might not know that she was an accidental doctor. She always wanted to be a veterinarian because she loved animals. and just took up medicine just because everyone else close to her took up medicine. But this is one of her other passions where she explores nature in its beauty. After that is when she's currently in her current role as the chairperson of the MS Swaminathan Research Foundation, which incidentally, it's opportune that she's our orator today because the MS Swaminathan Research Foundation is turns 100 now, or it's in honor of Professor Swaminathan, who many of you know as the father of the Green Revolution in India, someone who has revolutionized the entire aspect of food and availability of food. And even today, much of her work now deals with food and the availability of safe practices. So this was her when she was a little girl. I struggled to identify her, so I actually had to ask her which one of these she was. She's the eldest of three daughters that Dr. M.S. Swaminathan had. And you can see her on the right extreme of this. That's her. And I think, as I said before, she topped in school. You can see that little bit of a nerdy look that comes across very clearly in this photograph. And being the daughter of someone like Professor Swaminathan cannot be easy. We all know that Abhishek Bachchan and Mick Schumacher have a tough life to lead. But in spite of that, she and her sisters, one of her sisters, Madhura Swaminathan, a professor of economics at the Indian Statistical Institute in Bangalore. And the third sibling is Nitya Rao, a senior lecturer in gender analysis in international development. Clearly, not an underperforming family by any stretch of imagination. This is a more recent photograph of the three sisters with Professor Swaminathan, very recent, just before he passed away. And that's the rest of the family. This is Ajit, her husband, who's an orthopedic surgeon. These are his parents, and this is Akshay, her son, and Shreya, her elder daughter. And again, just to illustrate that they're not an underperforming family, Shreya now is a marine biologist, and Akshay, a cybersecurity engineer. So it's an interesting story how they met, and I kind of had to pry this out of her, and it's a really interesting story. So they were both medical students at the Armed Forces Medical College, and they went on a trek to a nearby. So a group of medical students went on a trek to a nearby hill station called Kandala, and this young lady got lost on the trek. And a very smart orthopedician, I know what you're all thinking, orthopedician and smart, decided to get lost in the same trek. And to cut a long story short, that was the beginning of a lifelong relationship. So this is a more recent picture of our marine biologist, Shreya, with her two parents. I put this up as the last picture because it's a really powerful picture. It's not just a picture of a father and a daughter. The expression on the faces is something that's so upbeat, something that we desperately need in the world of today, where we are surrounded by events which are not so happy, but also looking forward, looking optimistic. And I think that's something that we can take as a lesson from her and her father's existence. If you were to narrow her down, and what I truly admire about her as a person, it's been this ability to rapidly adapt from being a pediatrician to becoming a tuberculosis researcher to taking over as the director of the ICMR, then as a deputy director general of the WHO, subsequently to serve as the first chief scientist of the WHO, and then come back and do something that's really impactful on the ground as the chairperson of the MS Swaminathan Research Foundation, and moving through these roles, which are very diverse, completely different from each other, with effortless ease and not being trapped by the trappings of position that she has held. And actually, what she did yesterday was spend time in the tribal regions of Odisha. I didn't even know this place existed. There's this place called Jaipur. It's not Jaipur. It is Jeypore. And to travel from there to Bhubaneswar and from Bhubaneswar to Mumbai to be part of this meeting, she had to fly in a 7-seater Cessna from Jaipur to Bhubaneswar. And many times those Cessnas actually don't work. So uh, she landed at just around midnight, has come for this oration. Now we'll finish this oration, probably not have lunch, and go to another talk that she's giving at the Somaya University, and then heading back to Chennai, all in less than 18 hours. So if I could do that 10 years back, I'd be a happy man. So I do realize that this is the only thing standing between you and the oration, something that's a very awaited event. And I'll request Dr. Soumya Swaminathan to deliver the EBM 25 oration on achieving equity in health research.
Yes, see more of you. So thank you so much, Dr. Pramesh. And very good afternoon, Dr. Gupta, Dr. Mohanty. It's been wonderful to come back here after many, many years. I have very fond memories of coming here before as DG ICMR, and I'm always inspired as well as humbled when I come here to see the kind of work, that you do, the number of people that you serve, and also it's wonderful to see how this the TMC has grown, that the cancer, it's now a family of hospitals across India, and all the directors are here, and I was delighted to get a chance to meet all of them. And of course, it's a short time to really understand and appreciate everything that's going on. But I think that the fact that you have this conference every year, you've had it for over 20 years, this is really important. I think that the whole area of science, data, evidence that should drive our policies is something that we should not underestimate, and something that I'm so glad that this institution has been doing for many years and continues to commit itself to. And I know that during COVID as well, Dr. Pramesh and many of you were involved, even though it's nothing to do with cancer. But of course, during the pandemic, everybody, regardless of what they were working on, used their skills and their experience and their expertise to try and help us get out of the pandemic. And so many of you were involved in developing evidence-based guidelines for COVID. So it's really the approach, the principles that are important. And today it could be cancer. And I think, as Dr. Mohanty very beautifully described, how science, fundamental science, then ultimately translates itself into technologies that benefit people. And that is why countries that have invested heavily in fundamental science are the ones that can really hope to become super economies. And in fact, I have an op-ed today in the Hindustan Times that talks about the need for us to invest both in science, but also in scientists. And by scientists, I refer to a very broad range of people, not narrow people with white coats in labs, but I'm also talking about scientists out in the field, farmers, fisherwomen, and men, who have not only traditional wisdom, but are so quick to pick up modern technologies and use them. And that is the power of science. When you see it being used for societal good, and you see it transforming people's lives, very much as cancer treatments have done in the recent past, but in many other areas. And those kind of discoveries will happen only with investment, which is sustained, which is a significant percentage of our GDP, and which begins from school onwards, teaching children the wonder of science and inculcating in them, an interest. And we also work with school children. We have a program to bring government school children into the foundation to spend about 2 weeks really learning hands-on. And you can see how excited they become when they see, for example, a culture that they have set up the previous night, and the next morning they come back and they put it under the microscope and they can actually see colonies. This is the first time that these children would have seen something like that. And it makes science actually come alive for them. So thank you very much for this invitation. It's indeed a great honor to be here. And I was extremely thankful for the pilot yesterday of the Cessna plane who did fly us successfully from Jaipur to Bhubaneswar so that I could catch my flight to Mumbai. And in fact, that again shows us today how much we've advanced. Could not dream ever of having a flight to that small little place in the middle of a tribal district till a few years ago when, thanks to our expansion of air connectivity and the UDAN scheme and so on, we now have connectivity to places, and it's made life extremely convenient. So I thought I will, of course, not try and talk about cancer at all to this group because that would be very foolish. So I will talk about something that, I have thought about over the last few years. But first, I would like to pay tribute to Mr. Tata and, in fact, the whole Tata group that had the foresight and the wisdom to set up institutions like this, like the Indian Institute of Science and many others in India, and to continue to support science in a very big way. I did meet Mr. Tata a few weeks before he passed away, and was his usual very affectionate and interested in what I was telling him about. He was, of course, very passionate about cancer, but also about nutrition and TB. Those were his other two great passions. And, he was driven by wanting to do something to improve the situation in India. And we are really going to miss him. Now, if you look at, what the World Economic Forum talks about, these global threats, they are rapidly escalating. As you see, I mean, every time you open the newspaper or put on the television, there is some new horror that one is confronted with. But if you really look at the short and the medium term risks, you can look at these under about 5 different heads. There are the big economic shocks, of course, like the economic downturn and, various bubbles that burst. But you can also see in green the environmental risks, which are the biodiversity loss, the climate change, the extreme weather events, and pollution, which are threatening us today. And then in red, you see the geopolitical, and in orange, the societal threats, like armed conflicts, confrontations, and so on. And then the technological, which is also coming here as a threat. And I think Dr. Mohanty also made this point that, advances in science and technology, of course, can be used for good, but unfortunately, they can also be used to harm. And things like using artificial intelligence, I see at least 10 or 15 AI-generated videos on my X feed every day, which are completely nonsense. It's just making people say things that they never said. So we have to be extremely careful now when we read or hear of something to know whether is it a fact or is it just made up. Cybersecurity, technology power concentration in a few hands, particularly if it's in the hands of big corporate, is not a good thing. And every new technology, since the time that man invented fire or discovered fire, fire can, of course, without fire, where would we be today? But we know it's harm. So every technology, and when I was at WHO, we were trying to look at what are the technologies coming down the line, particularly for health, that we need to be looking at and promoting research, but in a manner where the ethical and regulatory frameworks are also well developed. So whether it's gene editing, and particularly when we talk about germline gene editing, where, of course, right now there's a moratorium globally, but somatic gene editing today has led to cures for things like sickle cell disease and thalassemia, things which we could not imagine that we would be able to cure. And at the same time, there's the famous case of a Chinese scientist who used germline gene editing in a twins to edit out the receptor for HIV, because those children would then in the future be not be ever able to get HIV because he's removed the receptor. But what else is that going to do to that person's immune system? And moreover, once you've edited the germline genes, then it's going to be passed on through generations. You can't stop it. You can't reverse it. So this is why it created such a huge global outcry. And even people like Jennifer Doudna, who won the Nobel Prize for the discovery of the CRISPR system for gene editing, she talks about how we need to be careful. So we need these, and the artificial intelligence is the other big one, of course, where there's a lot of global discussion as well on what should be some of the ethical and regulatory frameworks within which AI can be used. But again, the geopolitical tensions today are making it very difficult for the world to come to some of these agreements. So I think the threats to health and in fact to peace, stability, economic progress are very clear and are becoming more and more intertwined. And of course, pandemics, COVID being one, was one of those which added to people's distress. Now, I want to start by describing, we use the word equity very often, we use the word equality very often, but what's the difference between equity and equality? And I once saw a cartoon which made this very, very clear to me. So equality is you treat everybody the same, right? It doesn't matter what your background is or where you've come from. So let's say you have an apple tree and there are children trying to pluck the apples from the tree. You have a mix of children, some are short, some are tall. You give everyone the same stool to stand on. And so the taller children, of course, then have an advantage of picking the apples. Equity, on the other hand, is when you purposefully focus on those who would otherwise have been left behind or disadvantaged and give them some extra support. So in this case, you would have stools of different heights and you would give the shortest children the tallest stools to stand on so that then they have the same chance as the taller children of being able to pluck the apples from the tree. So I think it's very important to understand this difference between equity and equality. They are not the same thing. And so when I talk about equity, it's about historic injustices, marginalization, of course, the colonization that all countries, so many countries in the global south faced, and what that did, to our development. And then, of course, within countries also, we are not a homogeneous population. Of course, some of us are much more privileged than others in terms of access to education, resources, housing, financing, and so on. So my talk is a little bit on the global aspects of health research equity, but of course, you could immediately apply this, to a more national context as well. So if we want equity in health research, I'll also show some data. It means that we need fair and just inclusion of low and middle income country and marginalized populations, right from the conception to the execution. The research priorities should be guided by the global and local burden and risk factors, not only from high-income countries, and decision-making should be shared. We can measure equity in health research, and there are agencies that do that globally, from who sets the agenda, who's setting the priorities, because that's where the financing is going to flow, where is the funding actually going, who participates in trials. For example, I've been involved in many discussions about the involvement of pregnant women or lactating women and children in clinical trials. And all those of you who do clinical trials, of course, are aware that invariably, automatically, we put it in the exclusion criteria. Pregnant women, lactating women, children excluded. What does that do? Well, it delays access to those otherwise life-saving therapies. And I was very sad that the same thing happened during COVID, that even though we did have data that COVID vaccines did not cause harm, of course, these data took time, right? And vaccines were getting rolled out very rapidly. But many countries actually did not include pregnant women in the vaccination campaigns till much, much later. And we then realized later that COVID was more severe in pregnant women, and a lot of them actually ended up dying. So whether it's tuberculosis or I suppose the same in cancer, we have to think carefully that are we doing more good or harm by actually excluding these groups from trials. Similarly, phase 1 studies are usually done in men, and we know the metabolism of men and women is different. Similarly, children are not small adults. Their metabolism is different. And therefore, these drugs, especially the new drugs, have to be tried, in these different populations. So who's participating? And then if you look at global leadership and authorship of papers, we will see how many are from LMICs, and then the accessibility of the outcomes and the data in terms of open access. And all those of us who publish know now that, it's a double-edged sword. Open access is good when you want to read, but if you want to publish, then there's also a huge cost associated with open access publication. So either way, people who are from low-income countries get disadvantaged. So we know that, this is from a long time ago, this data that 90% of preventable deaths occur in low and middle income countries, but only 10% of health research happens here, and less than 1% of that is in sub-Saharan Africa. There are skewed power relations. Very often the priorities are set by international funders. And also we'll see also some data that even if the research is done in low and middle income countries, they're led by researchers from the global north. In the area of genomics, for example, where there's been such amazing advances, a meta-analysis showed that only 0.16% of papers on cancer genomics came from Africa. And it's, again, thanks to COVID that I think genomics has got a big boost. And there are people in Africa now that are doing amazing work, and that are training African scientists in genomics, both in human genomics and in pathogen genomics. But I remember that when in February 2020, when we knew by then that SARS-CoV-2 was the virus that was causing COVID, there were only 2 labs in Africa, one in Senegal and one in South Africa, that could actually do whole genome sequencing and even PCR. And so the first thing that WHO did, one of the first things was to do rapid training and ensure that every country in Africa had at least one lab that could do this. So this is where, again, diagnostics plays such a big role in access to treatments. And again, about 37% of papers on LMIC problems had an LMIC first author. Many of the big research funding for health, of course, comes from the US, the UK, and Europe till very recently. Now, of course, we don't know what the NIH, what's going to happen, but their annual budget was about $40 billion. So by far the largest funder of health and medical research. But again, if you look at where those grants are going, a lot of these grants go to either universities, academia, or companies in high-income countries. And there are groups that are actually tracking the grants that go for diseases like TB and neglected tropical diseases. The US NIH grants for TB, for example, 93% of their budget went to US-based institutions, even though, of course, there's very little TB in the US. You can look at other data like participation in conferences, and the last few AIDS conferences that have been held in cities in Australia and Canada and all that. There's been a huge uproar because of the denial of visas to people, especially those coming from Africa. So again, it's an AIDS conference held in a high-income country, but people from Africa cannot attend it, both because they can't afford it, and secondly, because they didn't get visas. So in terms of actual funding for diseases like TB and HIV, just a comparison between COVID, that funding for COVID vaccines in 1 year completely overwhelms the combined funding. You can see that thin slice over there, which is TB and HIV vaccines, and out of the total funding, the blue actually went to COVID vaccines. This is data for 2021. And so generally high-income economies mobilize when the disease affects their citizens, and this further widens the inequality gap. So in India, I think our investments in research, R&D have been growing, particularly in some areas. And if you look at our publications also going up, you can see that India published 1.3 million papers between 2017 and 22, compared to China, 4.5 million, and US, 4.4 million. But it's not just the numbers, right? It's also the quality. So our citation, India's paper citation was 8.9 million, and China's citations were 45 million. And you also have a significant proportion, by the way, of papers with zero citations. So 30% of papers being published. So then one needs to think about quality, and I think we all know that in India we have centers of excellence, like the one we're in right now, which produce very high quality science and research. But you have a large number of institutions across the country, especially state colleges and universities, where the quality of research really is not up to the mark. And of course, now with the establishment of the Anusandhan National Research Fund, hopefully that will start improving. Again, the number of researchers, we have 260 per million people. China has 1,600 and the US has 4,500 researchers per million people. Our health research spending is only 0.9% of GDP, whereas the world average is 0.27% of GDP. So again, we need to, and ICMR DHR budget has been going up, but I think for a country like ours with such a big population and so many health issues, it's very difficult with a budget of 3,500 crores to address all of the health research needs of the country. So I hope that budget continues to go up. Now, we also have to look at, are we funding the right things? So when I was DG ICMR, for the first time, we came out with a state-level disease burden estimation of India, which actually showed for the first time to the policymakers, the disease burden was different in different parts of the country. It's not uniform. The southern states, which so-called more developed states, had a much higher prevalence of non-communicable diseases, whereas the northern states and central India suffered more from infectious diseases, maternal and child health, nutrition, and so on. So again, and the Northeast will have a very different set of, and now with climate change, we do have stresses like the heat stress in large parts. The IMD has already put out a warning saying this year from March to May, we're going to have a large number of heat days. And they have also mapped in the country which parts of the country are going to be impacted. Similarly, we have flood warnings, we have cyclone warnings, we have landslides. So a lot of these natural hazards are increasing, and we need better preparation. And of course, then there's pandemic preparedness. And I was part of a group that actually developed a document for the Niti Aayog on pandemic preparedness for India, learning the lessons from COVID and what do we need to do in the future. And we grouped it under 4 major boxes. One was on actually governance and financing. You know, we still have a Public Health Emergency Act, which is from 1897. And we have not the Epidemic Diseases Act. So we have advocated for a new Public Health Emergency Act, which, because the National Disaster Management Authority really perhaps is not the right authority to deal with these kind of biological threats to health. They did a good job during COVID, but we, I think, first of all, need a law and policies. Secondly, we need policies around data sharing, and how, because that again was felt to be a constraint, because we spoke to several of the people who were involved in the COVID response, including secretaries, to the different departments, and they felt that data was not flowing as well, and the data sharing part. So that is very important. Then the third, of course, is around R&D. And this whole concept of a 100-day response that, this time it took us about 320 odd days to have the first vaccine licensed for use, which itself was a great record, by the way. Nobody has developed the mumps vaccine was developed in 4 years, but otherwise, on an average, it takes 10 to 15 years minimum to get a vaccine from, initial, the candidate being developed and then taking it through to registration, licensing, and then, of course, access after that to the population can also take much longer. Look at HPV, look at hepatitis B. It took decades between the hepatitis B vaccine being available in high-income countries compared to other countries. So I think we have to also prepare ourselves. And we saw during COVID that every country was first looking after itself in a way that was quite natural. So, which means we have the capacity, we have the infrastructure, we have the resources. So the paper says that one should really have prioritization of pathogens. We know roughly how many viral families can actually cause disease in humans and which ones are the most likely to cause the next pandemic, right? So coronaviruses, certainly, we've had 3 so far, we could have more. And influenza viruses, we've known for a long time, the most likely to cause. And we're very worrying now the way that H5N1 is actually circulating and jumping across different species, including in mammals, big infections in the cattle farms in the US. So it's a matter of a mutation or two before it's able to transmit from human to human. That has not happened yet. Once that happens, that's the beginning of the next big outbreak. Hopefully will not turn into a pandemic. But pandemics are not, it's an if now. It's not a, it's a when. It's not an if. So it's a question of when will the next pandemic happen and are we prepared enough? So I think this whole idea of prototype vaccines, having diagnostics ready, today with genomics, we can actually very quickly plug and play. You can have not just on the mRNA platform, but other platforms as well. If you have, let's say you're working on a vaccine, that's how COVID vaccines got developed so fast, right? There were groups that were working on other coronaviruses like MERS and SARS-1. They had already got the viral vector or the mRNA platform was being used to develop for chikungunya and so on. They were able to take the spike protein sequence from SARS-CoV-2 when it was available on January 11th. And by the end of January, they were ready with a candidate vaccine to go into first animal and then into very quickly into human studies. So that doesn't happen unless you have prepared and unless you have invested for it. So the importance of that and also the importance of public and private sector collaboration. So we have very good examples in India. So I'll just quickly mention 3 of them. The Rotavac vaccine, of course, Dr. Bhan, as you all know, was one of the key people there. And I'm very lucky that not only is he from AFMC, but he was also my professor at the All India Institute of Medical Sciences. And I remember when I was doing my MD, he was working on isolating this particular strain of rotavirus from children with diarrhea. And then it was a fantastic example of international collaboration with NIH, Fogarty, Bharat Biotech, DBT, ICMR, all came together. And the result was a vaccine that was much more affordable than other vaccines available at that time. And now it's used globally to prevent rotavirus. Another example is kangaroo mother care, very different from a vaccine. This is an extremely simple kind of a strategy where you keep the newborn baby, a low birth weight baby, skin to skin contact with a parent. It doesn't have to be the mother. It could be the father. It could be a grandparent. These trials, again, done in India, first clinical trials and then followed by implementation research showed that 25% reduction in neonatal mortality in low birth weight babies could be achieved just by following this kangaroo mother care. It's now WHO policy. So I think it's about doing the right thing at the right time. It's not really about very expensive technologies always. And I think that's what TMC also does, right? It's affordable, but high quality care. And another example, cervical cancer screening that was mentioned by Dr. Gupta, where actually this TMC was the one that did the trials that showed what strategies work. Now, Pramesh showed this picture earlier, but you see, I now advise the ministry on tuberculosis elimination program. And one of the things I try to do is to visit the homes of people who have died of TB. And this was a tribal family in Wayanad district in Kerala. And this was the mother of this young woman of 25 years old who had died, leaving behind 2 young children, and the husband, of course, had left by then. And I was trying to find out what went wrong. Why did a young woman without any other comorbidities, except perhaps she must have been malnourished, I presume, and also might have been severely anemic, very common in this area for severe anemia. But apart from that, why a 25-year-old healthy woman should die of TB today, in this day and age, when we have diagnostics, we have treatment, everything is freely available through the government at the primary healthcare center level, and still we are not able to reach everyone who needs this. So ultimately, our research must also ensure that whatever new technologies and things we are developing are also reaching everyone. And that was the other big thing during COVID, was the access, equitable access to the therapeutics, vaccines, and diagnostics that we were developing. And that was, I think, one of the low points for me, or one of the failures of the global response, was the fact that so many people had to wait for such a long time to get vaccine. India did very well because we have our own companies manufacturing vaccines, and we did a really wonderful job of vaccinating our population. Luckily, we did not have much vaccine hesitancy also, but Africa was completely left behind. So I think we need, when we do research, also to think about access to the fruits of that research, and who are the people who should participate in the studies to ensure that everybody has access. We shouldn't have a group of people who later on we say, oh, we never studied them. So I've been a TB clinical trialist myself, and very automatically we'll write down exclusion criteria. And I remember when I joined the institute, the TB Research Institute, one of the exclusion criteria will be weight less than 30 kilograms. So automatically everybody is following. Now, what do you do later when you have many TB patients with weight less than 30 kilograms? Because you have not included them in the trials, you don't know what the adverse effects are and so on. So I think let's be more thoughtful about that right from the very beginning, and also thinking about post-trial access to language could be a barrier, economy could be a barrier, distance could be a barrier. So many people who get left out. So of course we need to progress towards greater equity. This is a picture taken at a dementia center, again set up by an NGO called SCARF in Chennai. They do amazing work. Again, one of the very neglected areas of research in our country, particularly community-based and home-based management of dementia. I have personal experience with dementia, so I know how difficult it is for the caregivers. So I, strengthening these kind of local institutions, even NGOs, small institutions who are trying to address these kind of issues. And we have excellent NGOs in mental health, at least in Tamil Nadu. So we're very lucky that way. We need to fund local institutions directly. Regional biobanks we need, and I know that this institution has fantastic biobanks, but we need many more. For example, companies that are developing, new diagnostics, or where do they go? How do they test their product if we don't have a biobank that can give them a well-characterized, this is what is happening for TB now. So many startups coming, but we're not able to compare apples and apples, because we're not able to tell them, go to this biobank and do your testing there. For AI, we'll have to do the same thing. Tomorrow, we want to use AI widely, let's say for cervical cancer diagnosis or for pathology of any of your tumors. We need to have that type of well-characterized image bank against which your AI algorithms can be tested, so that you can say, yes, this one has so much sensitivity and specificity against this one. Otherwise, it's each company doing their own studies, and we will never know whether they are actually delivering what we want them to deliver. Data equity is very important, and I don't want to spend too much time here, but really I think having good practices and guidelines for how you collect and store and share data. I think we need to share more data, because we collect a lot of data and then we don't use it. And that itself is unethical. And also we need to address the AI training bias. Many algorithms which are coming from the West, for example, are not going to be the best suited ones for us. So we need to train AI algorithms on our own data sets. And of course, we need to advocate to not only increase funding, but reform funding models, particularly, as I said, talking about global funding. So I'd like to end with a quote from my father, who, while he embraced new technologies, and of course, during the Green Revolution, it was all about using new technology, but it was always in partnership with the stakeholders. In this case, it was farmers as well as policymakers. And he used to describe it as a symphony orchestra. He said, if you want a revolution in something, it has to be a symphony orchestra. It cannot be one group of people or one person trying to do it. You need the scientists or technologists. You need the stakeholders, the participants, the people who are ultimately going to use the technology. And you need the policymakers and the politicians to support that type of research which we see today in our space program, in our atomic energy program, how we are actually advancing because of the political backing and support that we get. So he said that wisdom lies in combining the best of traditional wisdom as well as modern technologies. So with that, I'd like to end my oration once again. Thank you. Thank you very much.
Thank you so much, madam, for that remarkable oration, which gave us a bird's eye view on equity, on access, on research, and I think gave us a very crystal clear vision of what all of this is about. Privileged to have heard from you. And I would now request Dr. A.K. Mohanty and Dr. Sudeep Gupta to present the oration plaque and scroll. And I would also request Dr. Sudeep Gupta to read the oration plaque.
Check. Before we have the pleasant duty of handing over the plaque to Professor Swaminathan, I have the privilege of reading out your citation. We, the director and staff members of Tata Memorial Center, on the occasion of the 23rd annual meeting on evidence-based management of cancers, have the proud privilege and honor of conferring the Hospital Day Oration 2025 on Professor Soumya Swaminathan, in grateful appreciation of her learned discourse on achieving equity in health research. We note with a sense of immense pride that her scholarly presentation provides profound insight, makes a vital contribution to the existing wisdom, and illuminates a path towards the welfare of all humankind. We place on record this benevolent gesture of Professor Swaminathan.
A big thank you to all the dignitaries for what was definitely, I think, the highlight of the ABM. We now move on to another enriching segment, the keynote presentation. I would like to invite on stage Dr. Pramesh and Dr. Pankaj Chaturvedi to chair the session. I request Dr. Girish Chinnaswamy, Professor in Medical Oncology, to introduce our keynote speaker, Professor Mahesh Parmar.
Thanks, Akshay, and good afternoon, everybody. It's my honor to introduce Professor Mahesh Parmar, who is also fondly known as Max to many people around the world, to deliver the keynote lecture today at EBM 2025. Max is a professor of statistics and epidemiology, and he is presently director of 2 units at the University College London. He is director of the prestigious MRC Clinical Trials Unit, as well as the director of the Clinical Trials and Methodology Institute at the University College London. So over the last 3 decades, being in the MRC, Max has revolutionized how clinical trials are designed and conducted across the world, focusing mainly on improving the efficacy of the clinical trials so that scientific research could be translated to clinical practice in a much more faster way. And aptly so, his talk today is addressing how to use clinical trial methodology to deliver healthcare much faster. So Max, and needless to say, has hundreds and hundreds of publications. I don't even want to go through his H index, which I'm sure is very, very high, and the number of citations, etc. But a bulk of his research work is focused on transforming clinical trials, which has been adopted by investigators all over the world and significantly influenced policy as well as clinical practice. So at the MRC Clinical Trials Unit, his innovative trial designs have addressed many of the global problems, including infectious diseases, neurological disorders, as well as cancer. So this is about his clinical trials thing. Max has multifaceted personality. He actually conducts boot camps every day morning in the parks in London. And at Wanstead, where I used to stay before, he told me at the same park, Girish, I used to conduct boot camp, but you never came even once. But I did not know Max then at all. He also is and those of you coming to Credo next week, please come prepared. We do have painkillers and body sprays for all of you because Max is going to conduct the boot camp every day morning at the Credo workshop. Max is also an avid cricket lover, so we have a lot of discussion on cricket. And today's morning discussion was not at all good because England is out of the Champions Trophy. And Max was a bit disappointed. And this time I had the upper hand on the discussion. So I would like to invite Max to deliver the keynote lecture, How to Improve Health Faster by Transforming Clinical Trials. Over to you, Max.
Thank you. Well, that was, thank you very, very much, Girish. And I'd like to thank the organizers, particularly Girish, for inviting me to give this presentation today. Listening to this morning's presentations, I'm a bit daunted and honored to contribute on this stage. I actually visited TMH now more than 30 years ago. And I remember meeting Raj Badwa then, Dr. Raj Badwa then. We were a year or two younger then, of course. And to see the development, the changes, the quality, and the quality of the work and the quality of the discussion is just so impressive. So it's really good to see that change over that period of time. I've been asked to speak to you about improving health faster by transforming clinical trials. So I'll start my presentation now. So where we might start this discussion is to think a little bit about what we currently do. And if you think about what we currently do in trials is we ask the question, does this new intervention improve outcomes for this specific disease? And if you speak to people around the world, you speak particularly to companies, they say this process can take up to 20 years, cost up to some £2 billion, $2 billion. And of course, what we've done for many of our diseases, this model has failed. What we've got is little or no progress. And I've just given you some diseases that I'm aware of that we've made little or no progress in for decades. For those of you involved in oncology, there's a number of cancers there. But there are many other diseases like motor neuron disease, dementia, Parkinson's disease, psychosis, a whole host of diseases we've made little or no progress in improving outcomes for absolutely decades. And so that model that we have currently is not moving things along for a large number of our diseases. And if you look a little bit under the bonnet of this problem a bit more, well, the basic problem has been is not that we've been short of signals for new interventions for our diseases. In our phase 2 trials, of many phase 2 trials done around the world, we have signals of activity, and we have loads of them in the literature. What has typically then happened is those phase 2 signals have not translated into improvements in phase 3, into outcomes, clinical outcomes in the phase 3 trials. And actually, if you look at the literature, you'll find that across a wide range of diseases, most phase 3 trials do not show superiority of the new intervention over the old intervention. And added to that problem, so we're failing late in the day, added to that problem that the phase 3 trial, if you talk to industry, costs about 75% of the evaluation of a new intervention. So that's where all the money goes. And of course, those of us who do these things know that they are much harder to do. They cost many millions of pounds or hundreds of millions of pounds if you're working with industry. You have many hundreds of individuals or participants in the study, or sometimes many thousands, and many sites, many multi-site, and many years. And often these are not just multi-site, multi-country as well. So these are big things to do. And a good example, I'll take you out of those who are on the cancer patch, I'll take you out of your cancer comfort zone here, because you can learn a lot from other diseases. I'll take the example of Parkinson's disease. This is a disease that's increasing worldwide, and we know some of the symptoms of Parkinson's disease. Horrible disease. And what I'm showing you here is a graphic which shows you in the brown boxes the phase 2 trials, the dots taking you across time, and the yellow box is showing you the phase 3 trials. So many phase 2 trials showing you signals of activity. Subsequently, at a period of time after that, the phase 3 trial has been done, and we've failed to show that the new intervention is better than the old. And we know that we've got only symptomatic treatments for Parkinson's disease. There are no disease-modifying therapies at all for Parkinson's disease, despite decades of research and absolutely billions of pounds and dollars being spent in that area. So how can we change our thinking in this area? Well, actually, you can do this really quite simply. If you change the thinking from the question, just change the question that we're asking. Does this specific, the question we currently ask is, does this specific intervention improve outcomes for this disease? That's what the phase 3 trial does. If we change that question to, how do we improve outcomes for this disease as quickly as possible, you come up with quite a different way of thinking. And if you think about it, actually the answer to that is really quite simple. If you're thinking of the clinical trial space, how do we improve outcomes as quickly as possible? Well, the first thing you do is you evaluate many interventions all in one protocol. Why wouldn't you do that? There's nothing magical about one intervention in one protocol at any given time. You focus on the phase 3 stage because that's where we keep failing, and that's where we spend all the money and all the time. We learn that in a number of our diseases, we acknowledge that many interventions will not succeed. We just know that. We just don't know which ones they're going to be. And we adapt the protocol as we go from data that's emerging from within the trial that you're doing within the protocol and from data that's emerging outside of the trial. Very simple concepts. And this leads to the concept of these platform protocols. We call them multi-arm, multi-stage platform trials, but there are also other types of platform protocols, basket trials, umbrella trials. But the principles are very simple. Evaluate many things, focus on the phase 3 stage, acknowledge that you're going to, many will fail, and adapt as we go. Very simple. And this is a schema just showing you that sort of idea. Traditional approach is shown at the top. We've got a control treatment against treatment A, control treatment, and then that fails, treatment A fails. We go on test treatment B against control, that fails, and then we go to control. This is what we've done for decades. You can see immediately that if you actually just put them all together and have treatment A, treatment B, treatment C, all starting at the same time with one control group in one protocol, and at a point in time when treatment D comes along to be evaluated, enter that into the same protocol. You can see that's just going to be more efficient. It's a barn door obvious that it's more efficient. And these are what we call multi-arm, multi-stage platform trials. These platform protocols are becoming increasingly common now. Many have been developed, and most of the methodology have been developed for phase 2 trials, and most of the methods and most of the application has been done in phase 3 trials, phase 2 trials rather. And that, my own view is that's largely going to be a waste of time. It will move us forward a little bit, but not much, because that's not where we've had the problem. And a huge number of methods have been developed. They'll have limited impact because the problem has been failure at phase 3, not failure at phase 2. We don't need to solve the phase 2 problem. And so the huge amount of work going on in that area is led and is going to improve things a bit, but not very much. We need a sea change. Also, it's useful to note that organizations like yourselves and ourselves in the UK, the MRC, and other academic organizations have a unique place in this research environment, because these platform trials are uniquely going to be done, almost uniquely, not completely, almost uniquely going to be done by academia, because industry at any given time for any given disease will only have one intervention that they're interested in. And research history shows this, experience shows this, that academia is uniquely placed to do these trials. And as I say, unfortunately, most applications have been phase 2. That's partly because we have a tendency in society as a whole to do things we can do rather than things we should be doing. And we can do the phase 2 trials. The phase 3 trials like these are really hard to do, but as I'll show you, the prize is huge. These sorts of designs are faster. They give you multiple treatments tested at the same time. They're cheaper. They're much more efficient. They facilitate recruitment. These trials that we're doing of these sorts of designs have been the fastest recruiting trials we've ever done, and we can discuss perhaps why that's the case. And they're flexible. We can drop and add treatments to these. And I'll give you, and just before I give you a specific example, just give you a little bit of a history component to this. The first formal MAMS platform trials in the modern era, and I'll pick up why that's in the modern era in a moment, is our trial in prostate cancer, which is STAMPEDE, which I'll give you a sense of in a moment. We launched the trial in 2005. The first discussion about adding arms was in 2007. More formally into a platform trial in 2010. And over time, we've added 5 new research arms. So 10 research arms have been evaluated. And I'll give you a bit more depth on that in a bit. At the same time, colleagues in the States at the Berry Group developed the I-SPY trial, but that was a randomized phase 2 platform looking at many new drugs in breast cancer, particularly, launched in 2010. So this sort of started around late 2007, 2008, 2009, around there in the UK and in the US. Let me give you an example of this to make it real for you. When we started this thinking in about 2000, there are about just over 1 million new prostate cancers worldwide. In 2005, when we started launching STAMPEDE, treatment for high-risk prostate cancer had not changed for 40 years. Nothing had changed. Hormone therapy was the standard of care, and it was, I mean, how could that have been? We'd spent 40, 50 years getting nowhere. Median survival was around 3 years for men with metastatic disease. So we launched this trial in prostate cancer, phase 3 platform trial, and we've evaluated in that trial a chemotherapy agent, a bisphosphonate, a COX-2 inhibitor, a radiotherapy, and the new androgen receptor signaling inhibitors, metformin, which is a repurposed drug, and estrogens, hormone replacement therapy that was used in women, used for men, estrogens in a wide variety of treatments. And that's an important part of the design of these things, because we know that most of our diseases, if you're going to treat them effectively, you're going to need combination treatment. So you test a wide variety of different interventions and then combine them should they be successful. What we've managed to do since 2005 to 2025 is do 10 phase 3 comparisons in 20 years in one protocol. A mixture of old drugs, new drugs, repurposed agents, and radiotherapy, all in the same protocol. So this is the trial, and it's quite simple to follow the schema here. Across the top, you've got the standard of care going from 2005 to 2025, and then the 10 research arms that we've added over time. The block shows you the accrual period. The dotted line shows you the follow-up period, and the black box at the end tells you the time point of analysis for that. And you can see there's all of the arms. We've started 5 research arms, added a further 5 research arms over time, and analyzed those at various times. So this slide summarizes here, let's have a look, the basic outcomes or outputs from this trial. We've randomized 12,000 participants in this trial over 120 hospitals. As a consequence of the results of Stampede and other trials which have reported, done the same comparisons, we've changed standard of care 5 times within the trial. So every time we get a result, positive, we change the standard of care, add that standard of care to the control arm and to the research arm. Survival now, as a consequence of Stampede and other trials which have contributed, we've improved survival for men with metastatic prostate cancer, a median of 3 years now to 7 years. And if you think of any other way you're going to try and do that in a 20-year period, evaluate 10 new different types of therapy, improve median survival from 3 to 7 years, you cannot think of another way you're going to do that in that period. It probably would have taken you 2 generations to have done all those comparisons. All the stopping and starting, all the initiation of all those protocols. And these things are very flexible. You can drop research arms, add research arms, change the control in research arms from using the data from both within and outside of the trial. You can actually even change the primary outcome measure and the sample size, etc. Very adaptive. This graph shows you on the left-hand side all the methodological publications that we've had out of this sort of design, because the design looks really quite simple, but actually underneath it, once you start opening up the methodological aspects, the methodology gets quite complex. It's very doable, but it gets complicated. But as I've shown you, the consequences of doing this sort of design are huge. And on the right-hand side, now, when I did this slide, more than 80 randomized trials have used this sort of design, particularly down here in the COVID era. A lot of the COVID trials use this sort of design. We're developing this sort of thinking going further. A number of you will be surgeons in this audience, and you'll know that wound infection after any type of surgery is one of the most common infections that you can get worldwide, of course, because there are so many surgical operations done. It's a major issue for the patient. It's a major issue for health services. And actually, we don't know very many ways of reducing wound infection rates. There's little progress been made. And the guidance on this is very, very poor. There's a poor evidence base. There's only generic guidance available on this. So what we've set up is this Rossini basket platform trial. It's multiple parallel, separately powered, multi-arm, multi-stage trials across specific body types, all in one protocol. For those who are more methodologically inclined, this is a basket factorial MAMS platform design. But you can see what it is here by this graphic here. So we've got 6 different types of surgery: breast, vascular, cardiac surgery, neurosurgery, amputations, and thoracic surgery. And a number of different interventions being evaluated in each of those surgical settings. Some of those interventions will be common across different surgical settings. And of course, at various points in time, if you find a successful intervention for one surgical setting, you might move it to another surgical setting. So this is just a very efficient way of doing lots of trials, evaluating lots of different interventions for different types of surgery, and learning both within each surgical intervention, but across surgical interventions. And also, for example, here, we know that the neurosurgery area will have probably fewer operations than, for example, the breast or the gynae one will. We know that. Well, can we use data from these more common surgical types to supplement the data for neurosurgery, because we'll never get enough patients in the neurosurgical setting. That doesn't mean to say we shouldn't investigate it, of course. Can we use those data to support that when the intervention is the same? The total sample size of this, we've designed this. Now, this trial is about to start. It's about 26,000 patients. But you can see over a period of next 5 to 10 years, we will make significant progress in this area with a little bit of a good wind and identifying appropriate interventions which might work. We're working, this sort of technology can be applied across a lot of areas. And I was just showing you the different areas that we're applying this sort of thinking in across many different diseases there that we're working on. It's not just us now working on this in this sort of design. The obvious question comes is, when should you prioritize such a strategy? And if you think about this superficially, you could argue that this could be when there's, these are big things. So you want lots of patients, you want short-term outcomes so you can make decisions quickly, and you want large funding pots. But actually, it's exactly the opposite. Because these things are much more efficient, these methodologies are much more efficient, if you haven't got many patients available, if the outcomes are long-term and you haven't got a huge amount of funding, this is exactly the sort of situation where you should be doing this at a time, because it's more efficient. And if you're going to make progress in our lifetimes in some of these diseases, you're going to have to change the way we think. So when should you prioritize such a strategy? Well, actually, I think those areas which really require this sort of different type of thinking is where progress has been slow. And we know some of those diseases. I've listed some for you there. You will have your own list there. When a number of interventions with different targets are available, because we know that if we're going to make significant progress for many of our diseases, it's going to require combination therapy, not single agent therapy. You've got to have enough patients and enough doctors and researchers on board. And of course, the funders have got to be on board, because the nature of the funding envelope you need for these things is different to the standard one. I'll just end to conclude by saying, in a range of diseases, we need to take a different approach. If we carry on doing what we've been doing for years, we'll keep getting the same answers and we'll keep making no or little progress. Part of this is planning for a 10 to 20-year horizon, focusing on the phase 3 evaluation. And this is a call for researchers and funders to change their strategies in a number of these diseases. And what we've found actually is key to this change has been the patient and public voice. Because my patient partner has asked me, when they've seen this sort of presentation, why don't you do all of your trials like this? And if anybody has a good answer to that question, I'd be very, very keen to hear it. And I'll stop there. Thank you very much.
That was simply a remarkable, very thought-provoking keynote. And I would say it was the perfect complement for the oration, where we talked of equity in healthcare, and now we are talking of pragmatism in healthcare, effectiveness, I would say a certain level of disruption, which is very much needed. So thank you so much for that. And to recognize the contribution, I invite Dr. Mohanty, Dr. Sudeep Gupta, Dr. Ramesh, and Dr. Chaturvedi to present the plaque to Professor Parmar. I would invite Dr. Mohanty and Dr. Sudeep Gupta to also come on stage to present the plaque. We approach the end of this prestigious session. I call upon Dr. Pramesh to deliver the vote of thanks.
Thank you, Akshay. I know I'm the only person standing between you and lunch, so I'll make this as quick and painless as possible. It's my honor to acknowledge the support that we've got from many people in the context of this conference and this session as well. First, I'd like to thank the Department of Atomic Energy, which has been a strong supporter for the Tata Memorial Center over the last 6+ decades of our existence. And I'll take this opportunity to thank Dr. Mohanty for finding the time to be part of this meeting as well. Thank you to Dr. Soumya as the main orator for today, who, as you know, went through a lot of difficulties during her travel reaching here, but fortunately was able to make it and deliver an outstanding oration on something that's extremely important in today's world, equity in healthcare. Thanks to Max, who, as usual, gave a very thought-provoking, stimulating talk on the importance of thinking differently in research and making research more efficient. I'd like to thank the two track teams, both from the infections as well as for the pediatric oncology, for putting together an excellent program. A lot of hard work has gone into it, and kudos to the team that worked behind the scenes to ensure that we had a very rich scientific program. I'm probably missing out on thanking a lot of people, but hypoglycemia is getting to me as much as it is for you. So thank you to everyone who was part of the organizing team, the clinical research secretariat team, Vikas, and the team which worked really hard over the last year to make sure that we delivered. To many of the people behind the scenes who put this together, the catering, the IT, the auditorium staff, and security who were instrumental. So for those of you who I have missed, forgive me, but thank you, and please join us for lunch.
In the morning, so welcome back post-lunch. In the morning, I was told that it would be good if I could cut down the total duration to about 15 minutes because we were going a bit late. But I think we have some time now, but I'll still go quick because I know we are going late. And my talk would be slightly different from what you have heard in the morning, the 4 talks on survivorship and what are the factors influencing them. What I would be focusing on is what is the impact of the technological changes that we have had in radiotherapy, and how has moving from photons or the X-ray based radiation therapy to protons made an impact in terms of disease control and also in terms of toxicity. So that's my mandate for the talk today. So that's photons to protons, optimizing radiotherapy for improved pediatric survivors. So what I'm going to do is I'm going to take you through what the big deal is about having protons and moving from photons to protons. How has the disease control and the toxicity profile changed? And do we really have an answer? And how do we go forward? So we've talked a lot about survival in childhood cancers, and this is a relatively recent publication that came in January this year. And as you can see in those graphs, the survivals for childhood cancers have actually improved over a period of time. In the late 70s, the general survival would be in the range of about 60-65%, whereas now we are talking about 80% survivals after the treatments that we have. And this has happened because of multiple things which I don't want to dwell on. But the important thing is that since you have long-term survivors, obviously, like we discussed in the morning, we would have children and young adults who would be having the side effects of treatment that they had when they were younger and when they were treated. If you look at the outcomes in terms of a disease, there are still some diseases which includes bone tumors, soft tissue tumors, liver tumors, where the outcomes are still in the range of about 60-65%, whereas in leukemias and lymphomas, we've reached cure rates of about 80-85%. So there is still something that we need to do so that our outcomes also improve in these tumors. Now, so this is an interesting study that was done some time back and published in the JCO, and we have the first author, fortunately, with us today here. What it generally showed is that the survival function, when you compare with the general population, after about 25 to 30 years, the causes of death in these young people who were treated for cancer, the causes of death is because of non-cancerous conditions rather than cancerous conditions. So, and these are mostly the toxicities related to the treatment that you gave them. So I'm going to, in my remaining slides, talk to you about, and some of you are non-radiation oncologists here, to tell you why proton therapy and why do we think proton therapy should have better survivorship, lesser toxicity compared to the X-ray therapy that we used earlier. As you can see in this cartoon, the broad difference between X-ray radiation therapy and proton therapy is that when you use X-ray radiation therapy, some amount of radiation goes beyond the tumor that you are actually treating, because of which your normal tissue surrounding the tumor also gets some amount of radiation. Whereas in protons, because of the physical characteristics of protons, the radiation actually stops just beyond the tumor. And because of that, the normal tissue that gets radiated becomes less, and thereby possibly resulting in a reduction in the late effects, acute and late effects of treatment. And this is visible in the cartoon that you can see here. So Because of your ability to reduce the dose to surrounding normal tissues, what are the clinical implications that we are talking about? Because the dose is more conformal, we are able to reduce non-target dose. If you're reducing non-target dose, you should theoretically be able to reduce both acute and late toxicities. If you are able to reduce the dose of normal tissues, you may be able to increase the dose to certain tumors that are resistant and thereby improve disease control and reduce toxicity. And you can also combine with chemotherapy, which is a combination that we use many times in pediatric tumors. So one of the main big advantages is reduction in toxicity and in the ability to combine chemotherapy and radiotherapy without increase in toxicity with proton therapy. Now, proton therapy has been there in the West for a long, long time. And so this data from the PTCOG, the Pediatric Radiation Oncology Society, and the European Proton Therapy Network, this just shows what is the current use of proton therapy and in which tumors do people use proton therapy. Now, I put that red box because those are the tumors that I am an expert in. I don't treat brain tumors. And my colleague, I can see Tejpal here, they are the neuro-oncology group, they treat brain tumors. So I'll concentrate my talk on these tumors, which I have put in the box, which is chondrosarcomas, chordomas, Ewing sarcomas, rhabdomyosarcomas, neuroblastomas, and Wilms tumor. So as you can see in chordomas and chondrosarcomas, which are resistant tumors, most of them in these countries would suggest treating with proton therapy. And what it really, the message that comes out is that those tumors where you require high doses of radiation do benefit with proton therapy. And you can see in this graph, and patients with Hodgkin's lymphoma still are treated with photons to an extent. Neuroblastomas and Wilms tumor are still treated with photons to an extent, whereas these resistant bone tumors are treated with proton therapy. So let's take the example of Ewing sarcoma and see what has the difference been between X-ray radiation therapy and proton therapy. And we're all looking for outcomes in terms of disease control and toxicity. This is early data from Mass General Hospital. Kids treated definitively with radiation therapy, 54 gray. And after a median follow-up of about 40 months, the local control rates are 88% that they reported in this study. So the local controls are extremely good with protons, although the follow-ups are short. Another study from the Paul Scherrer Institute, patients with non-resectable Ewing sarcoma, the pelvis and the axial skeleton treated with definitive radiotherapy with protons. The 5-year local control rate was 81% that has been reported by them. Now, this is very, very good by any standards. And when you look at the toxicity profile, late grade 3 toxicity was about 7%. I want you to remember these numbers when I'm talking about these numbers, the local controls and the toxicity that we are talking about. And then we will compare that with what we would see with photon radiotherapy. More data for pelvic tumors, pelvic Ewing sarcomas treated with definitive radiation therapy, 55 gray, standard dose of proton therapy. After a follow-up of about 4 to 5 years, local controls of 92%. We don't see these numbers even with surgery and post-operative radiotherapy in many of our centers here. So the local controls are extremely good. Again, I'm reiterating that because there is something probably happening in terms of biology. It's not only the conformality that we are talking about when we're talking protons. Again, this is more recent data published in 2022 from Florida, my good friend Danny Indelicato and his group. The same dose of radiation, 50 gray, 5-year local control of 92%. All the results that I have shown in protons till now is above 85 to 90%, and it is extremely good. The toxicities, we hardly see grade 3 toxicities in these patients. So toxicities are low, the local control rates are extremely high compared to what we see with photons. Again, this data from SN, Beate Zimmerman and her group treated chordomas, chondrosarcomas, 59 to 60 gray, which is not very high. And after a follow-up of about 3 to 4 years, the local control rates of 80%. So nothing is less than 80% with protons that they have published till now. And the toxicities, as you can see, grade 3 toxicities were seen in very, very few patients. This is another recent publication on protons for pelvic sarcomas and chest wall sarcomas, 4-year local control rates of 82%. The reason I'm showing you so many of these results is that there is one common thing, and that one common thing is that the local control rates are 80% and above. And I don't think I should not believe that they are true. They are true. This is again from University of Florida, local control rates of 96% with proton therapy. And we are not talking about, there were no second malignancies, although the duration of follow-up was short. People are also using proton as a preoperative treatment. This group in Birmingham, they're using for pelvic PNETs. And what they showed in the study, although small, is that when they used protons at pelvic as preoperative radiation therapy, the local failures were 0, vis-a-vis when they used photons, the local failure rates was 38%. So there was a huge difference in the local controls between photons and protons. So they are in Birmingham using preoperative proton therapy for many of their patients in Ewing sarcomas. Now, we had our own randomized trial. We didn't have protons at that point in time, so we thought of dose escalation. And when we escalated doses to 70 grade in non-resectable Ewing sarcomas, our local control rates were 76%. But even we did not see that many second malignancies. We had a median follow-up of almost about 7 years. So how do you compare proton versus photon in Ewing sarcomas? The local control rates seem to be slightly superior in protons, but there was reduced toxicity in patients who were treated with proton therapy. What about rhabdomyosarcoma? Majority of the rhabdomyosarcoma is in the pediatric, in the head and neck region, and we have many critical structures around that. And there have been multiple studies where they looked at dosimetry and the outcomes. Now, this is an example of where proton therapy was compared with intensity modulated photon therapy. And you can see the difference in the doses to contralateral globe, to the lens, to the retina. There was a huge reduction in the dose when you compared IMRT with proton beam therapy. But what they cautioned was that there was a risk of facial asymmetry because of the rapid follow-up of dose that you expect with protons. So there is definitely a benefit in terms of dose to the normal tissues that you would expect with protons. As you can see here, this is another study where they looked at the difference in the dose to non-target organs. The difference was in the range of 20 to 40% difference. That was a huge difference in the dose that goes to normal tissues when you compare photons versus protons in the head and neck region when you treated rhabdomyosarcoma. What about clinical outcomes? Now, this is a study where they looked at local controls with proton was 84%. It was slightly better than what was reported in the COG study, which was 77%. But what is more important is that the grade 3 toxicity was 11% in the patients who were treated with protons compared to 47% in the patients who were treated with photon radiotherapy. So theoretically, in terms of numbers, in terms of early outcomes, there is a clear benefit of protons when you compare with photons for rhabdomyosarcoma of the head and neck region. This is the same in this study too. There's a significant reduction in the dose to the normal tissues that you can expect with protons. And this is just a table showing the same thing which I mentioned. There's a slight, the disease controls is similar, but there's a slight improvement in the toxicity profile. What about more resistant tumors like osteosarcomas? Again, something is happening with protons. The local control rates are close to 70%. And this is what we see after we've done surgery and post-operative radiotherapy. And here you're getting it with definitive radiotherapy alone. And again, the same thing, the local control rates are slightly superior with protons compared to photons, the same outcomes. In chordoma, 81% local controls with standard doses of proton therapy, and you're able to reduce the toxicities to less than what you would see with photons. Our own outcomes, 75% local controls with photons. We didn't see second malignancies in our cohort of patients. And this was the same for osteosarcomas and chondrosarcomas also. The last few slides on retinoblastomas, the people have tried for organ conservation. And one thing that is important is that there were no second cancers reported in this cohort of patients that were treated at the Mass General Hospital with protons for retinoblastoma. Although very few patients would get protons now for retinoblastoma, but still, when indicated, it is of use. What about Hodgkin's lymphomas? And you've seen the differences in the portals that have evolved as we have evolved over the years. There's a significant reduction in the dose to the heart and other non-target organs that you can have with the use of proton therapy. And the similar thing has been reported in diseases like neuroblastomas and Wilms tumor. This is pictorially quite visible. The amount of dose that goes to the lung, the spill that spills over to the lungs is much less when you're using protons when you compare it with proton radiotherapy. I will go quickly over to the last part about second malignancies. Has this reduction in dose to the surrounding normal tissues or the low dose spill resulted in a reduction in second cancers with proton therapy when you compare? Now, this is data from Mass General Hospital. They had a matched pair analysis of 558 patients who were treated with protons compared with a database of patients who were treated with photons. If you look at the second malignancy rate, with protons, it was 5%. With X-rays, it was 7.5%. So there was not a huge difference in the outcomes, but there was still a trend towards reduction. And this profile would probably change with the new technology that we have and when we have long-term follow-ups in these patients. Similar outcomes were reported by this group from Japan. It's the same toxicity profile and second malignancies that you would see. I wanted to show you this database. This is a national cancer database of patients from 2004 to 2015. This was about 9 lakh patients that they looked at, both including children and adults, and they compared the outcomes in terms of second cancers between 3D conformal radiation therapy versus intensity modulated radiotherapy and compared with proton beam therapy. And this was the outcome, the cohorts, large cohorts, 1,51,000 patients in 3D CRT, 2,93,000 patients in IMRT, and almost 5,000 proton therapy. Look at the outcomes, comparative risk of second cancers. When you compare on your left-hand side of your screen, if you look at IMRT versus 3D CRT, not a huge difference. But when you look at proton versus IMRT, there was a clear benefit in all these diseases that you have seen. So there seems to be a benefit. We do not have a randomized clinical trial to tell you that, but these large group trials are showing that there is a benefit of using proton therapy. So how do we go ahead? Can we do randomized clinical trials? I know in our center that we have started now, we have 4 randomized clinical trials that have been already kind of submitted from neuro, from head and neck, from the pediatric group, we have submitted. So we have a few trials that we are going to run. But globally, when I ask this question, do we have a way to do a randomized trial? It would be very difficult to do a randomized clinical trial in protons today. And I also did discuss this with my good friend, Tom Merchant, and he feels it will be difficult to do randomized trials, but in children, but probably you could use models of your patients that were treated earlier to answer some questions. But what are people doing? This is one of the things that is currently ongoing. This is a pediatric proton and photon comparison cohort. And this was a study design that was published in 2023 in Advances in Radiation Oncology. This is a multi-center retrospective cohort to investigate subsequent cancers after pediatric radiation therapy. And here they're looking at, they're trying to match and see the differences between photons. They're looking at 10,000 patients treated with photons to compared with 10,000 patients who would be treated with protons. And the collection, and currently they are collecting the data, and they're going to look at dose volume statistics. This is not published data that you're going to compare. They're going to look at dose volume. And because of studies like this, I've also given it to one of my students to actually look at dose volume data to see how volumes and doses actually influence toxicity and second malignancies. I was fortunate to be part of this consensus report on the use of proton therapy. This was sometime back in 2016, and where we looked at which are the patients where would currently, based on the currently available data, recommend protons. And this was the outcome of the study, which was published in the Red Journal. Do we have ongoing randomized clinical trials addressing proton? There are very few, or actually none. And as you can see here, I've just enumerated these trials that are going on. This is from the Particle Therapy Cooperative Group, PTCOG. And hopefully in the next few years, we will have some results from these trials. So just to summarize, proton therapy results probably in similar or marginally superior outcomes in terms of disease control compared to photons. We could potentially reduce the dose of surrounding normal tissues, which could potentially reduce acute and late toxicity. We need to have long-term outcomes data. I showed you some of them. We need to have larger studies, and it'll be preferable if you have randomized clinical trials. Robust phase 3 data, randomized data is not available. We need to have more data in terms of quality of life and functional outcomes. There are certain uncertainties in proton therapy and particle therapy that needs to be answered in terms of the dosimetric robustness, the end of range RBE, the implication of the neutron contamination, implication of modern proton equipment, which uses a different technology compared to the scattering technology that was used earlier. And of course, it's a significantly expensive treatment, so it has to be available in a wider area in order to make and test the applicability of proton therapy in a wider group of patients. But I think, in my view, proton therapy is there to stay. With the data that we have available as of now, we will have more and more stronger data available as we accrue more patients. And we would look for studies like the one that is ongoing currently to answer some of the questions that has been there for a long, long time. So thank you very much. With that, I will stop. This is what our Proton Therapy Center looks like. We got 3 gantries. We've been operational since August 2023. We have treated more than 350 patients now. And right now, we are in a position where we are actually going to start off with these 3 or 4 randomized clinical trials. And hopefully, we'll be able to answer some of these questions in the near future. So thank you very much. And I'll be happy to take questions.
Thank you, Dr. Lashkar, for that comprehensive talk. For the want of time, we'll just move on to the next session. We have chairs here, Dr. Shailesh Kanvante, a senior pediatric oncologist from Dinanath Mangeshkar, Pune, and Dr. Nisha Iyer, she is from Surya Hospital, a pediatric oncologist as well. Over to you.
Okay, good afternoon, everybody. In the morning, we are having a pretty extensive discussion on what are the late effects in childhood cancer. And this session is going to focus on what are we going to do about prevention, surveillance, and intervention. So it's my great pleasure to invite Dr. Vasudev Bhatt for the next talk. Dr. Vasudev is the professor and head Department of Pediatric Oncology at Kasturba Medical College, Manipal. Dr. Bhatt, over to you.
Good afternoon, and at the outset, I would like to thank the organizers for calling me. So quickly, over the next 15 minutes, we'll go through this topic of chemoprotectants and what is the evidence to use it. Yes, so what we will be discussing is the relevant late effects in cancer survivors. We have heard a lot in the morning. What are chemoprotectants? Which late effects can actually be prevented by using them? What is actually the evidence that is available now? Where do we stand from a LMIC perspective and the future directions? So here you can see the list of the late effects, but there are certain late effects which can actually be prevented by, for example, cataract by eye shielding blocks during radiation. Similarly, for deafness, you monitor and you can use autoprotectants. Pulmonary fibrosis, you can always look at alternative regimens, lung shielding. Ventricular failure, again, look at cardiac functions, look at alternative regimens. Kidney diseases, you look at regimens which do not affect the kidney, and similarly infertility, transposition of gonads, and avoiding certain chemotherapy agents, etc. And I think as a pediatric oncologist, the most important part, the critical component while we plan the cancer-directed therapy is to prevent the late effects. So chemoprotectants, also called as rescue agents, are medications that limit host toxicity from the effects of chemotherapy. They can be natural or synthetic chemical compounds. Ideally, they should be non-toxic, and it should not add more side effects to the chemotherapy, which is already ongoing, and achieve high concentration at the target site to protect these tissues from injury. Most importantly, it should not have any anti-tumor effect. So some routinely used, it has got, we generally use this and we do not call it as chemoprotectants, but leucovorin, again, when we use with high-dose methotrexate, or mesna, when we use with ifosfamide and cyclophosphamide, are again types of chemoprotectants. But what I want to discuss here is about cisplatin-induced ototoxicity and anthracycline-induced cardiac dysfunction. And I'll be discussing more on the primary prevention, that is at the time of cancer therapy, rather than secondary prevention. So as we all know, cisplatin is used for many conditions, especially hepatoblastomas and for a lot of solid tumors. Cisplatin-induced ototoxicity is the dose-limiting side effect. It is bilateral, irreversible, and when it comes to a child, it hampers the speech, and that's why the cognition is affected, social development is affected. But again, cisplatin and ototoxicity depends upon what is the cumulative dose that is used, what are the concomitant nephrotoxic agents that are used, and whether the child is getting radiation like craniospinal irradiation. So basically, cisplatin crosses the blood endolymph barrier. It increases the the reactive oxygen species, which leads to apoptosis of hair cells and striae vascularis, thus leading to hearing loss. So there are a lot of otoprotectants which are available. The main ones include thiol compounds, the sodium thiosulfate, which has the sulfur binds to the platinum, and it's the only FDA-approved agent that is available. We would have heard about amifostin, again shows protection against ototoxicity, but has neurotoxicity as its own side effect, and it has actually tumor protection. That is the anti-tumor, it gives protection to the tumor as well in some of the studies. Other agents include N-acetylcysteine, aspirin, and D-methionine. So we will be discussing about sodium thiosulfate. It is basically an industrial compound which has been used as a food preservative for a long time. It is a water-soluble thiol compound with reducing agent properties, and it is used for treatment of cyanide, arsenic, lead, mercury, and bismuth poisoning. As a otoprotectant, it is basically a free radical scavenger, binds covalently inactivating the platinum compound, has direct interaction with the hair cells of the cochlea to rescue them from platinum-induced damage, and protects against nephrotoxicity as well by reducing the delivery of cisplatin to kidneys and thereby neutralizing cisplatin in the kidneys. So how did this come into play? Like how cisplatin causing this hearing loss and sodium thiosulfate is because of the CYPL-4 study, where we saw that dose-dense cisplatin-based chemotherapy when used for children with hepatoblastoma, it led to improved outcomes, but at the cost of moderate to severe ototoxicity, and it was reported in about 60% of the patients. So increased dose density of cisplatin in the preoperative phase can improve the prognosis, but at the cost again of ototoxicity. That is when this paper was published in 2018, which was a randomized phase 3 trial, which lasted for about 7 years with 52 centers in 12 countries, included only the standard risk hepatoblastoma, and the data was blinded for the audiology central reviewer. Very simple design. Basically, one arm got the standard chemotherapy, the other one got the standard chemotherapy along with, that is cisplatin, along with sodium thiosulfate. I will not go into the doses, but what is important to know is that the sodium thiosulfate was actually given after the cisplatin infusion. And it had good number of patients randomized in both the arms, and about 46 were evaluable in the cisplatin arm, and about 55 were evaluable with the combination. So what the results showed is that the relative risk of hearing loss with cisplatin sodium thiosulfate treatment was 0.52, which translated to about 48% lower risk with the use of the combination. And in all the grades, there was almost with the cisplatin, it was about 63%, whereas it was 33% for the combination. And the most important part again remains what happens to the outcomes. Was there any dip? So here you can see that the outcomes in both the groups which received the sodium thiosulfate and did not receive were the same. So there is probably no anti-tumor effect of this compound. And when it came to adverse events, there were not many major adverse events. Of course, grade 3 neutropenia was slightly higher, but I think it was manageable. So to conclude, in this paper, addition of delayed sodium thiosulfate to cisplatin led to a 48% lower risk of hearing loss. And the hearing loss of grade 1 or higher was 63% and 33% in the cisplatin with the combination. Trend was towards reduced ototoxicity in all the ROC grades with otoprotectant. And the number of progressive tumor developed in the same in both the arms, no significant difference in AFS and OS. And definitely it had led to a lower incidence of hearing loss. So the guidelines, the IGHG guidelines in 2019 also adapted, looked into this paper and gave the recommendation of level C. But as we all know, meta-analysis and systematic review is very critical when we look at this. And this was the paper which was published in 2021 and had looked into 4 studies, out of which 2 were done in pediatric age group. And again, it favored the use of sodium thiosulfate to prevent the ototoxicity. When you look into the paper further, when we see the event-free and the overall survival, actually it favors the control, but because of the low number of patients that were there in the analysis, it could not actually answer this question of survival. And again, the IV route showed better. And when we looked at the age less than 18 months, I think less than 18 years had better otoprotection compared to those who were more than 18 years. So that is regarding the cisplatin and ototoxicity. And next, I'll be talking about anthracycline in pediatric oncology, which is again the key component of many leukemia protocols as well as solid tumors. And we all know that the cumulative incidence of cardiac events is high, especially when treatments are combined. For example, the blue line here is anthracycline with radiotherapy involving the mediastinum. And it is estimated that it's about the grade 3 to 5 cardiovascular conditions is about 11%. So this systematic review and recommendations from the International Late Effects of Childhood Cancer Guideline Harmonization Group, the IGHG, had defined these risk categories. So basically, a child is low risk for developing anthracycline-induced cardiotoxicity if the dose is less than 100 mg per meter square and the mediastinal radiation is less than 15. Moderate is somebody who would get between 100 to 250, mediastinal radiation of 15 to 30. High risk is someone who would get more than 250 mg per meter square or 30 gray of mediastinal radiation, or a combination of 100 mg per meter square of anthracycline and 15 gray mediastinal radiation, or age exposure, any child receiving below 4 years of age was considered as high risk. So when it comes to the prevention, there are a lot of strategies that can be used, like, for example, decrease the cumulative anthracycline dose, like in children with Hodgkin's lymphoma. You can reduce the field of radiation in Hodgkin's lymphoma. Again, Dr. Lashkar had beautifully shown the pictures. And again, increasing the infusion time as per certain Cochrane reviews has shown to reduce the anthracycline-induced cardiomyotoxicity. So when it comes to the cardioprotective agents, when we look into this, there are these agents, the dexazoxazone, ACE inhibitors, beta blockers. But again, ACE inhibitors like enalapril, metoprolol are mainly used for secondary prevention, generally after the onset of cardiotoxicity. And we will be discussing about dexazoxazone and cardiac protection. So this agent is a cardioprotective pharmacological agent, and it is again the only FDA approved drug for this indication. It interferes with the pathophysiological mechanism of anthracycline by chelation of iron and transient binding with the topoisomerase receptors. Again, the ratio is very important. So you need to give 10:1 with doxo or daunorubicin, 40:1 with mitoxantrone, and 50:1 with idarubicin. And what is the evidence to use this? So again, from the IGHG, we kind of have some data that is when to administer dexazoxazone concurrently with anthracycline in patients who are diagnosed with cancer less than 21 years of age. So this, again, looked into a lot of studies, but eventually 18 studies were included in the analysis, and it included both the children as well as adults. So here you can see that most of the evidence that was available actually was very low quality to low quality evidence. And the conclusion of the panel, which included generally oncologists, radiation oncologists, patients, survivors, parents, etc., was that for a cumulative dose of doxorubicin or equivalent dose of 250 mg per meter square, there are anticipated benefits. So probably yes, using dexazoxazone in these patients will have a beneficial effect. And the other recommendation was the administration of dexazoxazone is reasonable in children who are again expected to receive a cumulative doxorubicin dose of more than or equal to 250 mg per meter square. And it is again very important to discuss the balance between the harms and benefits with the families before taking this decision. So if we look with all the evidence that is there and what applicability it has, so when you look at sodium thiosulfate and ototoxicity, we all agree that hearing aids are a big taboo. And we see a lot of children who have hearing aids not going to school after cancer treatment just because there are other children who are bullying or, it's a big taboo. They do not go to school. Cochlear implant for us is quite expensive. It actually costs more than the cancer treatment itself. And sodium thiosulfate is available in India as an IV formulation, but unfortunately, it is now a part of a cyanide poisoning kit. So you need to open the kit to procure it. And it's available as a 12.5 gram per 50 ml and costs about 1,000 rupees. And one vial, 6 cycles is about 5 to 6,000 rupees actually. So it is actually feasible to do it. And when you come to dexazoxazone and cardiotoxicity, availability now is an issue, and it is costing about 25,000 per vial of 250 mg. And I already discussed about the dosage range. It's about 10:1. And the total cost per dose, if the dose is 50 mg per meter square, is almost about 50,000 per course, and total about 5 to 6 courses are required. And yes, I think after discussion with the family, it should be feasible, provided affordable and the family understands. So to conclude, chemoprotectants offer promising strategies for reducing late effects. Evidence-based choices in chemoprotectants can improve quality of life for the survivors. And ongoing research will definitely shape the future of the chemoprotectant agents. And future directions again would be towards novel agents targeting specific toxicity. And I think yesterday Dr. Venkat also mentioned about personalized medicines. And it's very important. We currently have a child who got 200 mg per meter square of cisplatin, but already has grade 3 Brock score for hearing loss. Whereas we have another child who has almost got enough 600 mg per meter square of cisplatin, and there is no ototoxicity. So it's very important. Maybe the future study should look into the pharmacogenomics and look at utilizing this. Thank you.
Yeah, thank you, Dr. Vasudhan. We'll have questions at the end. So it's my pleasure to invite the next speaker, Dr. Puneet Arora. Dr. Puneet Arora is a senior consultant and fertility specialist at CIFAR Gurgaon, with special interest in preservation of oncofertility. But Arora, welcome.
I think I'll have to use Steph. Thank you.
Thank you so much. Thank you to organizers for having me and keeping this topic out of the pediatric, background and talking about fertility. So I have been asked to speak on evidence-based primary prevention, fertility preservation. So just kind of an overview. I won't waste much time, but it's just about, we'll talk about fertility preservation, what are the effects of cancer and its treatment on reproductive organs. We understand the risk factors which can bring in these effects, what to offer to these children, and ethical and legal dilemmas, which obviously we are facing a lot now because the practice of seeing such children has increased. So this term is, linking reproduction and oncology is not a new concept going on for long, but officially coined as oncofertility in 2006. So why we need to preserve? If you just understand the basic physiology, human ovary is an endocrine organ. It has oocytes, and also it has hormones, which basically are sex steroids. And hence, when we preserve the fertility, we can preserve the oocytes, but at the moment, there is a concept of preserving the whole tissue, which will not only provide us oocytes, but also the endocrine aspect of the ovary. So there is, if you see, just kind of again go to the basic physiology, the ovary has a lot of bunch of these, what we called as immature oocytes, called as primordial follicles. And then we have a bunch of growing follicles. When a cancer treatment is given, it mainly acts on the rapidly dividing cells. So it mainly acts on the growing follicles, which means we still have a reserve of primordial follicles with us, which can be saved if we are careful with our chemotherapies. And also if we preserve a bit of a growing follicles before the cancer treatment is started. Now, post the cancer treatment, we may lose all the growing follicles, which can take 3 to 6 to 9 months for those primordial follicles to reach to that growing follicle. And hence, if a girl or a woman doesn't start her menstrual cycle for 6 months, because that's the recovery time which is needed for the primordial follicles to reach the growing follicular stage. And sometimes, if the chemotoxicity is too much, then she may not recover completely, which means that she may have deficient of all the growing follicles and hence the estrogen deficiency and hence no periods and hence infertility. Now, if we see the basic, can I use the, yeah. So the basic, the bulk of these follicles are at birth and then it starts declining. So in a way, getting cancer at a younger age may be a boon because the cancer therapy may not affect as strongly as to what an adult because the bulk of follicles are too many. So again, and when talking about the male, we have 3 kinds of cells: sperm cells, Sertoli cell, and Leydig cells. Now, sperm cells, when they get affected, obviously affect fertility. Now, the supporting cells are Sertoli cells. So chemotherapy, radiotherapy can affect any of them. So, these are the direct effects of chemotherapy. And then the Sertoli cells can get affected secondarily, the sperm cells can get secondarily, and hence lead to altered growth factors and spermatogenic death. So it's important that when we get a child from an oncology colleague, it's important that not only we make a kind of a risk assessment, but also the oncologist should make a risk assessment based on, is the cancer going to affect the fertility outcome, reproductive health outcome? Is the cancer treatment going to affect it? Or there are any underlying patient factors which may be a responsible thing that a child, a girl or a boy may lose fertility. And if we talk about these various factors, I won't go much into details of diagnosis and treatment, but patient factors for us, it is important, the first of all, to know whether they have achieved the puberty or not. I think that's the main thing. And whether they have underlying condition where they are already at risk of losing the fertility due to any medical condition or genetic condition like Turner syndrome or so. So individual risk assessment is very important, and hence the multidisciplinary team comes into picture, that we talk combinedly with our oncology colleagues and with our patients. Also, I feel that this was an important slide because when we kind of give a risk assessment, we should also see which cancers have a high risk of going to ovaries. And I think there are some cancers which have high risk ovarian involvement, like neuroblastoma, leukemias, Burkitt lymphoma. So for us, they are high risk factors. So what are the options we can give to these children when they come to us? Obviously, we make a risk assessment. We can offer treatment before they start their chemotherapy. Maybe look after them when they are having their chemotherapy or radiotherapy, and also look after them once they have finished their treatment. Before treatment, we can offer them oocyte cryopreservation, sperm cryopreservation for males, and now ovarian tissue cryopreservation as well. And on top of that, there are GnRH agonist therapies which can be offered. During treatment, ovarian transposition, hormonal treatment with GnRH, and obviously looking after more fertility-friendly chemotherapies. After treatment, if we have preserved the ovarian tissue before, we can put it back in a female, in a girl, and then so that she can retain her hormones and also maybe get pregnant with those oocytes which have been transplanted back. Or if the sperms are frozen, we can offer them ART treatments like IUI or IVF, which is intrauterine insemination, or IVF and ICSI. Or they may consider, if nothing is frozen, they may be, kind of a discussion about going for adoptions or use of donor gametes, donor eggs, donor sperms to achieve fertility. So there is a kind of a common question which is asked to us that oncologists may ring us and say, patient has had one cycle of chemotherapy or one dose of chemotherapy. Can they now come in and freeze their sample or have their eggs frozen? Generally for us, theoretically, we say no, because we know that chemotherapy can damage DNA and cause gene mutations. So we are not in a way giving the best therapy by freezing their eggs or sperms after they have started their treatment. Even though some studies have shown that pregnant women not knowingly received a chemotherapy and there were no long-term effects. So this is little a debate, but still at the moment, we do not have enough data to say that, okay, we can preserve their fertility if they have already started their treatment. So if you look at these guidelines, which are international guideline group, so if you look at the male options, so at the top, you can see there is always a risk for infertility. And the second important thing is the pubertal status. So I think these two factors are important to assess before we offer anything. Counseling, obviously, is important for every group. Sperm cryopreservation for where the risk is high, and even when the risk is low, or with cranial radiotherapies. I mean, it's again a moderate recommendation when the risk factor is low, but I think we should always talk about it. Sperm cryopreservation through either of the route, masturbation or electroejaculation, or by extraction known as TISA, can be offered. Testicular tissue, it is very much at an experimental stage, and hence it's a moderate recommendation. I will discuss in detail a little bit about in the later slide. Hormone suppression with chemotherapy doesn't work well in males, even though for females, it has been shown some effects, especially in the hormone-sensitive cancers. Looking for the females, again, we can offer counseling throughout the groups, whether they are high, low, or even not at risk of having any infertility issue. Oocyte or embryo cryopreservation, again, is a strong recommendation, especially for the high-risk group. Ovarian tissue cryopreservation at the moment is a moderate recommendation because it is not available in all countries. I mean, it's available in India, but we are not being able to offer. I'll explain in a minute why. And ovarian transposition before radiotherapy, hormone suppression, according to these guidelines, not recommended, but I think every oncologist do give GnRH analogs to patients because we know that it will not do any harm, not do any good, but it may not do any harm as well. So if you just look at summarize the options, basically at the end of the day, what we need is a mature oocyte, which is going to give us a pregnancy and which is going to bring the period's menstrual cycle back for a girl. Now we can freeze them as such by stimulating the ovaries for 2 weeks with injections and getting those mature oocytes out. Or we can have the slices of the ovarian tissue frozen, which have oocytes, which we can mature them later by putting them back when a woman or a girl is recovered from her cancer treatment, or we can have the immature oocytes taken out, mature them in the lab, and make mature oocytes. So these three, because at the end of the day, we want these mature oocytes to give them a reliable hope of achieving pregnancy and the menstrual cycle. Sperms are relatively easier because it doesn't need the preparation much as what a mature oocyte would need to be taken out. Sperm retrieval can be done by ejaculated, or it can be extracted from the testicular region. So it is easier, but there is always an option whether it is going to come out in the same way, whether it will be used, whether the long-term storage is going to make an effect on the quality of the sperms once we decide to use them. Now, this is a good study which showed that what happens to the sperm frozen, because at the moment, because we are freezing sperms, not everybody is coming back to use it. So our cryocans are indeed filled with sperms. And this study showed that, yes, only 17 out of 100 came back to use those sperms for their reproductive health. And if we see the pregnancy outcome in the group who saved in the high gonadotoxicity group, 6 of them did use and achieve pregnancy compared to the one who didn't froze their sperms, and also the pregnancy outcome was low. So I mean, again, we have to do a risk assessment. We should not leave this group high gonadotoxicity because we do see an effect in them with regards to achieving pregnancies. Yes, they may not come and use, and I think that's what the problem we are having. They are not coming back and using those samples. They had frozen it because it was, discussed with them nicely. But again, we are losing them in between. Either we need to have a pathway where we know that where they are right now, whether they are okay or not. So it's a constant call from our clinics going to them, whether they want to use it or not. Testicular tissue, not very reassuring at the moment, done mainly in the research-based trials because there are a lot of dilemmas in that. And no reports of live birth have been reported yet in humans, even though animal studies are a little bit more reassuring. Coming to the oocyte cryopreservation, which is the main thing which we offer to our young girls, obviously she has to be post-pubertal. We need 10 to 15 days of stimulation to get those mature oocytes. It's always asked by the patients and also by their parents, how many oocytes should I freeze to get a reliable outcome? We always say double figures are better, 10 to 15 oocytes. And normally we get these oocytes from a young because like I showed that they do have a good ovarian reserve and we do manage to get these number of eggs from them and give them a hope. So getting the number is not an issue in the young girls. But we do need 12 to 14 days. Not necessarily from the periods. There was an old school of thought that a girl has to be on her menstrual cycle before she can be offered. But now we have random start protocols where we can stimulate them at any part of the menstrual cycle and get those mature oocytes retrieved. Obviously, they have to be counseled that once the oocyte is out, the option of achieving pregnancy is only through ART, which is IVF, in vitro fertilization, and ICSI, and make embryos and transfer her back into her uterus. And again, this is like a reassuring data because this is another question which is asked to us. Are my eggs going to be same as somebody who hasn't had a cancer? And I think the data, even the personal data and the published data is reassuring that yes, the outcome is very similar to the one if they haven't had a cancer. Again, the developmental competence, because this is a very common question which is asked. So again, some few slides on that. Even we have a long-term perinatal outcomes, and the children born through egg freezing are very similar to what they are with a normal conception. IVM, I will not much discuss in detail because it is not definitely, it doesn't give us any success where we retrieve the immature eggs and make them outside into mature. But what is reassuring and what is promising is an ovarian tissue, where we take the cortex out, kind of process them in the lab, make them into pieces, and then put them back later once they have finished the cancer. So this is the ovary where we cut section of the ovary. These are the follicles, which are growing follicles damaged by the chemotherapy. And there are lots of small primordial follicles, which are not visible, but which can be preserved through freezing. So what we do is we cut them into slices, make into small pieces of 1 centimeter by 1 millimeter thickness, and then preserve them. It can be used in various cancers. Cancer type is not a contraindication for it. A lot of babies, not lot, 200 babies have been born across India, across the world, but not in India. We're still to come here. So again, there are a lot of questions which come into picture as the ethical dilemmas. So again, the recovery of the menstrual cycle, once we put it back into the women, is around 3 to 6 months. It takes 3 to 6 months for the high FSH levels to go down and bring her menstrual cycle. So 3 to 6 months is the time. A couple of cases where a 10-year-old from sickle cell disease had the transplantation of the ovarian tissue back at 13 years, and she got her periods back in 2 years. 9-year-old with Ewing sarcoma, transplantation done at 13 years, and then in 19 months, she got her periods back. GNRH, again a controversy, I won't go, but I just want to discuss about, I know that we're short of time, ethical dilemmas, because now we are offering all these things. It comes with a lot of ethical consideration, consent, assent, experimental nature of a lot of techniques, psychosocial impact once we speak with them, but we cannot offer them sometimes a lot. Legal aspect, parental consent versus child autonomy, who's going to have the tissue. But recently we had a case where the child was no more, the parents separated, who's going to take the legal responsibility of that sperm? So a lot of things we are coming across. So it's a complex issue when we offer them. So we should have units which can deal with it. These are the consents which we take and do take.
Dr. Puneet, could you just please wind up?
Last consent form. And a lot of consent forms we do keep, but again, this is a lot of ethical dilemmas just happen, and we need for more clearer, I would say, ethical guidelines when we are offering it more to our patients. Thank you very much.
Thank you. Thank you. Next, we have Dr. Smita Bhatia, Professor, University of Alabama, to talk about the international guidelines.
Hello, everyone. Jack, did you lose your dad? Oh, he's standing at the back. All right. So this is on EBM, pertaining to EBM, and how the IGHG came about, and why do we need guidelines? So, we know this. In the United States, the survivals have improved from 10% in the 60s to 85% today. The burden of morbidity is high. I won't go into these slides again because I presented them this morning. Mortality, because of health-related reasons, continues to increase. There's no plateau, crosses over the recurrence-related mortality. The risk of dying is 6-fold higher than the general population. We have clearly established associations between treatments and adverse outcomes. Again, presented this in the morning. We know that there are modifiers of the association between treatment and adverse events, and these can be used to identify those at high risk, so we can modify therapeutic exposures, screen those at the highest risk, and then use risk reduction strategies, which were presented beautifully in the last 2 talks. How do we do them? We use a targeted approach with the goal of reducing the risk of morbidity. So now the goal of the talk just now is screening of high-risk populations. So the benefit of screening derives from detecting adverse events earlier than one would otherwise do, with a better prognosis and chance for cure. So that's the premise for why one would screen. And these are some things that I have gathered and put together as the guiding principles of surveillance for subsequent malignancies, for example. Why would one screen? If they had poor outcomes and if early detection were associated with a reduction in morbidity. That would determine the benefit from screening. If the magnitude of risk exceeds that in the general population, then we would determine if screening should differ from that of the general population. If the latency from exposure or the period at risk and the lead time compared with the general population were known, we could then determine when the screening should be started and for how long we should screen. If we could identify subpopulations at highest risk, then we could direct the screening to the populations at risk, with the frequency of the screening being higher amongst those who were at high risk. So the International Guidelines Harmonization Group for Late Effects of Childhood Cancer came about in a collaborative fashion with 4 groups: the Children's Oncology Group, the Children's Cancer and Leukemia Group, the Dutch Later Group, and the SIGN. And this was the first paper that they published. This was a worldwide collaboration to harmonize guidelines for the long-term follow-up of childhood and young adult cancer survivors. This was their report. The background was, just to give you a sense of the historical basis, so it started in 2010, so it's 15 years old. It was to establish a common vision and integrated strategy for the surveillance of late effects in childhood and young adult survivors. For each recommendation, 5 key questions are asked. Who needs the surveillance? At what age or time from exposure should surveillance be initiated? At what frequency should surveillance be performed? What surveillance modality should be used? And very importantly, what effective treatments are available if health problems are identified? Because there's no point in screening if you don't have effective treatments available. So several guidelines have been published: obstetrical risks, hepatic toxicity, coronary artery disease, gonadotoxicity, fertility preservation, many versions of it. And then, mental health, cardiomyopathy surveillance, cardioprotection, cancer-related fatigue, ototoxicity surveillance, education and employment outcome surveillance, and then breast cancer surveillance, premature ovarian insufficiency, pulmonary dysfunction, bone mineral density surveillance. So I'm going to give you a brief summary of a couple of guidelines. These are beautifully laid out, and they differ from the Children's Oncology Group in the sense that they're based on the outcome. They're not based on the risk of exposure or the exposure under consideration. So this one is for cardiomyopathy. A green recommendation means that they truly recommend that outcome. So survivors treated with anthracyclines, chest-directed radiotherapy, or both, and their healthcare providers should be aware of the risk of cardiomyopathy. Cardiomyopathy surveillance is recommended for survivors of childhood cancer treated with high doses of anthracyclines, high dose being defined at 250 milligrams. Now, yellow becomes that they are suggesting that it seems reasonable to do that. So cardiomyopathy surveillance is reasonable for survivors of childhood cancer treated with moderate doses, but not for those who received less than 100 milligrams per meter squared, so hence the red. Now, cardiomyopathy surveillance is recommended for survivors treated with moderate to high doses, i.e. more than 100 milligrams per meter squared, if in combination with moderate to high doses of chest radiation, 15 gray or higher. Recommended for survivors treated with high doses alone, not reasonable if you've got 15 to 30 gray of chest radiation, no anthracyclines. Please do not surveil if the dose of chest radiation is less than 15 gray in the absence of anthracyclines. Now, how do you screen? Left ventricular ejection fraction with 2D or 3D echocardiogram is the primary surveillance. If a cardiac MR imaging may be reasonable for cardiomyopathy surveillance in at-risk survivors for whom echocardiography is not feasible or optimal. Cardiac blood biomarkers in conjunction with imaging is reasonable, but not by themselves. High risk should, those at high risk should begin no later than 2 years after the completion of therapy. Yellow, lifelong cardiomyopathy surveillance. Yellow, at moderate risk, begins no later than 2 years after completion of cardiotoxic therapy, to be repeated at 5 years. And then in red, no surveillance for those at low risk. Screening for and management of modifiable cardiovascular risk factors is recommended. Now, do I have time? I think I might have time. So let's do breast cancer surveillance also. For those who receive chest radiation of 10 gray or higher, to perform breast cancer surveillance for survivors treated with upper abdominal radiation exposing breast tissue at a young age is yellow. No recommendation for those who received 1 to 9 gray of radiation. Obviously, none for those who didn't receive any radiation. No recommendation for breast cancer surveillance for patients treated with anthracyclines in the absence of chest radiation, although I have to say that these recommendations are currently under development. And then annual breast exam surveillance. This is clinical breast exams for at least up to age 60, and beyond 60 is yellow. Now, as I had mentioned, these are the published guidelines. These are the guidelines in progress. Colorectal cancer surveillance, growth hormone treatment, metabolic syndrome surveillance, nephrotoxicity surveillance, cognitive problem surveillance, splenic dysfunction, and then, as I had mentioned, anthracycline cardiotoxicity. So what next? We have guidelines. What do we do next? We have to remember these are consensus-based guidelines. The evidence is available for association between therapeutic exposures and the outcome of interest. There is limited or no information that is available for what screening modality to use, how frequently to screen, whether screening will reduce the morbidity or increase the lifespan. So for this reason, about a decade ago, we had conducted a study, single center, where we were faithfully following the Children's Oncology Group long-term follow-up guidelines to look at the yield of screening for long-term complications using these guidelines. So these were the guidelines, the recommendations that resulted in a high yield. These are asymptomatic survivors, long-term survivors who came to us. And this is what we found. Oh, really don't like me, do you? ये क्या हुआ? Now I can see who's sleeping. Okay, I think I can go here. Yeah? Okay, so high yield. Which ones, what were the recommendations that resulted in a high yield? These were pulmonary function test, chest x-ray, ferritin, DEXA, audiometry, and TSH. And we arbitrarily had said that anything that gave us 10% or higher yield would be considered in this group. Intermediate yield were these: testosterone, FSH, echocardiograms, LFTs, mammography, hepatitis C, and magnesium, potassium, phosphorus. And then low yield were these entities. I need it to go away. So urinalysis for protein, ECG, creatinine, CBC, UA, Hep C, and HIV. So we used these and to say that screening tests with a high yield are appropriate for risk groups targeted for screening, and that we could safely recommend elimination of screening tests with negligible or negative yield. And in fact, some of these were used in the subsequent versions of the Children's Oncology Group. The second thing we need to understand, once we've established guidelines and we are following them, to study what is the health benefit and the cost effectiveness of these guidelines. And we did that for breast cancer screening guidelines. And we did that also for heart failure guidelines. We have to remember a sobering thing that we discovered. We have to understand these are simulation studies that we did. We haven't yet randomized people to receive screening versus not receive screening in order to see reduction in mortality. But these simulation studies for breast cancer, we found that if you follow these patients with the screening for life, 100% adherence, you're prolonging their life by 11 months. Very sobering. So with that thought, I'll let you go and always end my talk by saying I thank my patients and their families for participating in these studies. And I finished on time.
Thank you, Dr. Bhatia. I invite the next speaker, Dr. Ramandeep Arora, to talk about evidence-based Indian guidelines. Dr. Ramandeep Arora is the consultant pediatric oncologist at Max Super Specialty Hospital in New Delhi. Dr. Ramandeep, over to you.
क्या करें? आप आदेश दो. Okay, thank you everyone and good afternoon. I think the previous talk set up very nicely for this this talk, and I would love to hear your feedback later in the afternoon. Okay. I'm not sure if this is the right presentation, but let's see. I think the formatting has changed again. So I'm talking about the Indian guidelines, and of course, we've been inspired heavily by some of the work which Dr. Smita has just shown. And when we, as a clinician, want to look at guidelines, we want to know, A, it should be based on evidence. B, very importantly, does it take local context into account? C, it should be simple and practical to use. And then, of course, it has to find acceptability in the patients and carers in our population. And that should remain the fundamental principles of guidelines. And this is something which we are all very familiar with. But the point I want to make over here is that these are exposure-related clinical practice guidelines. And so what I mean by that is, and this is the 6th version which came out in 2023, that you can see all these therapeutic agents in column number 4, which are the exposure, and then the potential late effect is listed in the book, in the guideline. And then you pick up any one page and it nicely illustrates starting from the therapeutic exposure again, and then goes to the late effect. So you need to first work it out by exposure and then go to the late effect. Of course, in the clinical practice, by putting it on a software and using an algorithm, they can then generate reports for the patients. But the guidelines as they stand are in this way, which can be daunting to navigate when you look at them for the first time. And I'm not going to go through the entire process of how they develop the guideline. But the point I wanted to make over here is that any guideline process is quite elaborate and takes time. So there is a lot of literature review and drafting of guidelines. And then there's experts and reviewers and task forces and a lot of people spending a lot of time on it. In the end, with that, you come out with certain recommendations. And so in this case, it's category 1, category 2A, category 2B. In IGHG case, it's a few different letters and alphabets. So that's how the COG guidelines have been structured, and you have already seen the IGHG, so I'm not going to take you through them, but just to say that unlike the COG guidelines, which are based on the therapeutic agent exposure, these are based on the problem, so ototoxicity or cardiotoxicity, and then they go backwards and ask those 5 questions which Dr. Smita pointed out. Who's at high risk? When should you start screening? When should you stop screening? What is the method of screening? And so on, so on. And again, this is a list which was shown in the previous presentation, which are guidelines which are in development, and there are a few more which are being developed. And again, picking on male gonadotoxicity, which the couple of speakers have talked about already, and this is how a guideline would come out. So this is data from the West, and to develop these guidelines, and I think Dr. Smita also showed this paper, again, they have a slightly different methodology, but the philosophy remains the same, that they extract the recommendations from the groups which already done the work. They then look at the evidence which supports it. If need be, they do additional work on it. And then they give recommendations, which in this case is, strong, moderate, weak, and not to do, that kind of thing. But with all this, what we have to remember is how does it remain relevant to us? Because these guidelines are being developed from evidence which is almost exclusively generated in high-income countries. It is being developed by people who work almost exclusively in high-income countries, and the setting and the patient profile and the context is there. Also, as I've shown, they are either therapeutic agent related or they're the problem related. They're not really disease related, which is what a clinician at the front end wants. I have a leukemia patient survivor, what should I do? I have a lymphoma survivor, what should I do? And of course, they don't take into account the resource limitations. And this is a figure which Dr. Gauri also showed earlier today, and Dr. Smita alluded to this, which is while there is a lot of evidence linking the late effect with the exposure, but the recommendations for screening, a lot of it comes from expert clinical experience in that context. And as Dr. Smita showed just now, that the yield, which they have done through modeling, and the cost effectiveness, there is a lot of work to be done to really understand the value of all this. So when you take that into account and you say, well, I always thought that these guidelines are, set in stone and they are like the 10 commandments and I should follow them, you realize that it's not so straightforward. You really have to think of your own setting and not just blindly do all the 20 things which the COG guidelines ask you to do, because maybe that's not the best thing for the patient in this case. Maybe it is, maybe it isn't. So I'll give you an example. So we took the COG guidelines and we said, okay, a patient with ALL who's on icicle protocol has received, standard risk therapy, what would the COG book tell us? And it listed out 12 things which you would want to do it when they come to your survival clinic. Now, for a busy clinician with limited time and a patient who's got other things to think about, going through all the 12 things may be challenging. And so with that background, we were trying to look at what is the method to find a balance between delivering a service, but also, using the evidence in the local context. And so we have done, or before we go to what we have done, I want to show you something which has already been done in our context. So very much in this room a few years ago, the NCG guidelines were being developed and the pediatric guidelines were actually discussed in the room. Chetan was moderating that session. And that led to this document which was produced. But that was, and it does not include survivorship, but that was limited in the way it was conducted, and I'll talk about that. And the other well-known guidelines, the ICMR guidelines, and a number of them came out in a series of papers and then also published as a book, which is available online. But the thing to consider is that there was no clear method to identify the evidence or grade the evidence in both these methods guidelines I've talked about. There was no way of knowing who was chosen to be an expert in these guidelines and how was their opinion incorporated, and there was no patient or carer feedback. So the guidelines, although a positive step, were not rigorous enough in terms of their methodology. And so to address this, NCG itself recognizes this and subsequently has been working on developing the NCG guidelines with more efforts towards it. And Dr. Manju led this work. And this is an algorithm from that, which basically talks about either adopting the guideline or adapting the guideline. And we actually did, some of us over here in this room were part of this. We did a workshop with the NCG and spent some time online and spent some time in person. And there were a mixture of pediatric and adult physicians. And we personally were looking at ototoxicity and cardiotoxicity. And it was a good exercise. But I think what it also taught us was that we were not ready for it yet. We didn't have the bandwidth, the ability, the resources, the time to give this project to achieve the outcome we desired. And of course, just one slide on ARIA. Some of you will be aware that ARIA has been working a lot on developing guidelines. They have been disease specific, but they also have a plan to produce survivorship guidelines. Currently, they're all under development. It'll take another 1 to 2 years before they come out. And they would be informative because they would, tailor it to the local setting in a LMIC. So now that we know what exists in the West, and now we know what has been happening in LMIC in India, can we do something more to take a step forward in this direction? And this is where the Indian Childhood Cancer Initiative, which has been active for the last 2 years, formed a survivorship task force. And within that, there were various aspects. And we are basically looking at health service delivery. And so one of the things which came out from there was developing survivorship guidelines. And I just want to share in the next 5 minutes with you the work which we have done in this regard. And there's a core team of people, but you know I think everybody over here is over here except Gargi. But I do want to credit both Ram and Gargi, who have really been doing most of the work on this project. And going back to the point I had made in a slide before, and I want to show how we are incorporating that. So we don't have the bandwidth to find the evidence, so we are outsourcing it. We are taking the COG manual as it is. Then we are using a system of the INFOG survivorship and late effect subcommittee members and the C2S, which is our late effect study, site primary investigators as the basis for our experts. Then to incorporate their opinion, we are using a Delphi consensus. For a patient carer feedback, we are doing a focus group discussion. And finally, what's been cut to the bottom of the slide is, and I'll show it in the subsequent slide, is that we are doing it by disease. And we have taken 5 disease groups. So let's take leukemia as an example, because that's the one which we have done so far. So we divided leukemia into ALL, AML, CML, and there was also a section for any cancer experience or general. And so from here, the first step was we took the COG guidelines and we said, and I showed you the ALL list of 12 things we have to look for. And we then discussed in the 6 core member team and said, are we happy with this? Do we want to incorporate something more? And I'll give you an example. So these are the 12 in black, which are from the COG book, but we felt that dyslipidemia and impaired glucose tolerance were also important to add. And so we added that to that list and made it a list of 14. From there, we then did a Delphi consensus. In the round 1, we had 2 questions. A, in your setting, how would you describe the need for evaluation of any of them? So I've taken an example of osteonecrosis. You would score them 1 to 9, and then we had a cutoff as to where we will have a consensus. And then the second question was, well, how would you conduct that evaluation? And this is again wording from the COG guideline. And we said, would you agree with change or agree without any change, or you disagree with it? And so using those 2 things, we reached out to around 42 people or 40 people, and 39 of them responded in round 1. And this led to feedback. We got the report, we did the analysis, we had an in-person meeting in September in the All India Institute last year. This is a photograph from that group meeting. We spent 1 day on the Delphi part, going through all the questions. And then from there, we conducted the second round of Delphi. So what have we found after all that exercise? Just before that, the end point over here was not to say that is not right to do or that is right to do. It is just to say, in our context, what is something we would like to prioritize and what is something which maybe does not meet wide consensus for prioritization. And that's all we are trying to do, so that the clinician can then decide what they want to do. And I'll take one example of cancer in general through the process, and then the others will be very easy to follow. So based on any cancer experience, the COG guidelines list 10 points. We added 3 more, and then we should have had, should be 4 more. We should have had 14. From 14, we first asked, is there a need? 5 of them met consensus for high degree of agreement for need. So 8 had some degree of agreement, and nobody said low degree of agreement. And then from there, we said, okay, the ones where there's already consensus, we just adopt them, and they didn't want to change the conduct. Where there was some degree of agreement, we took them to round 2, and then these were again changed and rediscussed. And from there again, 2 moved to the purple box of high degree. So in the end, from the 14, we were left with 7. So that is how we were able to trim down for all cancer. Then we go to ALL, and again in the bottom you will see that from 14 we were able to trim down, I think the number is 6 and 5. 5. The number is 5. So from 14 we were able to trim down to 5. Similarly, for AML, from 3 we were keeping all 3, and for CML from 5 we were able to trim down to 2. So the last part, which is the patient feedback and carer feedback, is something which we haven't done yet, but we do need to do a focus group discussion with survivors and parents on prioritization, access, dissemination, and advocacy. And we have a plan to do it with 8 to 10 people, which includes 3 survivors, 3 parents, 1 to 3 representatives of civil society organizations, and 1 facilitator. So here is the summary of all what has happened so far. For leukemia, as you would see, there are in green 11 for cancer experience, 14 for ALL, 3 for AML, and 5 for CML. Based on this entire process we have done, we have reduced them to the yellow. So this is one method which is transparent, takes feedback, incorporates everybody within it, and provides you some kind of prioritization in a busy clinic with a high workload. What do you focus on? What do you work on? And so having done this for leukemia, this is my last slide, and this is a summary of where we are. So we have divided it into 5 disease groups: leukemia, lymphoma, brain tumors and retinoblastoma, abdominal tumors, and sarcomas. The evidence is saying done because basically we're just taking the COG guidelines in its entirety. The experts, for the first one, we took the 40 experts from the late effects group. With each of them now, we will add experts. So it may be the INFOG lymphoma group, or it may be the INFOG sarcoma group, or it may be radiation oncologist we want to ask, or the neurosurgeon we want to ask, or the pediatric surgeon we want to ask. So we will increase the amount of experts, and then the Delphi process and the focus group discussion. So with that, I finish, and thank you for your time.
Thank you for that. Next, we have Technology and Distance-Driven Intervention and Survivorship by Dr. Claire Wakefield from Sydney Children, Australia. This is also technology and distance delivered, so it's an online talk.
Thank you so much for the opportunity to present today. It's an absolute honour to be part of this really important conference. I'm really excited to tell you today about our work in Sydney on technology and distance-delivered interventions in childhood cancer survivorship. My name is Claire Wakefield, and I'm a professor at UNSW Sydney, and I've worked at UNSW and at Sydney Children's Hospital for the last 20 years. So our work is really around helping families to achieve better outcomes when their child is very sick. And you can see some of the team at Sydney Kids here. Most of this work has been done through research, implemented into clinical practice as much as possible. So I've been delighted and honoured to be part of the Behavioural Sciences Unit, otherwise known as the BSU, since 2008. And our goal is to use research to help families to find their way when they have a very unwell child in hospital. We have 4 key research areas, and they cover mental health and relationships, patient-reported outcomes and quality of life, precision medicine and genomics, and health systems and survivorship. And all of those research areas aim to achieve these outcomes you can see on the screen now, including improved resilience and family wellbeing, measuring the outcomes that matter to patients, maximising the potential of children, the ethical implementation of precision medicine and genomics and other new technologies, as well as improving young people's ability to engage in their own healthcare and also to engage in healthier lifestyles. On the page now, you can see on the screen now, you can see a screenshot of all of our currently open studies organised by the team or research areas I outlined before. And you can see the bottom grey screen, box that we have some key focus areas that are pretty relevant to the talk today. And so the first one I wanted to highlight is that we have a real focus on global health work. And in particular, I wanted to give a shout out to our fabulous collaborator, Professor Mahati Chitan, who works with us in Hyderabad. And we've done a number of really interesting studies looking at outcomes for children with cancer and other serious health conditions in India, which have been really valued to us. But today I'm primarily going to talk to you about our focus areas in e-health and also survivorship. So hopefully that's useful for the context of this session. So we have a number of studies that are focused on e-health interventions in survivorship, actually 5 open studies at the moment. And so you can see them highlighted on the screen here. we have this lovely program called Ready Steady School, which is a school re-entry program for childhood cancer survivors, led by the incredible Dr. Dr. Jo Fardell and Clarissa Schilstra. And we also have an online physical activity intervention called Making Moves, led by Dr. Lauren Ha. We have a fruit and vegetable program, so it's a dietary intervention encouraging young people who've survived cancer to eat more fruits and vegetables, led by our incredible dietitian, Dr. Jennifer Cohen. And we have an incredible online peer support group for adolescents and young adults who've survived cancer as well, led by Dr. Ursula Sampson-Daly. And then lastly, we also have Engage, which is led by Dr. Jordana McClune and Christina Signorelli, which is helping to engage young survivors in long-term follow-up care. Given the time frame today, I'm just going to focus on Engage, but I wanted to kind of flag to you the other interventions we have in this space, so that if you're interested, you could look at our website, for example, and find out more about the other interventions. But I'm excited to tell you a bit more detail about really the beginnings of Engage all the way through to implementation, so right along that translational pipeline, which I thought might be of interest to this particular audience. So just to credit all of those wonderful people who I just mentioned, you can see them on the screen here, including Ursula, Joanna, Clarissa, Jordana, Christina, Lauren Ha, and then also our founding medical director, Professor Richard Conn, who's been there from the very beginning of BSU and has guided much of this work. I thank each of them for their incredible leadership in this space. So I think it would be a fair question to ask, why does the BSU do so many distance-delivered interventions? We've been doing this kind of work since well before the pandemic, when a lot of people moved to online. And the reason is probably due to our context. And so Australia has the lowest population density in the developed world. So we have 26 million people, 40 million kangaroos, and 140 million sheep. And you can see we have a very large landmass. So I've just mapped it there against Southeast Asia, including India, so you can get a sense of just how big the country is relative to the size of the population. And importantly, we only have 9 children's hospitals across that entire landmass. And so we have for many years needed to be early adopters of distance-delivered interventions to be able to meet the needs of our patients. And so when COVID hit, for example, which was interesting for us, we probably already had many more distance-delivered interventions and evidence bases around those than other centres around the world. I wanted to note also that there are different types of distance-delivered interventions, all maybe kind of termed under the term e-health. There are sort of ones ranging from telemedicine or telecare into applications which are really delivering physical and psychological treatments at a distance, often one-to-one. There's mobile health devices, there's internet-based technologies and websites and things that are potentially not kind of live, but internet-based with decision support tools and other areas. We probably in our team specialize more in that kind of like live telemedicine or telecare applications. We have multiple interventions in that space, including Engage sits there as well as a one-to-one live intervention. So trying to replicate what might be done in person, but online. But we do have other lovely programs that have used the other types of e-health tools over the years as well. So to tell you a bit about the story of Engage, I think this is a nice case study of how we've identified a problem and then worked through phase 1 and 2 trials through to implementation. And you can see the key leaders of this work down on the bottom right-hand side of the screen at the moment. So the goal of Engage was really to deliver effective childhood cancer survivorship care in the context of Australia. So I'm assuming that this audience is very familiar with the fact that survivorship care for childhood cancer survivors is very important. But just to reiterate again, it is really important because we know that 80% of young survivors experience a serious health problem by the time that they're 45. And we also know on the positive side that survivors who attend survivorship care or survivorship clinic end up with better knowledge about their diagnosis, treatment, and the late effects that they might experience post cancer treatment. They're more likely to engage in regular health surveillance. They are less likely to show up at the emergency department or be hospitalised, and they have more late effects detected and then hopefully managed relative to childhood cancer survivors who do not attend survivorship care. Unfortunately, despite all of those positives around survivorship care, our data in Australia showed us this concerning graph. So you can see there on in the red line, these are the average number of late effects or symptoms experienced by our survivors at our clinic as they age. And you can see that really going up there, escalating quite rapidly, so that you can see there that by the time we get into the 40s and 50s, we are meeting what is the kind of global average of 70 or 80% of survivors having some level of late effects. Unfortunately, concurrently, our data also showed that survivors, despite the availability of care in our clinic, survivors became increasingly less likely to attend care as they got older. So there's a significant gap there in terms of the needs experienced in the population and the engagement in care. And so that really was the reason for developing Engage. So this process has been probably, to be honest, an 8 to 10 year process, but I think we've done pretty well in that time frame. So it started with what we might call in the translational research pipeline T1, which was really discovering and assessing the problem, doing reviews and audits of our models of childhood cancer survivorship care in Australia, through to running phase 1 trials and pilot studies of different types of interventions that we could run, through to phase 2 trials, which might be considered a T3 or translational T3 stage, and then even now, excitingly, into implementation or T4. What's exciting today is that I'm going to share some data from our phase 1 pilot, and then also our phase 2 trial, which was just published last week, which is exciting, and then also give you an update on the implementation side of things. So what is the Engage program? So it's been tailored and tweaked along the way, but essentially it comprises 4 key areas or key domains. So the first area is that the first step of the Engage program is that there's a nurse-led consult with a survivor. So it's just a one-to-one consult between a nurse specialist and the survivor, either by phone, Zoom, Skype, whatever the survivor prefers, to review their medical history and their current symptoms. This information is then collated by the nurse and presented to a multidisciplinary team meeting. And that team meeting includes a paediatric oncologist, clinical nurse specialist, a primary care physician, social worker, and then that team together tailors a set of recommendations for that survivor based on their specific needs. That MDT is sometimes conducted live if possible, but since COVID, mostly that's also done by Zoom or by distance delivered. The nurse then uses that information and those recommendations to create a care package for survivors, which includes easy to use summary documents that are sent to the survivor and also to their GP. And those letters and packages to the GP have turned out to be really important. That means that young survivors are able to be managed at their local level and includes all of the important information about that survivor's treatment history, the recommendations they've received, the recommended screening schedules for that survivor, and any other risk information. Importantly, the intervention doesn't stop there. The nurse then meets back with the survivor as a one-on-one consultation to ensure that the survivor understands the information and has their questions answered, and also starts to discuss their health behaviours. So if there are any target health behaviours, those are discussed as well. For example, maybe aiming to quit smoking or to stay out of the sun or to improve their diet, for example. So wrapped around that basic intervention, we have done several research studies. So in our pilot, we had a 6-month pilot, a study looking at the 6-month outcomes for Engage, where we had a survey before the intervention, and then a second survey 1 month post and then 6-month post. So I can give you a little snapshot or summary of the data from the pilot. So in the pilot, we had 27 survivors who had childhood cancer before they turned 16. And we were really delighted in the pilot to be able to report that 72% of survivors experienced an increase in their health-related self-efficacy, which was one of our core goals. So health-related self-efficacy is really around your confidence to manage your healthcare yourself. And we felt like this was a really important target for this population because many of these young survivors had not taken over managing their own healthcare. Sometimes their diagnosis and treatment had been when they were really young and their parents had had responsibility, and that self-efficacy hadn't really built up in those young people yet. We also had a significant increase in satisfaction with their cancer care. So 52% of our survivors expressed that they were satisfied with their care before Engage, and then post-Engage that went up to 84%, which we were really pleased with. And then also importantly, only 67% of our survivors had reported that they had engaged with their regular GP or primary care physician, and that went up to 81% post intervention, which we were also pleased with. And then qualitatively in the pilot, we have just the most incredible quotes from survivors about the experience for them. And we have permission to share these and this image of one of our participants who shared that it changed my life completely. I wish I had done it sooner. And another one who shared, if it wasn't for Engage, I wouldn't be here. So really important and promising feedback, which encouraged us to push on with refinements to the program and then also a more fulsome phase 2 trial. So in the phase 2 trial, we again had the 4 core components. We did add a 5th component, which was a second or a third meeting with the nurse, which we call the booster session, about 6 months post-intervention. And that was just an informal 10 or 15-minute phone call to check in to see how the survivor was managing their health and to see if they had any questions. And we felt that that was just a sort of top-up of the intervention and seemed to be really well received by survivors. For the main trial, we actually did a much more intensive evaluation because one of the things we'd observed in the field is many interventions are not tested in the long term. So for this study, we committed to a 24-month follow-up, which was really important to see if a couple of years post the intervention, if there was still any remaining impacts. The other big change we made at this point was we realised that that initial nurse consult was really quite labour intensive and becoming a long consultation given the number of health difficulties that survivors were experiencing. So we developed a unique online health and lifestyle assessment, which was delivered by RedCap to survivors before their first consult. It is an unbelievably comprehensive tool developed by Dr. Jordana McLean with support from Richard Conn and Christina Signorelli and many others. But essentially, it assesses the survivor's health and lifestyle from head to toe. It can be it has 800 questions in the assessment battery, but because of the skip logic and AI we've used, most survivors can complete it within 30 to 40 minutes. And actually the feedback has been incredible about how much they actually enjoyed having their entire health and lifestyle assessed in one go, so they felt like nothing was missed. All of that information from the health and lifestyle assessment is automatically fed into a report for the nurse before their first consult. And then that first consult can now be spent just using that time to confirm all of the key details provided in the assessment. If the survivor has written that they're unsure about any aspects, she can clarify that at that point. And then the rest of the program is pretty similar in terms of the MDT and then the care package, the nurse-led consult, and then a booster session. And then we had a survey at both 1 month, 6 months, 12 months, and 24 months. So I'm really excited to present the data here from the paper, which was just published last week. So you can see here some really nice findings. We had 78 survivors in this phase 2 trial. And you can see here that by 1 month, 73% of survivors had experienced an increase in health-related self-efficacy. And by 24 months, 89% had experienced an increase. You can see in the graph below the mean scores for health-related self-efficacy, and I've just put in the red dots, the red X's, so you can see it a little bit more clearly on the screen. You can see a really significant increase in self-efficacy at that 1 month time point. And then this was actually maintained and slightly increased over the next 2 years, which we were really delighted about. We also measured health-related quality of life, which remained stable across the 2-year period at about 0.8 of a utility weight. So that's sort of, it's not terrible health overall, but it's not perfect. It sort of indicates someone who is managing okay with some health conditions, which sort of fits the population. We didn't notice a change in engagement with the regular GP in this study, interestingly, but we did note at the 6-month time point, or the 1-month and 6-month time point, a significant decrease in distress, anxiety, and anger in survivors. We noticed again a significant increase in satisfaction with cancer care, even maintained at the 2-year time point. And we also, at this 1-month time point, only noticed a significant decrease in information needs for survivors. So definitely really positive signs that this intervention is adding value for survivors at this time. So the next steps for us are, first of all, we have a second phase 2 trial that's just closed. This trial is tailored specifically for survivors of brain cancer. So we realised that actually their needs are a little bit more significant and they needed some tailoring for their intervention. So while the backbone of the intervention is very similar for the brain cancer survivors, they also have some additional tailoring, so additional supports to complete different steps along the process if need be, and also a different composition of their multidisciplinary team to include neurology. And so we're really excited that that trial is closed and we're doing the follow-up for that. So hopefully that trial will also show similar positive effects for brain cancer survivors. And in the meantime, we're really thrilled now that the trials have closed, that the clinical team has chosen to implement Engage now in just standard clinical practice in the survivorship clinic. It will be really fascinating to monitor now over the next couple of years how the team adapts and changes the tool over time, whether the health and lifestyle assessment will stay the same or whether the 4 core components will stay the same. It will be really interesting and such a good implementation science question. And we're really excited now that there are multiple international collaborations forming around Engage, so there might be new uses for Engage internationally over time. So if you'd like more, I hope this has been a useful summary of the sorts of work that we do in Sydney on distance-delivered interventions for childhood cancer survivors. If you would like more information, please do visit our website. You can scan the QR code on the screen, or you can go to the website link that I've added there. And you're also always welcome to email me anytime, and I'll happily answer your questions. I will join online as well, so hopefully, ask questions live as well. Thank you so much for your time. It's been an absolute honour to present some of our work, and I wish you all the best for the rest of the conference. Thank you.
We're now open to the question and answers. We'll start with questions for Dr. Claire because she's available on Zoom and it's beyond 9 p.m. there in Sydney. So,
hi Claire. Hi, it's Maya here.
Hi everyone. Hi Maya. Nice. I can hear your voice. I can't see you, but I can hear you.
Okay. Yeah. So I think all of us really enjoyed your talk. Thank you very much, and thank you for joining in so late for your time.
No problems. I'm a night owl, so this is early for me.
So I had 2 questions for you. One was about the Engage program that you just described. I think you've assessed survivors until about 2 years from the start of the program. Is that right?
Yeah.
That's what you mentioned about the 24 months. So what are your feelings about, how effective this will be in the long run? I mean, more and more. That's one question. The second question is you've implemented a wide range of distance delivered interventions, including diet, school re-entry, and of course, Engage. So amongst these, which do you think has been the most effective?
Good questions. They're fantastic questions. I might start with the last question first because it's on my mind. It's hard to know which ones have been the most effective. I think, Engage is one of our flagship programs, and we're really happy because our primary outcome, which was self-efficacy, was significant. However, it's important to note that it was not a randomized control trial because the way the clinic was set up, it was felt that it was not appropriate to do a randomized trial and not provide any care for the other cohort. So we don't know for sure that Engage is definitely effective, and that's the thing that's the core thing that is driving the change. But generally, I think Engage has been really successful. I think if I had to say which ones we have struggled to document or measure the impact, I'd say the more mental health ones, interestingly. So Recapture Life is our peer support program for young people after cancer. And it's a really interesting challenge because although we have had really wonderful qualitative feedback and such great engagement from young people from that program, the things we've been measuring haven't always shown significant results when we've tested those. And that one, we did do a 3-arm randomized control trial. There's different reasons why that might have happened. It might have been that we measured the wrong thing, or it might have been that we had too small a sample size because recruitment's quite tricky in Australia with our small population. Or maybe it's just we're not quite measuring the right thing that's actually of value to the young person. So I think there's more to be done there. Our fruit and vegetable program is lovely. And has increased in the trials we've done, did successfully increase vegetable intake in particular, which was what we were focusing on, but we haven't tested that in the long term. So it's a little hard to know. But overall, I mean, I think we're proud of the whole suite of interventions, but there's definitely more to be done in terms of really establishing efficacy and effectiveness, and then, of course, implementation. In terms of Engage, your second question around Engage in the long-term impact. The reason we did the 2-year time frame is because we feel like at the 2-year time point, they really need a reassessment again. And so the model that we're sort of thinking about for the clinic, we haven't got anyone who's gone through 2 years and then another 2 years yet. But the model that we're sort of thinking about is that survivors would have a top-up of the whole program at the 2-year time point, as essentially like replicating like a telecare intervention, replicating a clinic visit. And so essentially my thought was post that 24-month time point, they could do the health and lifestyle assessment again, and then it comes back to the nurse. She does the conversation with them again, and they get checked again by the MDT, mainly to check whether there's any new symptoms or medical problems that have occurred over that 24-month period. So I haven't thought about testing the impact of the intervention for more than 2 years at this point, because I think by then, according to guidelines, they would need a reassessment anyway. So yeah, so watch this space if that's what we end up doing clinically.
Hi, Claire. Can you hear me?
Hi, I can hear you. I can't see you, but I can hear you perfectly.
Yes, I'm Savita here from Tata Memorial Hospital. I'm the psycho-oncologist.
Oh, wonderful.
Yeah, so I would like to know that what were the challenges when you were dealing with this distance technology interventions? Because for us, when we did one randomized control trial, we had issues with language, because in India there are multiple languages, the diversity, culture, all those issues we came across. And also the technology barriers, and some people were not very comfortable with technology intervention, and they prefer face-to-face intervention. So did you also had similar experience?
Yeah, absolutely. We do have quite a multicultural society as well, and I have to say the interventions are only available in English at this point, and that's a really a big limitation. But it's quite tricky to deliver them and tailor them to each of the languages. Engage, so we have had some people participate with the support of an interpreter, which has been important. So it's not the same as delivering it in the patient's preferred language, but at least they could participate with the support of an interpreter. But then, of course, it doubles the length of the nurse consult and creates a bit more of a barrier. Technologically, we used to have huge challenges to the extent that we actually would get funding to send a device and an internet dongle in the olden days to the participants. It was a sort of specifically locked iPad where they could only use it for the purpose of the trial, and then we'd ask them to post it back to us. That was sort of clunky and expensive, and sometimes they never came back. So it wasn't ideal, but we certainly noticed an improvement in that post-COVID in terms of people being much more savvy and comfortable online. But I don't think it replaces face-to-face contact. And so this clinic still exists, and there's a lot of people who would prefer to do clinic, but it's a sort of option for people who may live really far away and really can't take the time off work to come to clinic if it's say a flight away or an all-day drive. It's helpful sometimes for people with neurodiversity who actually feel more comfortable behind the screen. So we've had a few participants say that they actually feel more comfortable being able to participate and answer questions in a sort of what feels like a safer environment. But there are some people who just don't like doing things online. So I think it's another option, and it's a sustainable option when we have at the moment quite long wait lists, like up to 9-month wait lists for clinic time. If they can have this done instead, that can be an option. But yeah, it's challenging and quite messy. I have to say, it's not the perfect science that you'd hope for when people drop out in the middle of an intervention, or there's a noisy child behind and someone forgets to dial into a session, and all of those things kind of make it messier than a really clean randomized trial that you might be able to coordinate in the hospital.
Oh, that's wonderful. Thank you so much.
Thank you. It was a great question.
Hello. Hi. Can I ask you a
Hi.
question? Hi, Claire. My name is Gauri. I'm a pediatric
Hi.
neurologist. It was so nice to see your program, which is almost like a dream. You have all the things perfectly laid out. And it's like the patient doesn't have to come, can be sitting in their bedroom and, having this consult. So a couple of questions, because we face a lot of overweight patients, sedentary lifestyles, a lot of junk food with all the advertisements you see. So my question is, for the nutrition program, what were your objective outcomes? And were you satisfied with them? And because we find nutrition counseling hardly ever works with our patients. And the second thing was, so this is a funded project, right? Do you ultimately hope insurance will pay for it, for these consults, from a long-term perspective, from a more national or global perspective?
Yeah, great questions. Yeah. So your question around nutrition is really important and thoughtful. So how we tackled that in the end, after we did a whole body of work looking at what the potential drivers of unhealthy eating and obesity in our survivors were. And we looked at all sorts of things like taste and smell changes, biological changes, psychosocial changes, different behaviors with food, parenting changes, and how parents have changed their relationship with food in meal times through the cancer center, through the cancer treatment experience. And using all of that information, we ended up deciding to focus pretty much solely on improving vegetable intake and fruit intake. So we were very clear to say for participants, this was not a weight loss intervention, but that all we wanted to do was increase variety and particularly increase vegetable intake. And there was good reason for that, because our data showed that was what dropped off the most in terms of the change in diet from pre to post treatment. And there's kind of some biological reasons potentially for that. So we did this taste and smell study where we showed that survivors had become more sensitive to bitter flavors post-treatment and showed more preferences for sweet flavors. And unfortunately, vegetables are our most bitter kind of foods. And so the program is really around kind of broadening horizons and increasing those exposure to those more bitter flavors that might have been left out while they were completing treatment. And we felt like it was therefore less kind of telling survivors that, you've got so many problems already and now you also have to lose weight. It was like, all we want you to do is eat a few more vegetables each day, a few more serves, with the hope that might, those vegetable serves might replace junk food or highly processed foods, but we didn't measure that. We only measured vegetable and fruit intake. So I think that was quite successful, and it's now, in terms of sustainability, that program specifically is now available through one of our national charities, so Red Kite. So parents can access it online, and it's delivered and sustained by Red Kite, which is fantastic. So it's no longer demands resources from the hospital. And I think that's kind of our goal for most of our work, is either it becomes part of standard care in the clinic or is delivered by a community organisation. So, for example, Recapture Life, which is our mental health and resilience program, that's now delivered by a community charity as well at a national level. So they raise the funds for it and they deliver it, and it's no longer a hospital-based program. Engage itself, we don't have insurance in the same way as there might be in other countries like the US. So if it's part of standard care, then it's kind of covered from public funding as long as it's considered standard care. So we do focus very much on sustainability in terms of the work that we do, because we can't continue to raise money for these interventions for years on end. And it's a tragedy when you finally develop an intervention and it works, and then you can't run it anymore because no one will fund it.
Yeah, so we are running short of time. So if there are any questions for any other speakers?
For any other speakers? No, I have a question for Claire.
Okay, yeah, please take. Yeah.
Hi, Claire. This is Rashmi Dalvi. And
Hi.
Nice to hear you again, and congratulations on your work.
Thank you.
I have a question. Are there any legal issues or any legal precautions you take to such a program, which for 2 years you are engaging with these patients, and in case some advice is misconstrued or misunderstood, are there any systems in place for that?
Yes, good question. We've grappled with this a lot, and we have a paper I could send you, Rashmi, if it would be helpful, about the ethical challenges and considerations around this. So some of the things that we've tackled are, so to be able to participate in the program, our participants sign consent that allows us to contact their parents and or their primary care physician if we're worried about them, because we had some times when participants expressed distress, for example, in a session, and then wouldn't show up to the next session, and they're potentially 100 kilometres away with no access. So we added that sort of safety net that if we feel like we can't contact the person, we do have permission to contact their parent or their health provider to check on them. And then we are really careful in our letters, for example, to the GP about the things that we recommend the GP do clinically. So we're quite careful in the way we frame Engage as more of it's not clinical care, it's a screening and guidance kind of program. And then the care delivery point is how we explain it to survivors is when you see your GP. And so the GP provides the care. We just help to assess what you might need, and we talk to your GP about what they might consider. But it's a very good question, good point. The other time we've had challenges is in group sessions, if we've had a young person who's relapsed during a survivorship program, for example, and then we have a protocol for that to support the other participants who are survivors who've then become bonded with the survivor, and then And if that survivor then progresses with their disease, that's really difficult for them. So we have a specific written protocol for if that happens as well. So those are the sorts of things we've tackled over the years.
I'm Vandana. My question is to Dr. Puneet. Hello, Dr. Puneet. So we have been interacting on the fertility-related issues, right, through Indian Cancer Society platform. I only had one question for you, which is very specific to a NGO setup. So, we heard Dr. Raman talking about different high-risk groups and the guidelines, etc. So if we have to focus on one particular group, which will really, I know ethically it's not right, we want to offer the preservation to everybody, but from the outcome perspective, if we want to focus on one high-risk group, which one would that be? Which would be most cost effective?
So you mean among the cancers?
Among the cancer.
So I think the cancer affecting the reproductive organs to me seem the most, because they will definitely lose their fertility and reproductive health, not only because the organ is affected, and also the treatment they are given will also affect their outcome. So if I have to just pick up one, I would say cancer related to reproductive organs would be something we should really focus on for providing fertility care.
So you mean, say,
testicular ovarian cancers?
Okay. Yeah. Thank you very much.
As we did not have the Q&A for the earlier survivorship sessions, I have a question for Dr. Greg. This is regarding the contemporary protocols kind of come down on the amount of radiation, the field of irradiation, and also doses of many drugs. So when you look at the aging survivors, the way you have shown the frailty, which is one of the like an important burden, would you think how would it change with these changes in the treatments to current treatments?
That's a great question. I think I can start by answering how have the changes in the 80s, 90s changed care. We've looked at that pretty extensively. We published in New England Journal about 10 years ago that those children from the 80s and 90s live longer than those from the 70s. So those changes matter. Chronic conditions are less. And then almost by every childhood cancer we've published from CCSS from ALL to AML all the way through that we see those changes. I think we'll expect to see that. Your question is, but now what is the future? So you're asking me to look at my crystal ball and predict the future, right? And I can't do that, but maybe we can. I think we'll continue. Well, first of all, let's just say it. A lot of the same chemotherapies are still being used. For most of our cancers, they're not going away. In some cases, they're being replaced, but in other cases, we're just adding, to those as the foundation by adding some of the novel therapies. So we still have to consider many of the old therapies and the toxicities we know, but now layered on top of it, the toxicities of the novel therapies. So what to predict? I think in some cases, we'll see overall improvement in late effects, but I think we're also going to discover some unknowns. We can't forget the lesson of cancer survivorship. That we started in the 60s and 70s, we started with cure, but then there was an aha moment about a decade later where we saw those ALL survivors. Cranioradiation gave 50%, almost a 50% increase in the cure rate. And then a decade later, we're learning the cost, right? And so what will it be this time? I don't know. Nivolumab is a hit in Hodgkin's lymphoma, potentially, right? On the current trial of nivolumab, very few children are getting chest radiation. That feels like a very good thing. At the same time, when you start considering what Darren told us, there's data on nivolumab that it might increase or accelerate atherosclerosis. If that's the case, when are we going to learn that? When will we know? It may be a decade, but that inflammatory pathway may be key. So it's all of that. I don't know if that answered the question, but maybe just sort of prepares us for the future. There may be others in the room that can give their thoughts on that as well.
Sure. Thank you. I have one more question to Dr. Smita Bhatia. So this is regarding what you had shown, like there's high yield in certain tests which you have looked into, and there's some low yield. So tests like DEXA and then tests like PFT, which have like quite high yield, like PFT showing some 84%. So when we order these investigations in the clinic, most of the times we do see that they are deranged. And how to go about it, the relevance of these abnormal tests, because mild restriction and then the patient being, the survivor being asymptomatic, not just like in that visit, but for years. So what about the relevance of them clinically, although you find a high yield test?
Right. So keep standing so I can see. No, I'm just kidding. Um, so the pulmonary function test is an easy answer. I'll take just that. There's two aspects to it. The COG guidelines say that we do the tests only once, okay, at baseline, and nothing else afterwards. Here, what we've shown is even if there's a mild derangement, when you follow them longitudinally, they continue to decline. So how can you prevent such a decline from happening? Again, being cautious and being more mindful about reducing any other pulmonary toxic agents. So absolutely no smoking or vaping. How do you handle pollution? I don't know. That you'll have to discover. But those would be the things, and being very, very quick and aggressive in managing infections, in managing restrictive, obstructive airway disease to prevent further damage to the lungs. That would be the way you would handle these. Yeah, and repeating those pulmonary function tests again to see how severe the decline is.
I have only one question and query, that how do you, when you follow this survivors for a long time, Greg and Smita both can give their inputs. How do you correlate them with various non-communicable disease? Like there is so much an overlap of all these non-communicable diseases which sets in with the age in a given population vis-a-vis the early senescence which you see in these long-term survivors. How do you overlay them in this population?
Greg, you want to answer that?
Maybe you want to clarify the question? I'm not
Yeah,
sure
so the
understand.
question is that, you saw a patient when the patient was diagnosed with cancer at age 5, and you started the survivorship follow-up at age 10, and then you're reporting all of these outcomes when they're in their 40s and 50s, average follow-up of 25 years. How do you account for all the intervening things that might have happened? So they received cisplatin, they were fine. And then at age 40, you're saying they have hearing impairment. But maybe they were avid Mobike bikers, they went and saw a ton of bad, whatever these young kids see, those shows with deafening music going on, all of those ototoxic things that are happening to them. How do you account for those that didn't do it, or versus didn't add to that effect on the ototoxicity, and it was purely cisplatin? And what do you do about those?
So that is a great question. And no study does that perfectly, right? Some studies do it better than others. I'll compare CCSS versus St. Jude Life for you. They're highly complementary studies. CCSS is very large, 38,000 eligible, 25,000 participating, but we collect that data by survey every 2 or 3 years. And you can bet by survey, we get a limited amount of information, right? So probably have a limited definite number of covariates, we'll call them, that could also be mediators or moderators of these outcomes. On the flip side, with the St. Jude Lifetime cohort, we actually collect a little more data, a deeper phenotyping. They come in for a visit, we get a detailed history in person, physical exam. We've done a maximal chart abstraction of their chart at St. Jude to collect that history. And the one thing we do with St. Jude Life that goes above and beyond CCSS in a big way is when they come in, if they self-report something that's happened out at an outside hospital, we get that information, we go get it, and we bring that in and we validate everything. So I would think when it comes to really getting all the details, St. Jude Life does a better job, but we still miss things. There's still questions like, I'm certain we don't ask about how much rock and roll music they listen to and at what volume. So we just don't know that. So everything is at risk for misclassification. There's no doubt about it. But I guess the one other thing we think about is, do we have a comparison population, right? We're reporting a rate of something, and that means nothing unless you've got a comparison population. In CCSS, we use the siblings. In St. Jude Life, we have a set of community controls. So at least we can say, here's what normal is, here's what the survivors have. But you're right. What percentage of that is attributable to the treatment is what we're really trying to get at. You're going to see a neat paper coming out. I believe we're inches away from getting a paper accepted in Lancet Oncology. If we do, this will be by Yadav Satkota. And in this paper, he looks at the attributable fraction for the risk for second cancer. So when you get a breast cancer, what is the attributable risk due to chemotherapy and radiation? And in this paper, we're adding on genomics and genetics. What is the attributable fraction that's due? So in that paper, we'll in some ways build, but it doesn't by any means get all the covariates you've mentioned. So misclassification is still there at the end of the day. Smita, did I get it? Anything you'd add?
So the only other thing that I want to add, and that's something that I think we all need to be cautious about, is we start our cohorts at 5 years out from cancer diagnosis. A fair number of children die in the first 5 years. So if you're doing genomic studies and looking only at survivors, we're not taking into account those genetic variants which caused early death. So we might be underestimating the association between genomics and these long-term outcomes. Something to consider when, Maya, where are you? Here. So when you and your mentee are setting up a study, best to collect those samples upfront at diagnosis and reconstruct the whole story from diagnosis onwards, rather than waiting to collect a 5-year survival or beyond.
Right. So that would be the end of this session. Thank you, everyone. Thanks to the speakers. Claire, thanks a lot. It's quite late in the evening. It was nice of you to have logged in. And thanks to the chairs as well. So we will quickly break for a tea break for 10 minutes. We are running a little late. And there is one announcement to make. The posters are being judged right now. There are 4 posters yet to be judged. Renu, Ria, Ganesuni, and Himani. If you are here, please stand by your posters. The judges will meet you. Thank you. Thanks, everyone. We'll reassemble in 10 minutes.
I invite upon stage Dr. Vibha Bafna to start this session 7, which is survivorship, learning from each other. Dr. Vibha Bafna is consultant based out of Pune, practicing pediatric oncology from Jahangir Hospital. Over to you, ma'am.
Good evening, everyone. Welcome to the last session, but not the least. I invite Dr. Greg Armstrong for his talk on lessons from collaborative efforts in cancer survivorship. We've heard him through the morning, through excellent talks, and I'm sure this will be the best. Welcome, Dr. Armstrong.
All right, thank you. Let's see. All right, so I was challenged to take the topic lessons learned from collaborative efforts. And I'll be honest, that's a new topic for me. And I like the challenge, new slides, new thoughts. And then Smita just told me I only had 5 minutes, so I'm going to move pretty fast. You guys ready? Buckle your seatbelts. Here we go. I want to give you 3 examples of thinking collaboratively, thinking globally. Number one, these should be numbered 1, 2, 3. I promise you they were on the slides I submitted, okay? But there's been some magic to some of these slides through the day, as you've noticed. So here's more magic. But number one is novel discovery of late effects from an international collaboration. I want to show you that for small or low prevalence outcomes, combining our data is really important and will lead to new discovery. Number 2, developing one set of guidelines. We've heard a lot about that today, so I won't go too long into that. And then finally, thinking about the future of global collaboration and other happy things. And I called it other happy things because if we work together, this is childhood cancer. We should come together. There's no reason across the world we shouldn't be working together. So let's talk about how and why. All right, so let's talk first about continued discovery in anthracycline chemotherapy. Here's a discovery that we really only could nail down by working collaboratively in an international way. 10 years ago, there was an early bit of data, early signal that there were some children growing up, females, who were developing breast cancer after childhood cancer, but they had not been treated with radiation. And you can see from CCSS, a paper titled Breast Cancer Risk in Childhood Cancer Survivors Without a History of Chest Radiation. That became a JCO paper. How in the world was that happening? At the same time, the Dutch published a paper, Long-Term Risk in Subsequent Neoplasms, and both said, hey, wait a second, there's an increased prevalence in women who have not received radiation. What chemotherapy is doing this? And there were a lot of questions. Could it be anthracyclines? Could it be the alkylating agents? Or could it just be an underlying genetic predisposition? Maybe they had some genetic predisposition for breast cancer and we hadn't discovered it. So CCSS took a deeper dive on that and did a nested case control study of 271 women with subsequent breast cancer and looked at the odds ratio of breast cancer that it increased with the cumulative anthracycline dose. So here's a step of evidence saying that actually for every 100 milligrams per meter squared of anthracycline, the risk increased, or the odds ratio is 1.23. So a 23% increase in risk with every increasing increment of anthracyclines. Dose response evidence, increasing the level of evidence. But this analysis also stratified by patients who did and did not get anthracyclines. For the no anthracycline group, no surprise that with increasing dose of chest radiation, an increasing risk of breast cancer, 10-fold risk above 10 gray. But for the anthracycline group who had radiation plus anthracyclines, their risk up with 10 plus gray radiation was 19-fold. That's twice, that's a doubling. So it really asks the question, is there an additive effect of anthracyclines plus radiation? St. Jude Life study came along at the same time and looked at the independent risk of genetic predisposition in this population and said it's not the underlying genetic predisposition. It took that off the table. So more evidence to say there's something in the chemotherapy, maybe the anthracyclines. But here's the thing. That was in one study or a couple of studies individually. We actually needed to pool data. And I want to show you that published in 2023, the results of pooling data, subsequent female breast cancer risk associated with anthracycline chemotherapy. Smita referred to this when she was talking through the guidelines. You remember she paused at the anthracycline exposure and breast cancer guideline and saying that it might be updated. And if it's going to be updated, it's going to be based on this evidence. When pooled, 17,943 female survivors of childhood cancer across 6 international cohorts, it confirmed that that 100 milligram per meter squared hazard ratio of 1.24 And it showed that above 200 milligrams per meter squared cumulative dose of doxorubicin, there's a 2.5-fold increased risk, solidifying that evidence. So finding support that early initiation of breast cancer surveillance, sorry, let me get rid of that box if I can, I don't know how to, may be reasonable for survivors who receive more than 200 milligrams per meter squared of cumulative dose. Now, we'll see the next time the guidelines or literature results are reviewed if that increases. But if it does so on the back of good collaboration. Okay, I'm missing more arrows on this, but just the point here, 6 groups, a couple from the United States, St. Jude Live, CCSS, the National Women's Tumor Study, but the Dutch later cohort, so the Netherlands, the French Childhood Cancer Survivor Study, the Swiss Childhood Cancer Survivor, international collaboration. And for the sake of time, I'm not going to go through the details of this data because I think we've got the point from that overall overview slide. I'm just going to skip through that and just say that there are a number of other things. So all the more reason why you should think about systematic assessment of your population. We need to know what Indian survivors, their experience, not from your anecdotes, but from systematic assessment, and maybe even developing a cohort. All right, number 2 example of international collaboration, Smita and Dr. Arora mentioned this very nicely today, developing one set of guidelines for the whole world. And this, of course, is the International Harmonization Guidelines led by Leontine Krimmer, Melissa Hudson, and many others. And again, because you've heard about this from Smita, I'll just highlight, you know this has happened. There's been harmonization of more than 20 survivor health surveillance guidelines. And as Smita told you, there is evidence for these, but the evidence is in the linking with late effects. What therapies lead to what late effects? Strong evidence for that. But where we don't have evidence, as Smita and Dr. Arora both told you, is for actually the screening recommendations. We don't have evidence, and we may never, to be honest, for many of these things, because it takes hundreds of thousands of people in a trial to really develop evidence for screening recommendations. But here it is. Here's the complete list of all the things that they've accomplished. So that's a great example of harmonization, of a worldwide collaboration. But let's talk about the future. Let's dream a little bit. Let's think out loud a little bit. Maybe the things I'm going to say here don't come to realization, but maybe they do. And maybe we start with a little brainstorming. So beyond North America and Europe, where do we really need to consider advancing knowledge through the development of survivorship cohorts as research platforms? Systematic assessment, systematically bringing in a population, systematically assessing them the same way so we can really measure these things in India and understand the risks here and the implications here so we can have targeted interventions here for your survivors. So I'm going to go back to Smita's wheel diagram. I love this diagram. I always come back to it. And I'm going to say there's a critical principle here as we think about the future. Number 1, success in cancer survivorship has been on the shoulders of large cohort studies. Success in cancer survivorship has been on the shoulders of large cohort studies. So why not now? Why not here? Why not with a few of your larger institutions in India, can we put together a cohort? We know how to do it. Is there the capacity to do it? Let's think about it. Let's have those conversations here. But critical principle number 2 is ultimate success is dependent on dissemination and implementation of the science, right? This wheel diagram is not complete unless you disseminate the information back to the survivors. That's how you close the circle. And when I was young in this career, I really thought all of the bang was in the first 2/3 of the circle, generating the discovery, generating the evidence. I wake up halfway or 2/3 through my career and say, that's actually not the case. We can keep discovering, but if it never gets back to the patients, how much does it matter? It's got to get back to the patients. Okay, so this is where I really want to talk, is how to ultimately disseminate and implement this science back to the survivors themselves. Now, when I became chair of our department, in part of a 5-fold vision, one of the elements, just to show that I'm not making this up for this talk, one of the elements that I decided was mission critical was implementing guideline-based care to all survivors. I don't want to end my career not closing the circle in this wheel. I don't think any of us do. So we've got to think about it. We've got to put some effort and resources into it. So who do I turn to? I turn to Melissa Hudson and Matt Earhart. They're the leaders for the COG guidelines, along with Smita, Melissa, and Wendy, and Sandy Constein founded them. Matt and Danielle Freeman are now the leaders of the COG guidelines. But here's the problem. After 20 years of development, current guidelines have had a limited impact in community settings in the United States and North America due to poor uptake among practitioners and survivors. So we've got guidelines and we've got incredible evidence that has driven those guidelines. But if that evidence isn't getting into the hands of the community providers, it's not effective. And so here's the evidence that it's not getting into their hands. This is from the Childhood Cancer Survivor Study, Adherence to Surveillance in Childhood Cancer Survivors. Look at colorectal or cardiac dysfunction. We've progressively, through 2003, 2007, and 2016, as measured in CCSS, have seen incremental small increases in adherence to these screenings, but we haven't gotten to 50% in any of them. If we're not getting to 50% of the population, we're really not succeeding. So we can't be satisfied. So Madam Melissa, oh, one other slide is the need for international implementation. You know, we could start first in just North America and try to be successful there, but that wasn't my vision, and that's not Melissa or Matt's vision either. The reality is that only 10 to 15% of childhood cancer survivors are diagnosed in high-income countries, suggesting that this problem isn't just a North America problem, it's an everywhere problem. You told me today, and I didn't know it, 500,000 survivors in India, then this is an India problem too. We've got to get this information into the hands of the people that will be caring for them for their lives. Now, the problem is different across continents, no doubt. How we solve the problem may be different, but it's a massive problem. So in the United States, here's what we've started to do. To address poor rates of guideline adherence, we've actually done a survey on 1,200 providers in the United States to really start listening to them and see what their practices are, current practices are, and what their needs are. Now, this is not published yet. Matt is working on this publication. What I want to focus on, you don't need to look at this entire dashboard, but this survey of 1,200 survivors included 38% were in family medicine, 26% internal medicine, and 18% pediatrics. So there's your primary care providers. But we also went to subspecialists. 10% were OBGYN, 9% GI, 6% cardiology, 6% endocrinology. So now you know a sense of what clinicians filled out this survey. And here's what we found. When we asked them about, okay, a little more magic. Okay, here we go. We asked them about awareness of the COG long-term follow-up guidelines. Only 37% of these 1,200 survivors were aware of the guidelines. 2/3 were not. So there's a problem right out of the gate, right? If they don't even know that there's guidelines, how in the world would they be using them? And they certainly won't. The second was among those who are aware of the guidelines, how many are knowledgeable? And only 8% were fully knowledgeable and 13% somewhat knowledgeable. So 21% of the population would say they were knowledgeable about the guidelines. So clearly, our primary care providers and subspecialists in the United States are not facile with the guidelines. But here's the good news. There we go. Openness to changing current screening practices based on evidence-based guidelines. When we asked them, would you be open-minded if you knew about these guidelines to use them? 88% said, yes, I'd be open to that. So there's a window of opportunity, we do believe. Far too busy, I understand. But to address poor rates of guideline adherence, we also have to think about the cost. So in the United States, we performed an economic analysis of the costs and benefits of guideline-directed screening within the U.S. payer system. We thought about a population-based assessment. And for breast cancer, very simply, this table provides the COG screening guidelines, the comparator for the general population who are at high risk, in this case for breast cancer. And then in the end, what would be, based on a lot of assumptions and calculations, the net cost savings if universally, let's say Medicare or Medicaid paid for and provided for screening. And this study estimated there'd be 500 million to 3.4 billion saved in cost across the entire US population. Now, we don't have time for the details. I know you want to say, how did we get to that? This is an abstract submitted to ASCO. And so hopefully at ASCO this summer, if any of you are attending, we'll have the opportunity, or Matt Earhart will have the opportunity to present this. But we think there's now a good argument to the US government to say, hey, there's reason to say we could save money if we were screening survivors and doing early detection for breast and colorectal cancer. So here are a bit of summary of what we think we need to be doing in North America, and that is address provider knowledge gaps by leveraging professional associations, peer networks, and educational tools such as UpToDate, for example, to increase awareness and utilization of the guidelines. Coordinate with decision-making bodies that issue preventative and high-risk screening guidelines to align recommendations and designate survivors as high risk. Partner with advocacy organizations, you guys do this very well, to launch education and advocacy programs. Equip patients with materials and resources to empower them. And ultimately, number 5, to identify opportunities to facilitate increased provider utilization of the guidelines and survivorship care plans. So in closing, I want to throw out a process, a global process that Matt and Melissa and others are thinking about. In fact, Matt and Melissa and Nikhil Bhakta from St. Jude just flew to Amsterdam a couple of weeks ago to meet with Princess Maxima and talk about really a worldwide vision and kind of coming together. And because the problem, we believe, is that when you think about how much work, you saw Dr. Aurora lay out how much work it goes into these guidelines and to going through the data, parsing through that data, and making decisions. It's a lot of work, from formulating the clinical question, comprehensive literature review, assessing and grading the evidence, the expert panels, formulating the clinical questions, guideline development and publication. And both COG and IGHG go through these process. And Smita, this is something maybe you can answer. I've never quite understood. And maybe naively, I thought when the International Harmonization Group started 10 or 15 years ago, that they would do it for everyone and obviate the need for COG guidelines. But clearly, both groups are combing through the literature, and it seems like a massive extra effort than what needs to happen. But then after that, you have groups like PanCare who come in and use the literature review, but then do their own expert review and formulate a version of the guidelines, and other groups do that. And then as well, the Chinese cancer group and other groups that ultimately, as Dr. Aurora just said at the end, take these all the way full process and then adapt them locally. But I think the question at hand that Matt and Melissa has raised is there's countless of hours lost in this process, attempting to meet all the group's needs, duplicating processes, and maintaining currency. And so the question becomes, can we just unify that process? And Dr. Aurora alluded to ARIA. And I don't know if you heard about ARIA yesterday, and I know I'm over my time, but I've only got 2 more slides, I think. I don't know if you heard about ARIA yesterday. You're certainly going to hear about it tomorrow from Nikhil Bhakta. But ARIA is an adapted resource and implementation application. And ARIA is intended to be used for protocols, treatment protocols, the adapted management guidelines to take treatment protocols that might be used, let's say, at St. Jude, but then adapt them locally based on resources and needs. And so while not designed for survivorship guidelines, if it's going to be used and implemented for protocols worldwide, why not just use that platform to also place the guidelines there and then have a one-stop place for guideline availability? And so that's what they were discussing in the Netherlands is, could we just globalize this? Could we just standardize this and do it once for all for everybody, right? And so this is what that process could look like. Here's the same process at the top. Oh, the fun art is gone. It doesn't look so nice anymore. But imagine the whole world coming together to parse through the data one time together. And then imagine having some central coordination and facilitation of resources through Princess Maxima and St. Jude to centralize all of this process and ultimately place it in a place where everyone can get to it. The ARIA guide portal that contains globally developed resource-adapted survivor recommendations. Then, once available globally, they could be available to each of you who need to locally contextualize them based on local needs. And so ideally, that would be a more efficient process, resulting in globally developed and agreed upon recommendations, elimination of duplication, and facilitating rapid regional endorsement and implementation. So this is the vision. This is the thing we're thinking about, beginning to work towards, and would be eager to join forces. So with that, I'll thank you. Again, all of this work is team science. It's a big team, and it's been really a privilege to talk to you today. So thank you.
Thank you, Dr. Greg, for that excellent talk. Now, I invite Dr. Rachna Sheth for her panel discussion.
Good afternoon, good evening, everybody. Thank the organizers for inviting me to conduct this panel discussion. And without any delay, I'll call the panelists. Dr. Smita Bhatia, Dr. Purna Kurkure, Dr. Rashmi Dalvi, Dr. Tejpal, Dr. Vandana, and Dr. Savita, please kindly come. So while they I think anyway it's fine. So I'll be quickly taking you through this overview in the next 45 minutes or so in a primarily a case-based discussion mode. So while I think there's some distortion with the slides, but I'll just continue. So just thank you panelists for joining, and I just start my discussion now. So to give you a background, we all know that I think it's loud enough. Is it loud enough? Yeah. So we all know that with advances in cancer treatments, our survivorship has improved and we have a growing population of cancer survivors. And of course, we all have been dwelling on this, that of course the survivors, whatever disease, are at a higher risk of chronic health conditions when you compare to the controls. The blue dotted line is indicative of the controls. And of course, this can take various forms of organ systems being affected. Particularly, these reflect as one form of the late effects. So with this, again, then this burden, what I just mentioned regarding the late effects, is just not tuned, it's just restricted to just the late effects. The burden with cancer survivors is huge. There is a concept of premature aging, frailty, increased hospitalization, mortality, post-traumatic stress, aging, etc. It's the whole gambit of psychosocial issues. So the problem with cancer survivors is huge. But also it is true that we know that even in the Western countries, these survivors, only about 1/3 are receiving cancer-based survivorship care. So this is one big lacuna that that the cancer survivors are facing. And there's also this concept of what is the best way of this long-term systematic care that these survivors need. So there are these basic concepts, this model of survivorship care. These could be either traditional hospital-based, oncology-led, the oncology, the nurse practitioners, the primary care-led, shared care, or the most popular that we see getting cut, the shared care or the survivorship clinics that are most popular. So with this background, I would put this question to Dr. Smita, Dr. Purna, and Dr. Rashmi. What is your opinion regarding the various models that we have and the most popular survivorship clinics that we are resorting to and are using it in our practice now?
Dr. Rachna, thank you so much for that question. I'll give you the opinion on the US side, knowing full well what the issues are in India as well, but Dr. Kurkure will handle that one. In the US, it's very much based on the context. So several centers have pediatric oncology programs. They're mainly in the academic setting, and most of them have developed long-term follow-up clinics. And in many cases, these clinics allow longitudinal care regardless of the age of the survivor. In some settings, the childhood cancer survivors are not allowed to be seen in the setting of a children's hospital, and they have to be transitioned into an adult setting. Shared care models are rarer. They require a lot of coordination, but sometimes they do happen. And then the least common and often hard to implement is the transition to an adult oncology program or to the community hospital. So I'll stop there.
Thank you.
In the Indian context, we started this as a very important part of our pediatric oncology program at Tata Hospital way back in 91. And when you start, they are all children. And I was in the setup of this Tata Hospital where you have adult colleagues to take care of children who have grown into young adults. So that was not an issue. The questions were not asked as to how they can enter the hospital for medical care beyond 18 years of age. But now I am at a place where I am questioned because it's a dedicated children's hospital. And we will have to think of how to transition them. Now, transitioning them for a standalone children's hospital, which may exist in the country and have the survivors with them, is also huge. So we have to think as a dynamic process that you may begin with a late effect clinic, but you have to also consider the context where you are located, whether you are in a adult, whether you are in a super specialty setup, cancer center where the age is no bar, or in a pediatric setup where you will have this constraint of age beyond a point, and management means the management will not permit you to look after these children. So how to transition them? So that is the next phase which I have been thinking as to how to do it in this setting. So far, I had never faced. Also, the oncological care like second malignancies and other things, particularly second malignancies, were taken care of so nicely and smoothly at Tata Hospital, but not so when it comes to Children's Hospital. So this is something now we have to work on it. But what I understood from my experience at Tata was that we need a model where we depend very heavily on a civil organization, civil society organization that is not for profit, because this care is not being taken care of and not looked at in our health system. So we do need it beyond the boundaries of the hospital. And that is how we propose this model of medical care, medical stroke oncological care at the pediatric cancer unit, joining hands with not-for-profit organization for many other needs and psychosocial cares, also looking after the late effects. So this combination led to this partnership project called Picasso, and that is working out well because we do need support at this stage of not-for-profit organizations to run the show.
That I think we'll be discussing Picasso. Dr. Rashmi, what is your opinion on this?
The models that Dr. Rachna had put up, I mean, it's like one size doesn't fit all. So one has to see in one's context what works and what doesn't work. So basically what Dr. Purna has said, what Smita has also said. So for example, you saw Claire's talk where she showed a nurse-led program which they have been running. So which obviously is not going to work for us. And also it depends on what kind of hospital situation you are in, whether it's a children's hospital or it's a multi-specialty hospital with other departments available to you. You can have everything in one place. Because, for a survivor to come and then to go to 20 other places, it's logistically very difficult, and we will lose many of them to follow up. Of course, telehealth is going to help us. But so also I want to say that hospital-based and shared care is also a model that can work in our situation, because we are closely connected with the pediatricians and we have to develop a network with adult physicians as well. So it's, we have to find our own way around. But one thing I want to say is that we have to keep it simple for the patients and the parents, as well as simple for the physicians managing, and the shared care if we are going to go in for shared care.
I think shared care will be the model in the times to come, because the numbers are increasing, I think, with every center. So in some form or the other, I think shared care will be the rule with many centers. So quickly we'll be discussing this. I think partly has been covered up, but then this consensus statement from India, from our centers, came up a while ago on setting up of survivorship clinic. This was the result of a workshop that was conducted in one of our FOCONs. So in this is just to gather the opinion that is it rational to classify our survivors into low, moderate, and high risk? And the attributes that have been selected is the chemotherapy exposure, whether it is low dose, moderate dose, or higher dose, or any radiation that has been received, the risk of recurrence, and the extent of toxicity that we are expecting. So these are the criteria that was used, and then the surveillance plan was formulated that for the low risk, we'll just follow them up annually for 2 years, and then there could be a virtual follow-up. For those at moderate risk, we could follow them manually for 5 years, and those at high risk, physically for 10 years, and then it could be on a virtual. Of course, desired would be that they should visit the primary teaching center every 2 years. So are you sort of fine with this model? We have incorporated that into our models in our survivorship clinic. So we put in these boxes where we tick the moment the children are, registered into the survivorship clinic, and we sort of designate a survivorship plan for them. So these questions are going to ma'am and Dr. Smita. So is this template suitable, and would you like to advocate it to the centers who are doing survivorship care? We can be very brief with this. And for Dr. Smita, I think you partly answered it, but if you would want to add to this.
No, theoretically, this is right, that we have to classify them and wean them off as we go by. But the practical problem is that survivors, they tend to latch on to this late effect clinics, whatever you may do, and they grow out of the age and the risk zone, still they want to come back to you only. That is my practical experience. I don't know what Smita and others they face, but this is it. Like they are there for you for the whole life.
So there's many facets to the story. I am glad you've developed this risk stratified model, because it's not humanly possible to continue to sustain this follow-up long term of the entire population. The important thing will be to keep studying this group of patients and refining this risk stratification based on what you've established. For example, your intermediate risk group might actually be needing either high or low risk to fall into those two categories, and you'll have to refine that going forward. And then the final thing is the high risk group. We know that risk doesn't end. So even beyond 10 years, you might need to continue to follow them long term. That's the issue.
Okay. I'm really sorry for the slides. I checked them there. They were all quite well aligned, but somehow they seem to have. Now my next question is, I'll just
Can I just
go on with this? Yeah,
Dr.
please.
Can I make
Yes,
a
please.
comment? Yeah.
Yeah.
So I echo the sentiment of Dr. Smita. I think 10 years is certainly not the last, and most of the radiation-induced second cancers would actually happen only 10 years and beyond. So, of course, I mean, the frequency of visit can reduce, but the risk never ends. It's lifelong.
It's a lifelong. That is a caveat that we've put in, but yes, I accept all these limitations. So going ahead, Dr. Vandana, you are from the Indian Cancer Society and are, well associated with the Picasso project, which stands for Partnership in Cancer Survivorship Optimization. So this has been developed and you're really into it. So what is your experience with the Picasso project, and how has it influenced our survivorship studies, and how has it integrated into the survivorship clinics and the C2S study that we have been all talking of?
Thank you, Dr. Rachna. So as Dr. Kurkure mentioned, this is one of the initiatives by a non-profit organization, because again, a country like India, we need to be a little bit innovative, because pediatric oncologists and the hospitals are way too busy. So how can we complement as non-profits to the pediatric cancer units was the thought process. And basically the model is that the pediatric cancer units start the clinic. So the pediatric oncologist becomes the champion there, and the Indian Cancer Society complements it through the psychosocial care. And it started with the ACT clinic at Tata, which was started at 1991 by Madam and now taken care by Maya and Ram. And the survivors who were following up in that clinic, they started their own support group called UGAM, which was registered with the Indian Cancer Society. So the psychosocial model was developed with UGAM. So, this was like A plus B putting together, that the medical care is taken care of obviously by the pediatric oncologist, but the psychosocial care, which is many a times missing in our country. So putting resources, like Dr. Gauri also said in her talk today morning, that the role of NGOs, which the oncologist envisages, number one, resources, and number two, knowledge sharing among the survivors. So with these two objectives, Picasso was formed. And you asked me about integration. Yes, I think it really started with baby steps. I mean, I still remember walking to Wadia Hospital, going, literally doing 6, 7 meetings as to how should we work together. Earlier thought was they would just refer the patients to Indian Cancer Society, being, in proximity. But then if we want to scale up, everywhere there is no Indian Cancer Society branch, then how do we do it? Hence, putting psychologists in these units who will then refer to Indian Cancer Society for the needs identified. So whether it is an educational scholarship or it is a late effect which is identified by the oncologist, if we need to, put in financial support for that, that was the main objective. Integrating it, yes, I would say, although it started with baby steps, very happy to say now that there are 16 hospitals which are kind of running these clinics. More than 5 or 6 were already having the clinic. We only provided the psychologist, but the others, actually, because of Picasso, they could be sensitized to start the clinic. And integrating it into the C2S study, yes, because this is, a continuation. So when you're talking about C2S, it is a research study wherein the survivor is enrolled immediately after completion of treatment, or say between 3 or 6 months of completion of treatment. And we are talking about ACT clinic, which is a long-term follow-up after 2 years of disease-free interval. So I think it is natural that they will kind of, integrate into the Vikas.
Thank you.
Thank you.
Thank you. So again, now the rest of the discussion would be primarily focusing on various aspects of late effects, which we all know what they are, and of course, what percentages. According to Western data, there are about 2/3 of the survivors would have one form of late effect, and 1/4 or 1/3 would be life-threatening for these survivors. But then again, and we know the spectrum, the causes that cause these late effects. But again, what I feel is that the understanding or the mechanisms of occurrence we've been hearing since morning is expanding and expanding. Genetics, use the biomarkers, cancer predisposition, all these are coming up in a big, big way as to, they are going to be responsible for the occurrence of late effects. These are the spectrum. The arrows that you see we'll be discussing a little in detail today. And again, this has again been discussed, so I'll go through this fast because the simple question is that, does the profile of late toxicities in long-term survivors in India differ from that occurs in the West? And I think maybe the answer is going to be yes, because in the recent study from TMH by Dr. Maya and team has shown that over 3,000 survivors, almost 2/3 had little or either had no effect or very mild late effects. Again, contrary to what we've been conventionally reading. And the profile of late effects was also different. In the interest of time, I'm not going to go into detail of this. And also a similar study primarily focusing on neurocognitive deficits in ALL survivors from our center also reflected the same, that what we have been reading, the reasons, etc., have been different because the socioeconomic background, the opportunities for survivors are totally different for the Western cohort when we compare to the Indian cohort. And from the other Asian countries also, as well as from our studies, we've found that socioeconomic strata, parental education, birth orders, etc., are important risk factors for neurocognitive deficits. So I think all these, the more and more, I think there is a reason, and it's becoming visible that we need to evaluate the spectrum of our late effects. So coming to this first case scenario, again, I'm going to focus on the neurocognitive deficits. The term that now we all are familiar with is more cancer-related cognitive impairment, CRCI, because what we realize is it is a big spectrum of even neurological deficits that occur, and cognition is only one form of the neurological sequelae that occur as the late effect in a survivor. So it is today we'll be focusing only on cognitive decline as part of the CRCI spectrum. Again, the definitions are known to everybody. I'll be skipping through it. So we have a case. This was about a 7-year-old girl child who presented to the emergency with the complaints of single episode of generalized tonic-clonic seizures. And then she had this MR where you see a irregular, cystic solid lesion in the right frontoparietal region with some evidence of calcification and hemorrhage, and then a midline shift. And then again, a mass effect was there. She was operated outside with frontal craniotomy with subpleural dissection, and her histopathology showed to be ependymoma, WHO grade 2. All this happened outside. Then she came to us after 1 month, where we saw that a month later, there was still a significant residual tumor here. She was put on chemotherapy. This was done at our center. But then again, after this, there were a lot of ups and downs where there was so there was this child was put on chemotherapy, but then again, During chemotherapy also, there was some clinical worsening, a possibility of progression was kept. Again, a neurosurgical intervention, etc. was done. Then even EVDs, Omaya, all these interventions kept on occurring due to the complications that kept occurring. Ultimately, there was a total resection, and this child was planned on RT and was started on RT. Then subsequently, again, she went into a series of complications where there was features of hydrocephalus, periventricular ooze, cranial nerve palsy, shunt infection. Everything possible happened in this 7-year-old girl child. So ultimately, we could tackle all these, and the treatment completed by 15 months of age required 4 major prolonged admissions and 6 neurosurgical interventions. So then now my question is to Dr. Tejpal and to Dr. Smita subsequently. First to Dr. Tejpal, how would you approach this child for CRCI? Opinion on the exposures, multiple exposures that she had, complications that you would anticipate, whether these are modifiable or non-modifiable, and whether they would progress with time.
So thank you for sharing the case. I think this child ideally should have undergone upfront radiation therapy. The role of chemotherapy is not so proven in ependymomas unless that chemotherapy is being given to sort of shrink the tumor further and facilitate a gross total resection. Having said that, it's unfortunate that there were multiple neurosurgeries, and all of that contributes to cognitive impairment. The tumor mass itself, the chemotherapy, and of course, mostly the radiation therapy. Without the radiation, you would not achieve a very long-term survival or cure. So radiation is absolutely important and critical. But use of modern techniques, I see the dose that was delivered was 50.4 gray. So that's not very high dose of radiation. Normally for a grade 2, we generally give 54 gray in 30 fractions. But the more conformal technique that you use, you can reduce the risk of cognitive impairment. And particularly now with the availability of proton beam therapy, where normal adjacent brain parenchyma, you would be able to significantly reduce the dose to the normal brain parenchyma. So it would be recommended to use proton beam therapy if available and affordable. Of course, it is, I mean, I don't think the radiation-induced cognitive impairment is something that you can, it's not avoidable, but certainly modifiable if you use modern techniques and new technology. The dose and volume of radiation remain the most important factors that determine cognitive impairment. And if you can go back to the question, maybe I can just, yeah. So you would expect not only cognitive impairment, you would also expect endocrine. It was close to the suprasellar region, so you would also expect neuroendocrine sequelae and pituitary hypofunction. Fortunately, that can be addressed by supplementing with hormones externally. The neurocognitive state is, unfortunately, the decline is irreversible. So it's not that a few years later, 5 years later, the child would have it does sort of slow down and stabilize, but it doesn't reverse.
It is known to progress on the other, on the contrary.
It can progress depending on this late sequelae. So you get leukoencephalopathy because of the radiation, or if there is a shunt blockage, hydrocephalus, all that can certainly lead to further progression.
Okay, so these are some of the acute complications. Would you want to just, I just skip, I think you've covered most of these. Should I just go ahead? Dr. Tejpal, should I go ahead or you want to cover these?
No, I think you can go ahead.
Yeah, so I think that is, so again, Dr. Smita, you want to add something on this?
No, I think Dr. Tejpal covered it beautifully.
So I just, if you could just mention something about the proton, and then again, the logistics that are, I mean, akin to Indian setting. It's
so as I mentioned, the dose and the volume of radiation are the most important, but also the modality now between the standard photons that come from a linear accelerator versus the protons, because of the depth dose characteristics that Dr. Lashkar showed in his talk. The surrounding normal brain parenchyma is exposed to much lesser dose with protons, and the less normal brain is exposed to the radiation, the lesser would be the late neurocognitive impairment. Of course, that comes at a cost in the sense that protons are not easily, I mean, they're expensive and not accessible to most patients in the world. Even
as of today, as we speak, less than 1% of all cancer patients that need radiation get treated with protons. Even in childhood cancers, that figure stands at only about 2 to 3%. So it's not that 97% of our children still get treated with photons. We have to make it more available and accessible to our children.
So I'll skip the screening part because in the interest of time, yes.
Dr. Ratna, for neurocognitive functions in this setting, while it is inevitable to treat this child with radiation and other things, the early interventions, not to wait for the late effects, because as you treat, you know that you are going to land up with the problems. So early neurorehabilitation has a big place in such situations. And it is said that when you start the interventions early, anticipating the problem, rather than waiting for problems to arrive, it does make a difference. So perhaps early neurorehabilitation.
That's that's the question to Dr. Savita. So this child is about 8 years. So you just read this. So how would you approach this? If briefly, we can have your answer.
Thank you, Dr. Rachna. So, as we are actually listening continuously about neurocognitive deficits, and in this case, surely, the child has undergone multiple procedures, neurosurgeries, and there are also consequences of disease. So, looking at the case, and as we practice in our hospital, when a child is planned for radiation, pre-radiation, child is referred for neurocognitive evaluation, and at baseline, because that is we consider baseline treatment wise, but otherwise surgery and disease at itself has already done the damage to cognition. So when the child comes to the clinic, we do detailed clinical interview and take consideration of all the developmental task which has been performed. That is taken as a baseline for the functioning. And then the standardized age-appropriate neurocognitive tests are performed to do evaluation. When we talk about neurocognitive is not just, the functions which brain-related higher mental functions. When we talk about neurocognitive, we have to take into consideration how it is going to impact on other, areas of child's quality of life. Because if suppose any child is having neurocognitive deficits, definitely then is lagging in scholastic performance, and that is going to hamper the self-esteem, also the facial palsy, and even the scholastic performance not being good can create low self-image. So that is hampering even behavior. And the behavioral issues are also because of the neurocognitive deficits, because probably low judgment and poor goal-directed behavior can lead to ADHD, hyperactivity. So all these things are also taken into consideration when we are evaluating. Parental assessment is also there, interviews also taken in depth, so that we understand the social dynamics and not just the treatment and the disease related part, but other aspects which are impacting on child's overall, what we can say, overall performance or functioning. Yeah. So, and the next was, I think there was
Briefly, you could just touch on the interventions. I think you've by and large covered. So anything else you want to add for the intervention part?
Yes, in the interventions, as Madam has said, early integration, scholastic program, individually, we have to address all the issues. And probably we also have to take into consideration the support network which is available here, like Indian Cancer Society, other NGOs, Impact Foundation, because there are multiple needs of the child, and most of the agencies have their own protocols. So accordingly, what fits best for the child to rehabilitate actively.
Okay, thank you. So this was just summary slides I'll be omitting. So we come straight to case 2. So this is a 13-year-old male child treated for left-sided chest wall events. Sarcoma, received multimodal treatment, completed treatment in 2020 when he was about 15 years. Exposures knowingly would be anthracycline, ifosfamide-based radiation to the chest. And of course, surgery was done, excision of 7th rib was done, and he was evaluated in the survivorship clinic, keeping all these comorbidities in mind. So his growth was by and large fine, but then what we picked up was ejection fraction about 25 to 30%, and his lung function were highly compromised, and which showed a severe restriction. So my question again now to Dr. Smita Bhatia would be that if we can, I think we've touched upon, if you could just quickly say, we've touched upon many of these aspects in the previous talks, but then how do we approach for this, the approach, any changes that you would have done? Then regarding the dose equivalence calculation, the doxorubicin equivalence, because these seem to change with time and some residents are here. So these are likely to change, even have changed from the 2018 to 23 guidelines. And in resource constraint setting, if echocardiography is not available, do we have any surrogate for that? And again, pregnancy is a risk factor where we need added surveillance. And again, role of genetics, which if you can just dwell on it quickly.
So I'll start with the fact that these guidelines for the cumulative anthracycline dose calculation has indeed changed. And the change is primarily to account for mitoxantrone. And so if you go back, you will take a look at the, I'm talking to to RDM fellows now. You will go back and you will find exactly what the changes are. And essentially what we are trying to do is to level the playing field in terms of what is the equivalent cardiotoxic dose for each of those anthracycline classes of drugs. In a resource-constrained setting, how can surveillance be implemented if echo is not readily available? We need to go back to the times when we could do a good physical exam and be able to detect a particular, make a diagnosis. I remember going to the TB hospital and being able to find out an abscess on just auscultation. Need to go back to doing that. And that should be able to help us. What are the other cardiovascular risk factors? The other cardiovascular risk factors are diabetes, hypertension, dyslipidemia. Occasionally, obesity is also considered part of that, and smoking. And of these, hypertension and diabetes are the primary factors which, when combined with anthracyclines, really increases the risk of cardiomyopathy. So those are the factors that one needs to watch out for aggressively and manage them appropriately. Now, in management of pregnant females, any times we have high-dose anthracycline exposure in a pregnant female, we refer them to the high-risk clinic. So having continuous obstetrics evaluation would be a good thing in this group of people. And Dr. Kurkure is saying, hurry up and finish, because I'm done. And genetics are a work in progress. Sorry. Genetics are a work in progress.
Yes, so.
Cannot hear? Here. My hope is that in my lifetime, we'll be able to have a blood test that tells us exactly what the risk is for a patient.
So actually, these questions were made before hearing to the the talks. They've partly covered quite a lot of the issues that we are discussing right now. So, Dr.
Can I just
Dr.
add?
Rashmi.
So, I did what Smita said about, if you don't have echo, you look at the, clinical features of cardiac failure that we traditionally look at. But if we want to really intervene and pick up, I think in today's times, 2D echo, even in 2-tier and 3-tier cities, is available. You may not have, 3D echo or echo giving you myocardial strain and all those, other patterns. But because many of our residents, they don't do ECG at all, like echo is, So whether we should be pushing for an echo,
We should definitely push for an echo if we can. And then the other thing is the handheld echocardiograms. If we can have a point of contact ultrasound or an echocardiogram that can be performed, there's nothing like it. And those aren't very expensive.
Because that's the only way you'll pick them up early to have some intervention.
Agreed.
Absolutely.
Completely.
There's a lot of subjectivity to it, but then definitely it is it is
It
a
is
mandatory,
subjective.
mandatory requirement. Absolutely. So anything, Dr. Rashmi, would want to comment on the pulmonary aspect? Otherwise, we could just go ahead. So the child does have a severe restrictive pattern in the pulmonary function test.
Yeah, this child has everything
possible.
Possible means surgery, radiation, chemotherapy. So he is at a very high risk for pulmonary toxicity, and he should be followed up clinically and investigationally for lung toxicity. And so your clinical features of, signs and symptoms of whether it is restrictive lung disease or obstruction, wheezing, cough, etc. On symptoms, clinical examination. The same should be conveyed to, if you are doing shared care, to the primary physician also to monitor clinically. Apart from that, X-ray chest, pulmonary function tests to be done, both spirometry and diffusion studies to be done. Also, if there is any role of chest physiotherapy, that could be incorporated. And whether if there is any infection or asthma, they should be treated very vigorously and actively. And perhaps flu vaccine and pneumococcal vaccines also.
So these are given, and of course some counseling on healthy lifestyle.
Healthy, and of course no smoking, counseling regarding smoking and health.
Okay.
Yoga, yes, breathing, yeah.
Okay, so this seems to be totally messed up. So I'll just quickly speak the third case. So this was a 12-year-old female child was diagnosed with bilateral retinoblastoma in 2011 at the age of 3 months. Right eye was group E, left eye was group B, and the child was enucleated with no high-risk features and had received 6 cycles of CV long ago. Parents had declined genetic testing for the same. Unfortunately, 10 years down the line, the child had a relapse, and possibility of retinoblastoma versus osteosarcoma relapses were kept, but then ultimately, I think looks too jumbled up, but it was picked up to be a retinoblastoma relapse. So this child was treated with high-dose chemotherapy followed by autologous stem cell transplantation, and thiotepa was used as a conditioning regime. This child was in remission for 14 months, but then unfortunately relapsed. This actually case was even discussed in our virtual tumor board. But leave aside the second relapse, even in the first, the child was ultimately treated with radiation and is now doing well post 18 months of the second relapse. But my questions pertain to the first one, that the exposures have been, of course, besides the processes the child had, impaired vision, the disability, the concerns of hearing deficit, second neoplasm, reproductive dysfunction, etc. And these have been the exposures, the drugs that we have given her, besides cyclophosphamide, carboplatin, etoposide, adria, thiotepa, and the local radiation and the enucleation. Focus here is on the fertility concern. So the child, otherwise the very bright child going to school, has a enucleated eye, but the other eye has good vision. Growth parameters are normal. But while we are evaluating her, now that she's 14.5 years, menarche has not been attained. Serial ultrasound shows uterus to be pubertal, volumes of the ovaries are declining, follicle counts are decreasing, and this is the hormone profile that the child has, and this has been tested on 3 separate occasions. So now my questions will be to Dr. Rashmi and to Dr. Purna. I think part of it Dr. Puneet has already covered, but then Dr. Rashmi, would you want to tell how you would approach this child? And of course, Madam, we'll just discuss the options that are available for fertility preservation.
So, basically, the approach for this child would be to monitor puberty, I mean, which you have already done. As I understand, there's no menarche, but the other
Physically, yeah. Some thelarchy has
some
started.
thelarchy is there.
Started, yeah.
And you've done the hormonal profile also, which is what one would do. And you've done a ultrasound also. Both are suggestive of, prepubertal stage, but with high LH and FSH, with very low estradiol and so and AMH, so which suggests low follicular count. Definitely this child will need some
hormone replacement therapy.
Hormone replacement therapy, and and some other, if these facilities are available, then either oocyte or ovarian tissue preservation. Some options one may have to look at.
Oh, but now it's not almost, that is not a feasible option.
Yeah, it is
now.
not a feasible.
Follicle counts, it's just,
and she's just 15 years old,
and
you can't even do anything else. So only hormone replacement is
therapy that is being done for her.
You will require a hormone replacement therapy for her to develop normally external secondary sexual characters and psychologically cyclical hormonal therapy to have the withdrawal bleeding so as to have the like what you can say to feel the normalcy and womanhood. That is the most important part for this girl at this moment. Definitely with the the ovarian failure being set up so early, she will need assisted reproductive efforts when she gets married, and it has to be disclosed very honestly to the prospective
Family.
partner. That is the most important part of the whole story, because this girl, if they don't disclose this, she will have lots of issues and mistrust with the prospective partner. So this needs to be told and grilled into the minds of the parents, because they are the one who will push her for marriage without revealing the facts. So that needs to be avoided.
So I think I'll just wind up. I'll skip the last case. So just 2 more minutes, I think, Dr. Maya. Can we just take 2, 3 minutes towards the last end? So Dr. Savita, so now skip one of the interesting cases also where the one RV patient, actually survivor, had osteosarcoma. But then knowing all these 3, 4 cases with multiple stressors, adolescent children, how would you tackle these? And then of course, when do we need that? How do we decide the need for special education, vocational training, and input? When does the psychiatry person come into? So it is a psychologist, and then when do we decide that a psychiatric uh, personnel is required or consults are required? You can just quickly, deal with this.
Thank you. Thank you very much. I think, all these cases, these children are constantly busy with their late effect management. And even if with a moderate risk, when children are coming to the hospital, they are perceiving the whole experience. If you look at from the patient's point of view or survivor's point of view, it is totally different many times. And even their situation is independent. So it is important to know how they are perceiving, what they are thinking, what are their stresses, how those stresses are impacting their life, and how they are reacting. So that's why we need to spend a lot of time, and that we are doing. Then there is a lot of grief if there are losses, like we are seeing there are so many body losses, there are so many functional losses. So there is a lot of grief associated with that. So understanding that, giving more opportunity to talk about it, how to accept. So evidence-based therapies are there. We have heard many times about cognitive behavior therapy. So it helps them to accept their life situation to some extent, and even we can introduce a coping strategies which can help them to cope with the situations. And this will need constant work with them, constant work with the families, and acceptance and commitment to the situation. So all these therapeutic techniques will definitely help them to accept this. And as you said, when the psychiatric interventions will coming, whenever there are issues like depression, anxiety, which are actually interfering their day-to-day life situation, and they're not able to manage, they definitely have to send to the psychiatrist, or psychopharmacological interventions will be required. If suppose somebody is having depressed mood but at the same time having hypothyroidism, then we cannot ignore and we cannot wait ke dekhte hain next time. We really have to proactively do something about it and have aggressive interventions for that. And also there will be some organic issues, like due to some reasons, or even for this, because of this cognitive and all the sequelae, they will have sudden onset of psychosis, or if there is any past history of psychosis during the treatment, then any behavioral changes, we cannot ignore that. Even that time they have to be referred to the psychiatrist. Suicidal attempts, suicidal ideation, helplessness, worthlessness, all these symptoms are really, really important to address as early as possible. And we cannot just say that hota hai, no, it is their difficult life, difficult situation. No, we have to do something proactively at that time. And educational, vocational interventions, I feel As and when the child completes the treatment,
it has to go hand in
that
hand.
early integration should be, considered, and parents should be motivated, because the apprehensions is more about parents. They are worried that how child will cope, how people will treat, and reforming social situation, which is many times out of our control. But if we can do, like we are doing awareness campaigns, speaking to teachers, speaking to friends and peers, I think those interventions are equally important to deal with their, to some extent, to their life situation. Otherwise, their experience is totally their experience. We just cannot imagine many times about it.
I would just like to add, Dr. Rachna, to these. One is the support group. So what we have observed in UGAM is that since 2009, there are about now 500 plus members. And the stressors are kind of, when there are UGAM meetings, on whenever there are events, that is the time when they actually bond with each other and they share these stressors. And we have actually observed that people, I mean, the survivors who were really very shy couldn't open up. But when they were given opportunities in these school platforms, they actually open up and share their success stories. So that's one. And secondly, as a part of Picasso, what we do is there are low, moderate, and severe kind of stressors that the psychologists identify. And then, like how there is a medical grade for late effects. For psychologists also, if there are red flag signs, apart from referring to a psychiatrist or that hospital psychology unit, they will also constantly, like the frequency of follow up increases. So it is not that once the child goes back, the usually he or she comes back to the ACT clinic after a year or 2 years based on the risk stratification. But here, what we do is proactively the frequency of follow-up increases to see whether the stressors are reduced.
Expertise
And also you need to have
psychiatrist is
some.
in the part of psycho-oncology team and the survivorship team, so that is easier, easily they can be referred and they can be seen, and which is then non-offending also for them.
Okay, so to just summarize, I think I'll just repeat the summary points. Is survivorship again has attracted attention, but we need to have, and there's a lot of momentum in India as well. And because it translates into decades of life for every child, and there are increasing number of childhood cancer survivors, late effects are a concern. And again, risk-based care is important. And we still need to have the answer of the profile, whether our profile of patients are different from what we see in the Western cohort. So with this, thank you very much, and thanks to all the panelists for this. No, I've skipped and gone very fast.
Thank you, everyone. This wraps up one full day of a lot of conversation about childhood cancer survivorship, addressing many aspects of childhood cancer survivorship, which include all the new developments which we are seeing, and also the need for the guidelines and how to make them universally, acceptable for all the physicians and care providers to implement them. So we request all of you to join for the hospital day dinner, which would be at Taj Lands End in some time. So there are the transportation can be made available. You can reach out to the travel desk. Tomorrow we'll be starting our sessions at 8:30 a.m. This would be on translating evidence into practice and advances in diagnostic and therapeutics. See you all tomorrow. Thank you.